not making. Let me ask you some questions. You are said about the age. You think the age is relevant in any way to diagnosis? In her age,
So you should have
50s and
included.
60s, what do
Patient
you
has
think
no
will be the
complaints
common
with
shoulder
neck pain,
problem?
no
Frozen
complaints
shoulder.
of abdominal
Frozen
pain,
shoulder.
Okay,
something
degenerative
to let
joint
the
disease or
examiner know that you
other
know this.
degenerative lesion.
Let me
Degenerative
ask you
rotator
some
cuff
questions.
tear.
You are
These are the
said
common
about the
problems
age.
at
You
that
think
age.
the age
You
is
won't think of
relevant in any
instability
way
in
to
this age.
diagnosis?
Normal. Anything can happen.
In
They are
her
not,
age,
thing. So
at
like
50s
that,
and 60s,
every
what do you
point
think will
of
be
view,
the
what you
common
say,
shoulder problem?
you should have an idea of
Frozen
that.
shoulder.
Okay, degenerative joint disease.
You said
or
one more thing,
other
that
degenerative
she
lesions.
was not able to lie down on the
Degenerative
left side
rotator
or
cuff
right
tear.
side.
These
something
are the
mentioned.
common problems in that age. You won't think of instability in this age.
What's the
Normal.
importance of
Anything
that?
can happen. They are not thing. So like
Because
that,
you are having a
every
right
point
shoulder
of
pain.
view, what you
So,
say,
like-
Yeah,
you should
that-
have
see
an
the
idea of
thing
that.
is one of the
You said
of the
one more
base in
thing
the history
that she
where
was
you
not
know
able to lie
that
down on
the
the left side
shoulder
or right
joint
side
is
of the
irritable.
What
I'm just
does-
telling you,
what
whatever
does
be the
that
pathology
help
can
you
be,
to know?
this patient
What is the
cannot
importance of
lie
that?
down on that side. If it is a
Because you are having a
problem
right
from
shoulder
elsewhere,
pain.
she'll
So
be
like
comfortably
that- see
sleeping
the
on that side. That
thing is one of
another
the
part you
one of the base in the
And,
history
third thing I
where
want to
you
ask you
know
was, you
that
said
the
pain is
shoulder
referred
joint
to,
is irritable. I'm just telling you, whatever be the
elbow
pathology
and
can
hand,
be,
something
this
like
patient
that.
cannot
Okay,
lie down.
where
on
do
that.
you feel? What is the
If it is
common?
a
Commonly the
problem
patient
from
comes with
elsewhere,
pain where?
she'll be comfortably
shoulder
sleeping.
problem.
Say that is another
Do
part
they
you
come
know.
with shoulder pain or
And
shoulder
third
pain
thing
or
I want
will
to
it
ask
be
you
more
was,
specific?
you said pain
If you
is
take
referred to
100% of shoulder problem,
elbow and hand, something like this.
my knowledge
Okay,
is
where do you feel?
MBBS
What is the
and MS
common?
knowledge.
Commonly the
correct
patient
me,
comes with pain
orthoscopy
where?
knowledge I don't
In
know.
a shoulder
I don't have.
problem.
I don't even see it.
Do they come with shoulder pain or shoulder pain
No,
or
no.
will it be more
I prefer
specific?
big things,
If
small,
you take
small things.
100% of shoulder
So,
problem,
the 60% of the things. all
my
this,
knowledge is
we also know
MBBS and MS.
patient pain comes
So
with
correct
the
me. Orthoscopy
deltoid
knowledge I don't know. I
deltoid
don't have.
insertion area.
I don't even
That
see it.
is the commonest thing. If this patient, if
No,
this
no.
lady tells us
prefer
pain
big
is
things, small,
even
small
up to
things.
the hand, it
So,
doesn't go below the
60% of the things.
What does that mean? What is the importance of that? That's very important.
Patient pain comes with the deltoid area.
See,
Deltoid
see,
insertion area.
You know,
That
you
is
can
the
open
common.
and see like that.
If this patient, if this lady
we
tells
do
us
not
pain
know,
is
we have to
even
know
up to
more
the
about
hand,
the history.
it doesn't go below
Can
the
you tell me, anybody from the audience,
does that
postgraduates can tell me,
What is the
what is the
importance
relevance
of
of
that?
that?
It's very
If the pain radiates to the shoulder, to the elbow or to the hand.
If you know, if you can open and
Below,
see
go
like that,
beyond the radio style.
see
This is
no
all
problem.
given in the book. Huh?
we do not
Nothing
know,
is original.
we have to
All
know
are only
more about the
copies. It
Can
indicates
you tell me, anybody
that
from the
severity
audience,
of it.
postgraduates can tell me,
More
what
severe
is the
the
relevance
lesion,
of that?
the pain is
If the pain radiates to the shoulder, to the elbow or to the hand.
So small points like
Below,
that
go
help
beyond
you
the
a
radio
lot.
style. This is all given in the book. Huh?
No
Nothing is original.
investigation
All
is
are
above a
only
clinical
copies.
examination. Please remember.
It indicates that.
So
the
from what
severity
you said, what do you think
more
from the
severe the
history
lesion,
is
the pain is
a short case. So whatever you said, so many things you have said, so many you are not said.
help you a
I
lot.
didn't hear about pain in the
No
diurnal
investigation
variation.
is above a
If
clinical
you have said that, in
Please
my
remember.
days, if I had pain in the shoulder,
from what you
first thing in
said,
our mind
what
was
do you think from
tuberculosis
the
shoulder.
history
Those days,
is
that was 50
is a
years
short
back.
case. So
55
well,
years
whatever
back
you
when
said,
I
so many
did my
things you have said, so
postgraduation.
many you are not,
So that is different.
not said.
But today,
I didn't
other
hear
things
about
are
pain
there.
in the
With
diurnal
whatever
variation.
you have told, what do
If
you
you have
think?
said that,
What kind?
in
I
my
know
days, if I had
shoulder
pain in the
problems
shoulder,
you will group
first thing
into
in our mind
what?
was tuberculosis shoulder. Those days, that was 50
1,
years
2,
back.
3 like that.
55
Either
years
it
back
be
when I
instability
did my postgraduation.
or it could
So
be
that is different.
degenerative.
But today,
Or
other things are
what is
there.
third one?
With whatever you
Inflammatory
have told, what do you
pathologies. Where
think?
do you think?
What kind? I don't. Shoulder problems you will group
From
into
whatever you said.
1, 2,
I
3
mean,
like
you
that.
find it difficult.
Either it be
correct me.
instability
Degenerative.
or it could be
Degenerative
degenerative or
No, based on the pain,
What
can
is
you
third
tell
one?
where the problem
inflammatory
is coming from?
pathology.
Site of
Where do you
pain.
think?
It's from the shoulder only, sir.
Say
From
the
whatever
pain.
you said.
Good answer. But from
I mean,
The
you
exam,
find it
don't
difficult.
irritate the examiner, okay? We are discussing
Degenerative
shoulder case, so it
causes.
is shoulder problem only.
No, based
But
on the
apart
pain,
from
can
that,
you
where
tell
the pain is coming from, where the site of pathology is, the examiner would
It's
want to
from the
know.
shoulder only,
So you
sir.
have to tell that.
Say the pain.
Suppose the pain is on the
Good
top of the
answer.
shoulder, where is the problem?
In the exam, don't irritate the examiner,
I'm
okay?
giving you leading questions.
We are
and leading
discussing
answers.
shoulder case, so it is shoulder problem only.
Acromion, sir.
Acromion
But
top
apart
of the
from that,
shoulder.
where the
Back
pain
of
is
the shoulder,
coming from,
where is the
where the
problem?
site of pathology is, the examiner would want to
Spine,
know. So you have to tell that.
Acromion, soft spot swelling.
Suppose the
Back
pain is
of
on
the
the top of the
shoulder,
shoulder,
where is the problem? Anybody else from the audience also can tell.
Acromion.
I am giving you leading questions. And leading
Patient is
answers.
not sure, but he will point to the back of the shoulder.
Acromion
Where should
top
be
of
the
the
problem?
Back of the shoulder, where is the problem?
Spine.
Nerve entrapment,
angle of
common
the acromion,
things.
soft spot swelling will be.
Back of the shoulder, where is the problem? Anybody else from the
Software
audience
engineers
also can
generally
tell.
come to you with that problem.
Patient is not sure, but he
Trapezius
will point to the
fibrofasciitis,
back of the shoulder.
very
Where
common.
should be the problem?
Okay. Common things first. Slap lesions, when they are not sure
Nerve
where the pain
entrapment,
is, they
common
generally
things.
point to the back. Arm of the shoulder, what is the cause?
Delta.
Software engineers generally come to you with that problem.
Here,
Trapezius fibrofasciitis, very common. Okay?
we are
Common things
discussing
first.
that case, so that is the problem.
Slap
Cuff case.
lesions, when they are not sure where the pain is, they will generally point to
Where
the
is the
back.
problem?
Arm of the shoulder, what is the cause?
Biceps tendinitis,
Delta.
good. If it is below the elbow, then where the problem is coming from?
Here.
You said it in the beginning, you
We are
examined
discussing
already.
that case, so that is the
In the
problem.
history
Cuff
you are
test.
told pain is not
Supraspinatus
irritating.
If it is in the arm, where is the problem? Arm.
Cervical tendinitis.
Yes. So
Biceps
these are the
tendinitis,
5 things
good.
that you should know.
If it is below the elbow, then where
Okay.
the problem is coming
Top
from?
of the shoulder, back of the shoulder, arm of the shoulder,
You said it in the beginning,
then
you
the
examined
deltoid
already.
region and below
In the
the
history
elbow.
you are told
So these
pain
are the
is not
things you should
radiating.
know, and then we move on from there. Because it is a short case,
Cervical
we
spine.
need to move on.
Yeah.
All right?
These are the
One
5
more
things that
thing
you
I
should
want
know.
to say in this. Please remember,
Top of the
it is
shoulder,
very
back of
difficult
the
for the
shoulder,
patient to
arm of the
exactly
shoulder.
localize. Ask him where the pain is.
Then
It is
the
difficult for
deltoid
him.
region
Can you
and
tell me
below
why?
the elbow.
Whereas if
So
it is
these are the things you should know, and
acromioclavicular
then we
joint
move on from
problem,
there.
he will
Because it is a short case,
specifically tell.
we
So
need
when
to
is
move
it
on.
easy
All
for
right?
the
There's
patient
one more
to
thing I
localize?
want to say in
What is
this.
the difference between
Please remember,
acromioclavicular
it
joint,
is very
IOA,
difficult for the
EC, and
patient to
shoulder
exactly
deficiency? Anybody from the
localize. Ask him
audience?
where the pain is.
He will curse
It is
me if I
difficult for
ask him more.
Can you tell me why?
Anybody from the
Whereas
audience?
if it is
Shoulder
acromioclavicular
is
joint
dermato-
problem, he
see,
will
acromioclavicular.
So when is
see,
it easy for the
shoulder
patient?
is a
to localize?
huge area.
What's the
It
difference
is in the
between a
border of the
acromioclavicular joint? Why do I say
where
easy
the
and
C4
shoulder
ends.
difficult?
C4
Anybody
ends
from
in
the audience?
acromioclavicular.
He will curse me
Shoulder
if I
begins
ask him more.
after that. It is the
Anybody from the
periphery.
audience?
He cannot locate it.
Shoulder is
Shoulder
which
is more
dermato?
deep-seated compared to
See,
acromioclavicular.
acromioclavicular
Acromioclavicular is in the
shoulder
dot of
is a huge area.
will easily
It is in the
localize.
border
It is more
of the
superficial. So,
where the
according
C4
to
ends.
situation,
C4 ends
where
in
the
the
person is,
acromioclavicular.
even if
Shoulder begins
acromioclavicular
after
was
that.
deep,
It is the
still
periphery.
it is
He
in the
cannot
heart
locate
of
it.
the
Shoulder
center
is
of the
more
C4
deep-seated
neurons.
compared to
So,
acromioclavicular.
these are some of the things where
Acromioclavicular
you should
is the
understand.
dot of
Otherwise,
C4.
it will
He
be
will easily
difficult to
localize.
know.
It is more superficial.
Sometimes, like
So,
so many
according to
problems will be there.
situation,
Yes, we are taking
where the
time to
person
come
is
to
taking,
examine.
even if acromioclavicular
So
was
the
deep,
inference from this, what
still
is the
it is in
inference
the
you got?
heart of the center of the C4
Rajkumar.
neurons. So these are some of the things where you should
What it
understand.
signifies? What is the inference you got now? Say the history.
And we have told you where the site of pain is arising from. What do you think the patient has got? Tentative diagnosis from the history.
Instability, shoulder and DG.
Is it instability? Yes or no? Is it instability of the shoulder? You have heard the history. Is it instability? Did the patient have such a trauma to have instability? No. Correct? Patient has got only a decompensated shoulder where the pain is not allowing her to do her activities of daily living, not allowing her to sleep on that same side. Correct? If say patient was a shuttle player or a weight lifter and all, it would have been difficulty to lift the weight and keep it on the shelf. Or if it is a cricket player, the first ball he can bowl with full force, fourth and fifth ball the power in the throw is less. So these are the kind of history you should know from what kind of patient you are dealing with. Simple, eh? Definitely it is not dislocation in this case. So don't make blunders like this. Not required in the exam. Please proceed with the examination.
Also, I'll add that in her age, instability is very unlikely to be the common problem. Examination. Examination.
On examination, local examination, general physical examination, no pallor, no icterus, no cyanosis.
Come to local examination.
Okay.
Straight away.
I think you should have given him breakfast first. Louder.
Yes, local examination of the right shoulder. The patient was examined in sitting, standing, and supine position. On inspection,
Questions will be always for the backbenchers.
on inspection, the shoulder is neutral, and elbow is also neutral in position, and arm is neutral, and upper limb, the right upper limb is in supination, and there's no swelling present over the right shoulder, and there's no
I think that is not acceptable to me, at least, even if it's the. Your first thing about shoulder will be the symmetry of the shoulder. I mean, I know there are problems in exposing, otherwise, is there a history of muscle, is there a squaring of shoulder? I mean, the first thing you notice is that, then the level of the shoulder. That strikes, and that strikes your eye, number one, and you haven't even mentioned it so far.
See, when you start presenting in the exam, try to impress the examiner with the positive findings. Okay? It is like you are going to see a girl for a proposal. You cannot say all the negative things that you want to say about yourself. Right? Yes or no? Huh? How many of you are married here in the public? Yeah? So do you say negative things about yourself in the beginning? So tell the positive findings. You get 2 minutes to impress her. So that is the thing that you have to do in the exam as well. Okay? Don't beat around the bush. Not required. Examination findings, please, doctor.
Bilateral shoulders are at the same level, sir.
Yes.
And there's no any limb length discrepancy.
Okay, go on. I will not stop you. Go on.
There's no swelling over the shoulder joint, and there's all.
In a short case, unlike a long case, you don't have to tell all the negative points. What are very, very important? Something very important to your diagnosis or management file. No swelling, no that already as mentioned twice. Carry on. If you don't have anything else in inspection, then go to the next one. If you don't have, I don't know whether there is. Yes, we go to palpation.
On palpation, there's no rise of temperature. Tenderness present over the acromion, and tenderness present over on the anterior aspect of the acromion.
So we have 10 minutes now. You want to finish your examination? Yes or no? Jaldi, jaldi. See, in 10 minutes you have to come to diagnosis. So tell me your positive findings on examination. Quick. Scapulas are moving symmetrically, yes or no?
Yes, sir.
Demonstrate. Quick.
Sister.
ನಿಂತ್ಕೊಳ್ಳಿ ಸಿಸ್ಟರ್. ಆ ಸೀರೆ ಹೆಂಗೆ ಹಾಕೊಳ್ಳಿ, ಸೊಂಟದಲ್ಲಿ ಹಾಕೊಳ್ಳಿ, ಹಾಕೊಳ್ಳಿ ಇಲ್ಲಿ. How will you see if the scapula is moving symmetrically? Please demonstrate.
So we go along, press the shoulder.
was the one.
Okay, anybody knows how to demonstrate symmetrical movements of scapula? Anybody here in the front? No? Anybody here in the public would like to show how to demonstrate symmetrical movements of scapula? Okay, sister. Okay, right. Go on. Go on. Go on. Normal hand you lift. Okay? That's all you have to do. You have to see that both the shoulders are not moving symmetrical. Even if it is moving symmetrical in an young individual who can move the shoulder, you should see whether they are moving in unison or not, or if there is any dyskinetic movement of the shoulder. That's all. Nothing more is required. In this lady, because of the pain in the shoulder, she is not able to lift the hand. That's all it is. Okay? So there is something that is happening that is not allowing her to lift the shoulder. That is the impression. Finished. How do you rule out if the pain is coming from the neck? One test.
Spurling sign.
How will you do? Demonstrate. Quick.
Sit on. Detail.
What you are doing? The mic is on. Explain.
Make the patient sit and turn to the affected side of the joint. Give a downward flexion to the pain. If the pain radiates from the neck to the till the elbow level, Spurling sign is positive.
Okay, demonstrate.
Just turn to the. Yep.
What you do with the hand?
Sir?
Don't break her neck. What you want to do with the hand? Okay, twist the neck to the side of the pain. Lift the hand. It's like doing a straight leg raising test. If the pain is coming below the elbow, then definitely pain is from the cervical spine or from the trapezius fibrophaciitis. Right? If it is not radiating below the elbow, then the pain is localized to the shoulder. That is the impression. Okay? Correct? Yeah. Tell me if the biceps is involved in this lady. What test you will do?
Speed test we do.
Demonstrate.
Raise the hand straight.
So what you are looking for?
We look for the biceps. We look for forward flexion of the.
Are you able to hear what this speaker is telling? Is it clear? You have to speak little louder, doctor. Okay? Tell.
So we make the patient lift the upper limb against the resistance. You feel the tendonitis. She will have tenderness over the biceps limb. Insertion in the limb.
One is you look for the tender spot in the shoulder. Second is you demonstrate by a test like this. Any other test you know for the biceps problem apart from speed test?
Egerson test is there.
Other than that, any other test for biceps pathology that you want to know or you know of? Starting from letter O.
O'Brien's.
How will you do that?
So make the keep your thumbs up like this. Hold like this, sister. Make the
shoulder is adducted or abducted?
The
Or flexed or adducted?
It's abducted, sir. And you have to make sure the patient goes against the resistance. This position. And she has to, with resistance, she has to turn thumbs up. So like if she's having.
That is O'Brien's test, or that is some other test that you are telling us?
The Job's test.
You adduct the shoulder in this fashion. Okay, apply pressure and look for pain in the shoulder. If she is having pain, then do it in this position, supine. The pain should be less in this position. Then the test is positive. Having said that, there is no single test that is positive for a biceps pathology. That much you should know. In the exam, speed test and O'Brien's you have to do. Ergason not required to do in the exam. All right? How do you test the cuff? Infraspinatus, how do you test?
Keep external rotate system.
Always for shoulder, God has given you 2 arms, 2 hands. That is for comparison. It is easy to compare and then tell the other side is pathologic. If we are doing or if we are found doing only on the pathological side, I am sure the examiner will mark you down. Okay, try to compare it with the normal side. Always try to demonstrate it on the normal side. That is the norm in the exam. Okay, please do it on both sides.
Just keep your hand and push it outside, sister. Push the hand outside.
What you are trying to do? Infraspinatus is an abductor of the shoulder or a rotator of the shoulder.
External rotator.
So where will be your arm or the hand?
Towards the sides of the arm.
You are blocking rotations, doctor. So where will you put your hand?
In the elbow, sir.
Put there, how will you turn the rotation? You can only adduct it that way.
Yep. In the arm, sir.
You want her not to do this, correct? So where will be your force that is preventing her to rotate?
Forearm.
Yeah, so put your hand there. Still in the front, some more in the front. Yeah, okay. Sister, rotate this way. Okay? You can see that on the right side the internal rotation, external rotation is limited. But if you want to know, it is also involving the teres minor. What will you do?
We abduct the shoulder.
And
Sir,
external rotation in this fashion. Please do. Both sides.
Sister, we'll abduct and next do arms.
That is from physics.
Like this.
So whatever test he is doing, definitely the examiner is going to mark him down. Okay? You are supposed to test external rotation in this fashion. You are not supposed to find out whether the lady has developed her biceps well. You are not supposed to do that in the exam, correct? Look for abduction, external rotation. That is for teres minor. Okay? How do you test subscapularis?
Belly press test is
Demonstrate.
just keep it. And we look in the when we look at the from the sides, we have to look at they are at the same level this angle, and there should not be a 45.
You demonstrate on yourself belly press. Is that correct? Is that correct? Doctor is demonstrating belly press for subscapularis. Is that correct? Okay, don't interlock your finger when you are doing belly press because the other shoulder can compensate for the movement. So your hand should be apart like this. Okay? And then you try to do this. And look for the elbow point that is coming from the midline. Stand on the side and see where the elbow is pointing. So plus or minus is based on where the elbow lags behind. Okay? Correct? Yeah. If you want to know if the upper subscapularis is involved, what will you do?
Here a test we do.
How will you do that?
Sister, keep your hand and push down. We make the patient flex the elbow and touch the opposite shoulder so that to give a downward resistance here. We give resistance to the downward push she gives. So if she's giving resistance pain, she has pain, it's supposed to, it
What will
corresponds.
be the patient's neck turned to? Which side you want to turn the patient's neck? Same side or opposite side? This is common sense. You are lifting the hand up like this. Imagine your force is more than what the patient is doing. You will hit her chin like that. Okay, turn the patient's neck to the other side and then try to lift the shoulder. How will you demonstrate supraspinatus problem?
30-degree abduction, we 30-degree abduction. Keep your thumbs up, sister. And make the patient to lift the 30-degree abduction. Make the patient to lift the arm against the resistance. If she's having initial pain, like corresponds to supraspinatus, and if she's having not able to withstand the whole time, it corresponds to deltoid insufficiency.
Deltoid insufficiency. Okay, supraspinatus is involved in the first 30 degrees of abduction or About 30 degrees.
About 30, sir. 0 to 30 is
What's your diagnosis?
She's having subacromial,
Nothing what you said is being heard in the last rows. This is meant for them, not for us. Talk louder.
she's having a supraspinatus tear with biceps tendinitis and suspect subacromial plus or minus subacromial bursitis.
Sorry, what is the last thing you said?
Subacromial bursitis.
Subacromial bursitis. They put all the problems possible.
Patient has got infraspinatus weakness. Patient has got supraspinatus weakness. Her speed test is positive. So limit your diagnosis to that. Subacromial bursitis is very difficult to diagnose. All right. So you say it is a cuff tear with this problem with biceps tendinitis. Correct? Now what you want to do for this patient?
X-rays and followed with MRI we have to take, sir. And
X-ray, MRI and ultrasound. Okay? So all these things you have to do from the beginning. What you would like to see in the X-ray? What you would like to see in the X-ray? You have seen the X-ray. If there is a cuff tear, what you will see on the X-ray?
sir,
Don't take X-ray just for increasing the revenue of your hospital. Okay? Not required.
any subacromial sclerosis or osteoarthritic changes we can see.
What is sourcil sign?
That subacromial sclerosis we can see. That is called
Sclerosis of the
acromion.
acromion. So that is an indirect sign to say that there is a cuff tear. Possible. Okay? No, sir. Any other sign you would like to see on the greater tuberosity?
Hill-Sachs.
Hill-Sachs sign. Gentlemen, we are discussing cuff tear. Sclerosis of the GT is another secondary sign to say that there is a possible cuff tear. Any other sign to say that there would be a cuff tear? In a massive cuff tear, generally it will be seen, but not in this X-ray. What is Roman arch?
It's from the border of the scapula, lateral border of the scapula to the shoulder, glenoid labrum, and along the medial border of the shoulder. That
Will form a symmetrical arch. If it is disrupted, what does it mean to you?
Rotator cuff tear.
Massive cuff tear where the shoulder migrates proximally. Correct. So X-ray is done. Any other investigation you would want to do?
Ultrasound. Sir.
Ultrasound is done. Okay, it is not available here. So any other investigation? MRI would like to do?
Yes, sir.
MRI is available? किधर है? Stop. Okay. Quick. What is the muscle that you are seeing on the scan? And what is the problem?
Supraspinatus tear is there, sir. And
where is the tear? Who has got the pointer? Aditi. It is an articular side tear or a bursal side tear?
so look at the bursal. Articular.
It is an articular side tear, okay, of the supraspinatus. What you want to do?
Arthroscopic.
What do you do?
What you want to do for an articular side tear?
what can you improve? We'll stop it. The last question, and we are going to next. What will do? What will be the normal listing?
So,
You have a patient. Assume that she has not taken any treatment so far. What will be your line of management?
first we start with physiotherapy, then the pain. We start with
Okay,
the physiotherapy and local ultrasonic massage and ROM exercises. Like if the pain is improving, pain is subsiding, we'll continue physiotherapy. If the pain is worsening, we'll go for further surgical management.
You not only will.
So to improve her ROM, like she's having
What is short form?
a range of motion should be.
Improve the range of movements.
If her scapula mechanics is improved, much of her pain will be settled. Okay, she is having a protracted shoulder like this. Bring her shoulder back, she will have much eased problem for her and she will be able to sleep well in the night. You prescribe her some medication. So what medications you would like to prescribe? She is not able to sleep, correct?
Yes, sir.
After hard day's labor, she is entitled to sleep well. So what medication you will prescribe?
Pregabalin.
I want to give a pregabalin. What is pregabalin? What he has told you very clearly for the pain. Pregabalin is for pain, but what kind of action is it?
It's a neuropathic pain.
It is centrally active one. But here it's not a neuralgic pain. The pain is mainly all movements here. And there will be, along with any chair, there will be inflammation. What kind of anti-inflammatory? What is
Okay, if the pain doesn't settle down over 3 months, 6 months, what would be your option?
Arthroscopic shoulder repair.
Arthroscopic?
Reconstruction. So
I don't know to do arthroscopy. Any other way of managing it surgically? There is always, remember, open surgeries before arthroscopy. Alright? If you are able to identify in arthroscopy articular side cuff tear, it is great. But if you do an open surgery, it's difficult to recognize a cuff tear if it is articular side. Because you will not see the cuff at all. Correct? So arthroscopic cuff tear, completion of the cuff tear and repair is the option for her if the pain is not settling down. The long lever arm you have to give for the patient, minimum 6 months you have to try physiotherapy. After that is the choice for you to manage her surgically. If the patient agrees. If she doesn't agree, you are then still there with intra-articular steroids, physiotherapy, those things will continue. Okay? Because articular side is a double-edged sword. Sometimes you will get benefit from surgery, sometimes she will be there with you for life with the pain in the shoulder if you don't treat her well. Understood? So clinical signs are very important when you are diagnosing a short case like this. You need straight to come to the test. But 1, 2, 3. Biceps you have to evaluate. Cervical spine you have to evaluate. You have to evaluate all the 3 cuffs. Subscapularis, supraspinatus, infraspinatus, and then come to a diagnosis and tell the proper treatment for that particular patient and age. Okay? Is she right-handed dominant or left-handed dominant?
He has not asked that at all. We leave that there. And just for the graduates who couldn't hear everything, the most important thing is the clinical examination. A relevant history, a good clinical examination. That is the cornerstone for your examination. You make a mistake at that level, it's not pardonable. If you are now making a mistake at the management level, orthoscopic management level, pardonable for me, but not the clinical thing. And the usual problem is that you don't spend time on clinical examination. That's where you going to lag behind. So all the even minutest details he told, where the patient doesn't get hurt by the sudden movement of your palm. Even that has to be thought of. Okay? So we close the session. Thank you. Learn to speak louder. Okay? All right. Thank you.
you.
Session to start off. Let Kevin do the And now we'll have a master class by Dr. Rajkumar on examination of the shoulder joint.
We have 10 minutes. Okay? So within 10 minutes, we need to demonstrate some clinical science for you to pick up and ready. Okay? He's a special humanity for us today. Okay? And everybody has to prepare because he's given us special time. Okay, as you heard the history, she has a right shoulder pain for a couple of days, and she's right-handed dominant, as you have to tell in the exam. Okay, some people can compensate with the other hand and work if you don't know which is dominant and not dominant. So sir said earlier that there is bicep problem now. Okay, when there is a bicep problem, you have to look for Malhotra's point. Abduct your shoulder, externally rotate, look for tenderness in this point here. You can roll your finger under the bicep, on the bicep like this, and look at the face of the patient. Okay, if she complains of pain, yes, there is a possible bicep pathology. Speed test, ergometric test you have to do, okay, in the exam. Okay? You have to ask her to lift in this fashion. Etti mele. Etti. She doesn't like it, correct? If she doesn't like it, there is a problem in the shoulder, right? You have to demonstrate it on the normal side first. Okay? This is one test which you need to do, and also you need to do Canadian Hawking test. Canadian Hawking test you have to do in the last in the exam because it is very, very painful. So what you have to do? Abduct your shoulder in this fashion, in the front of your shoulder, internally rotate in this fashion. If she has pain, there is a probable biceps pathology. That's all it is. It is not significant, it is not specific. Probable sign it is. Okay? If you can see here, this fashion, sister, mettige. See, she's already starting shaking her head, telling that please don't do. So you have to stop. Okay? So that is the positive test. There is another test which is yet to be described in the book called as Dr. Rajkumar's test, which is for biceps pathology. Okay? For that, the prerequisite is shoulder should be moving completely in this fashion. The ligament should not be lax. There should not be any associated cuff tear. So when that is there, keep the hand up like this in this fashion. Sister, ee tara kutkoli. Ee tara. Kutkoli. Okay? Okay? Keep it on the scapula in this fashion. Meaning the shoulder is directly sitting on the glenoid like this. Okay? Sister, mele madike. This fashion. Okay? So an observer will be there in the front, or you have a mirror in front of you. Give a vertical load on the shoulder in this fashion. This hand will stabilize the scapula. Okay? Press the shoulder like this. Look at the face if patient is having pain or not. Patient is not complaining of pain, then you tell, now I am going to give little traction on the shoulder and a jerk. Look for presence of pain or not. Sometimes patient have collapsed in the OPD. It is that kind of pain that will generate. Okay? You just have to tug it in this fashion. That's all. If the patient complains of pain or winces with pain, then the test is positive. Alright? Then, in the same line, you have to do what is called as gauges test. Press the shoulder down to look for any dislocation in the shoulder. Okay? Then apprehension in this fashion. So everything should be done in one go. Then look for ligament laxity. All right? There is no ligament laxity, it is fine for the patient. Okay? Infraspinatus, this fashion. Namaste Madi. Talli nan kai aache. Look where your hand is. It is not here. It should be here. Talli sister. Talli. Okay, you can see that there is weakness on this side. Namaste Madi. Jodsi kaina. Jodsi. Okay, she is not able to do that. Kai ingidire. Munde. Madi. Okay. Sometimes they will try to compensate and cheat you by doing a flexion in the wrist like this. You will feel that it is come in the front. So what you have to do? Press it here. Okay, Madi. Okay. See? She doesn't like it. Yeah? If she doesn't like it, there is a problem. So that you have to go and see when you go inside the joint. Alright? So that is for subscap. Any other test for subscap you know of? Lift off test, okay? This is lift off, okay? Sometimes they will cheat you using your triceps. So that you have to be careful. My preferred test in OPD is belly press, okay? Right? Because you can compare nicely. This is only one side, correct? And then you can get false test if they use triceps, okay? Then supraspinatus, which is in this fashion. Madi sister. Okay. You can see her shoulders are not at the same level. This is protracted, this is behind. Okay. While giving physiotherapy, make sure this goes back. Once she has a better shoulder like this, she will be able to lift it in nice fashion. See? Last test. Lift sister. Okay, so that is the difference. So she has supra, she has infra, and probably this she has a subscap tear with biceps tendinitis. So that will be your diagnosis. Ultrasound, X-ray, and MRI. Right? Thank you so much.
Yeah.
Thank you, sister.
Thank you, sir, for a brief examination on shoulder. Now, I'd like to welcome you all for this IOA PG teaching program conducted by the Department of Orthopaedics at St. John's Medical College. Now, through the years, this has been one of the landmark events and the most sought after teaching programs in the academic calendar. Without much ado, we will move on to the inauguration of the program. I'd like to request our director in charge, who's going to become the director from September, Father Jesudas, to please come on stage. Dr. George D'Souza, our beloved Dean of the Medical College. President of the Karnataka Orthopaedic Association, Professor Edward Nazareth. Bangalore Orthopaedic Society President, Professor K.P. Raju. IOA PG Committee Chairman, Professor Dr. Rajagopal, and ex-HOD of Department of Orthopaedics here. We have KOA Secretary General, Dr. Bharat Raju with us. I'd like to request his presence on stage. BOS Secretary, Dr. B. Ramesh. We request the organizing chairman of this wonderful teaching program, Dr. Mallikarjuna Swamy, to please come on stage. Organizing co-chairman, Dr. Rajkumar Amaravati, to go on stage. Yes, sir. Organizing secretary, Dr. H.P. Rajagopal. And our beloved Chief of Medical Services, Dr. Arvind Kasturi, on stage, please. So it's an honor to have all these dignitaries together, and I request all the delegates to make full use of this teaching program. All right? Yeah. Okay. Now I'd request all the delegates to kindly inaugurate the program by lighting the lamp.
शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते
Thank you all. Now I'd like to request the head of department at St. John's, Dr. Mallikarjuna Swamy, and the organizing chairman to address the gathering.
Good morning to everybody. It's one of the most auspicious day for our department, as per the institution also. Consecutively, we are running the IOA program in our institution. And this time we are add on our late Professor K.T. Thomas, one of the icon teacher for us in the region of our country. He's no more, and after this function, I think the oration will be given by our Professor Malhotra sir, all the way has come from Delhi. First of all, I thank all the dignitaries on the dais, our Father Yesudas, direct designated, most welcome Father, our beloved Dean George D'Souza, thank you sir, and our KO President Edward Nazras sir, and our BOS President my friend Raju, and IOA PG Committee Chairman Professor Rajagopal, our mentor always, our past HOD, and our Chief of Medical Services Dr. Arvind Kasturi. He is always encouraging us to do all this program. My friend brother Rajkumar and Rajagopal and the people of the dais, all the faculties, all the way I come from Professor Ashwini Kumar Singh, our past president, and sir has come all the way from Jammu, Rajesh, and Sridhar sir, my beloved teacher Putti sir, Prakashappa sir, and Ramesh Krishna, our dean from Bangalore Medical College, previous HOD, our my close friend Ramesh Helje, our OSS president Sir Srinivasa Garu, and Anil Bhatt, and not to leave anybody, I'm my friend Shiv Kumar from KIMS, and all the other department HODs like Anil from physiotherapy, and nursing staffs from here and in charge. Our people are there, sister in charge from OT, Sister Rosie, and most welcome all the delegates, and please make use of this occasion and go for more clinical discussion and clarify your doubts, and it will be more useful for your final exams and future practice. Thank you one and all, welcome to one and all. Thank you.
Thank you, sir. Now I'd like to request Professor K.P. Raju, President of the Bangalore Orthopaedic Society, to say a few words.
It's a wonderful program from IOA. I congratulate even Dr. Atul Srivastav, who is a president now. All the best for the PG course. Thank you.
Professor Edward Nazarath, President of the Karnataka Orthopaedic Association, to say a few words.
Respected dignitaries on the dais, off the dais, and PG teachers and delegates. At the outset, I congratulate the Department of Orthopaedics St. John's, headed by Dr. Mallikarjuna sir and all his staff, for conducting this program year after year. I've been here for I think this is the third time we are present here. They have a good number of cases here to be demonstrated. I request all the PGs take to use of it, interact here, because this is the time which if you have any doubts to clear. Wish the program all the best.
Thanks a lot, sir. Now I'd like to request the very popular Professor Dr. Rajagopalan. He's the President of the IOA PG Committee, to say a few words.
Good morning to you all, respected ladies on the dais, off the dais. It's very heartening for me to see a galaxy of all the eminent people from here. When I started this program many years back in St. John's, never imagined it will come to such a big event. First of all, on behalf of our President of IOA, Dr. Atul, he has asked me to convey his greetings to you all and best wishes for the team. Also, on behalf of the committee, and some of us are here, We thank the organizing team, Dr. Mallikarjuna and the whole team of St. John's for doing this for thing. And the last one more word to the postgraduates. This is entirely meant for you, and we are doing our best to do it in every part of the India by rotation. And please make use of it. And also, please become associate members of IOA, which will help you in many ways. Not only that you won't lose any money, you have to pay the balance only when you join. Number two, for the inland fellowships, you get a priority if you are attended the program also, and also IOS. Remember, with that, thank you all, and make us good use of the opportunity. Thank you.
Thanks a lot, sir. I request our Dean, Dr. George D'Souza, to please address the gathering.
Dignitaries on the dais and faculty and their delegates. At the outset, welcome to St. John's. And as Dr. Mallikarjuna has said, this is Diamond Jubilee. This is the 60th year of our existence. And the Department of Orthopaedics is very central to this institution. It's probably one of the first departments to be started. And like Dr. Mallikarjuna said, one of the leading forces was Dr. Katie Thomas, who is no more with us, and for which there's going to be an oration today. This department, normally when we talk about orthopedics, we think of broken bones and destroyed joints. But this department has forayed into rehabilitation, has forayed into preventive orthopedics, and I think I must congratulate them for that also. And this program, like Dr. Rajagopal has said, has been going on for many years and has become increasingly more and more popular. So I wish that this program is very successful and continues as the years go. Thank you very much.
Thank you, sir. Finally, I request Father Jesudas to say a few words.
Dear esteemed guest and dear dignitaries, as well as our best friends, we are proud of you. And especially, I wish and thank the Department of Orthopaedics, who takes always a new initiative to learn new things. We all learn. Learning is an art. And we learn things for ourselves. But when we point the doctors, when they learn, it is not for yourself. Whatever you learn, it is for others to make things better. Therefore, I would like to take this opportunity to wish you all the best and learn things you always do, not for yourself, but for others. God bless and thank you.
Thanks a lot, Father, for the kind words. Now, I'd request our organizing chairman, Dr. Mallikarjuna, to kindly felicitate Father Jesudas. I request all the dignitaries to join in. The organizing co-chairman, Dr. Rajkumar, to kindly felicitate our Dean, Dr. George D'Souza. I request all the dignitaries to join in the felicitation. Society, Karnataka Orthopaedic Association, and IOA PG Committee Chairman, please. First, can we have BOS President Dr. KP Raju, Dr. Edward Nazareth, and Dr. Rajagopal to kindly request all the other dignitaries to kindly join in the felicitation. Request Dr. Rajkumar to kindly deliver the vote of thanks. I request all the dignitaries and the delegates to be around, because for the first time we have a main event. We have head of the departments from AIMS Delhi, Professor Rajesh Malhotra, delivering the first KT Thomas Oration. So that immediately follows the inauguration. So I request all of you to stay back. Thank you.
At the outset, I would like to thank all the dignitaries on the dais for giving their precious time for us for this IOA PG teaching program, and the oration following which is in the name of Professor K.T. Thomas. And I also would like to thank all the dignitaries of the dais who have spared their valuable time and graced this occasion. All the teachers, all the faculty, in-house, outstation, we thank you for coming here. And we hope all these 2 days of deliberations that we are going to have will be fruitful for all the delegates who have come. And I wish all the delegates the very best. Please interact with the faculty, learn from them, and this is your moment of truth. And this is where you can make mistakes and then learn from it. And you should be able to perform better in the exams that is going to come in the coming days. I wish all of you the very best, and thank you so much for coming here. I request all of you to please stand up for our national anthem in reverence.
Janagana mana adhinayaka jaya he Bharat bhagya vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे Jaya 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 He.
Please be seated.
Jaya.
Thank you, sir. All right, we move on to the. All right, I request everyone to please settle down. All right, we move on to the main event. Now, for the first time, as I said, we're starting Oration in the name of Professor K.T. Thomas. So, he was the first postgraduate in the Department of Orthopaedics at KMC Manipal. He was the head of department in St. John's from the year 1976 to 99. And in a way, he was a cornerstone for the department to be the way it is today. So he encouraged all his faculty and postgraduates, especially to take up subspecialty practice. And he, in fact, under his guidance, started the postgraduate course in St. John's. So the list is endless. These are the few salient features. Now for this oration, I'd like to request the following chairpersons to please come on stage. Dr. Rajendra KV, Professor Putti, Dr. Rajagopalan, and Dr. Mallikarjuna Swamy, and the Dean and Director, BMC, we have Professor Ramesh Krishna, to please come on stage. Now I'd request the organizing secretary, Dr. H.P. Rajagopal, to kindly escort the orator onto the stage. We have, needs no introduction, Professor Rajesh Malhotra, the head of departments at AIMS. To please join in for the felicitation ceremony. So Professor Rajesh Malhotra is the head of Department of Orthopaedics at AIMS, New Delhi. The ex-chief of Jai Prakash Narayan Apex Trauma Center, past president of Indian Orthopaedic Association. BC Roy National Award winner in 2014, MBBS and MS from AIMS New Delhi, fellowship in joint replacement from Australia, Brisbane. He's been a renowned traveling fellow, AO Trauma and Reconstructive Fellow, Indo-British Traveling Senior Fellow. I think the list is endless, as I said. I think he's also been part of these various committees and been responsible to start various initiatives in the PG teaching program and in the field of orthopedics. It's a pleasure to have you, sir. Now can we have Professor K.V. Rajendra to kindly give the introduction, to say a few words about the orator.
Thank you so much. I'm delighted to be here today, this morning, because I was working here almost 40 years back. That's almost in the 80s, 1980s I was here. And I'm telling you, I recall these nostalgic memories of St. John's. It's fantastic to be here today again, and especially for this Golden Jubilee and the Diamond Jubilee, which Mallikarjuna has initiated in the name of this oration in name of Katie Thomas. I'm so happy about it. I was one of his favorite students while I was working with him, and really I cannot, if at all I have to confess, it's any professor that I've worked, the best is Katie Thomas. He is just a wonderful personality. Not only a good surgeon, a great human being he was. He never had any sort of jealousy in any of his juniors upcoming. He always promoted them. So that was the great virtues of Thomas. We used to spend the whole days with him here. I really feel sad today he's not here with us. But anyway, coming to Dr. Rajesh Malhotra, I'm sure he has got a huge series of his things need not be introduced. But my acquaintance with Rajesh was the bone and joint day when it was celebrated. That was at Delhi, right, Rajesh sir? Under the Professor Dr. Rajshekaran, Coimbatore, he brought in that this thing, and the Chief Justice of the Supreme Court was our chief guest, right, sir? So we were a few invitees there, and when Rajshekaran was addressing the meeting, he said the whole work was going to Dr. Rajesh Malhotra's credit. So give a big clap for that, for the bringing the bone joint conference here. Then my other association was, when he was the president, I was the chairman for the disaster committee, which he initiated that. We did some good work during the COVID time in bringing some free masks, and which were very difficult those days to get that. With these few words, my respects to you, sir. You can just stick with it. Thank you.
Thank you. Before the start of the oration, I request Dr. Rajkumar to kindly read out the citation.
The citation for the Professor Katie Thomas Memorial Oration reads like this. Professor Rajesh Malhotra is a great human being, Head of Department of Orthopaedics, AIIMS New Delhi, past President of IOA. He is the recipient of the prestigious BC Roy National Award and many national and international awards for his contribution in the field of orthopedics. In recognition of his excellence in patient care, research and education, we are indeed honored to present this citation to Professor Rajesh Malhotra on Friday the 4th August 2023 on behalf of the Department of Orthopaedics. Thank you.
Thank you, sir. Now I request Professor Rajesh Malhotra to kindly deliver his talk.
Thank you so much. Thank you. A very good morning to all of you. I am overwhelmed by the affection and the honor which has been bestowed upon me to be giving the inaugural oration in the name of one of the doyens of orthopedics and such a beloved teacher. I think there cannot be a better recognition for any teacher. I want to thank the Department of Orthopaedics at St. John's Medical College, led by Dr. Mallikarjuna Swamy, for this honor. And I think this remains the most prestigious honor I've ever received. Thank you so much for that. Now we did talk about the training. We did talk about the next generation. See, what I see in you all is the future. And we had great teachers, and they helped us build our career. You got a head start in that, so many things are so much more advanced now than what they were when we started our career. So what I would like to request to you is to, learn from your seniors. So you saw the disappearing art of physical examination, because these days if somebody cannot lift up the arm, you ask for an MRI, and the radiologist says MRI shows complete rotator cuff tear, And then you ask the patient to elevate the arm, and he elevates the arm overhead like that. So there's such a big disconnect between what the MRI is telling you and what the clinical finding is. So clinical findings, clinical examination is far, far more important. And an MRI will also not tell you whether the patient is symptomatic or not, whether the patient is, the handedness as it was discussed. So today I'm going to attempt and show you how my practice evolved with a few key messages. One is, no problem is too big if you're prepared to take up the challenge. That's number one. So keep an open mind. And second thing is, when you think something is beyond your comprehension or beyond your competence, just take another opinion. Go to a senior. In medicine, you are in operation theater, things are not going, ask for help. You will have that occasion in your life many times when you are struggling. Don't just make it an ego issue. Ask for help. And that will, help you overcome the challenge. So today I'm going to talk about the lifetime experience I have had in revision hip arthroplasty. It may look a very highly specialized topic, but the fact is that given the number of hip replacements being done in India, within your career you are going to find a huge burden of revisions. And I just want to address some key issues and show you how we have taken care of these over the years. So those of you who are interested in basics or advanced, I was lucky enough to get support, and you'll see some key names on the authors of forewords. These are the people who contributed their experience from all around the world to contribute chapters in the primary as well as the revision hip. And this is something we should always start with, not this particular book, but read a text which you like reading, which you understand, and start your practice from that. Now, I'm going to actually talk about 4 major issues here which lead to revision hip replacement: the aseptic loosening, instability, infection, and the young age. So let me show you how we have overcome these challenges over a period of time. So about the aseptic loosening, I made a strategy long time back that you can either chase the bone, you can augment the bone, or you can replace the bone. Chase bone means you put your implant wherever the bone is, right? So you use a special, say the upper end of femur is, wherever in socket there is some bone at a slightly higher hip center, you put your cup at a slighter hip center. That is one strategy of overcoming the bone defect. In knee replacement, you always know that we say that if there's a tibial defect, you can undersize the tibia by one size, lateralize, and you can take care of the defect. So you chase bone. The second is to augment the bone. So you can use allografts, you can use the special implants, or you can replace bone, which means that the upper end of femur is missing, just put a tumor prosthesis. They'll be the 3 key strategies for acetabular reconstruction. So let's talk about the Peprosky classification for acetabular defect, because that remains actually one of the most difficult things to overcome. So the type 1 is when there is a minimal bone loss, there is no migration, minimum lysis, and the rim is supportive. And that intact and supportive rim actually gives the support to the cup, and we know that if 50% of the post bone contact is there with the cup, so then it will succeed. That has been reduced to 40% with the trabecular metal or the porous metal cups because they are so good. So this is an example of a type 1 defect where the rim is supportive, and you can just put another cup, and then this is the follow-up of the same patient. So it is partly like chasing bone. It's a slightly higher hip center, but I think you can accept up to 1 centimeter of high hip center. This was the resurfacing gone wrong with a fracture, and you see that the socket was not bad, and on the left hip, you could put away even get away even with a cup without any screws. So that is the type 1. Then the type 2 is when there is a superior migration of less than 2 centimeters. The teardrop is intact. There is no lysis in the ischium. So here the superior dome is deficient, but the superior rim is intact. So this is the type 2A. So the shape of the acetabulum has become bad now. The dome is deficient, but there is enough host bone to give hemispherical cup and inherent stability. So again, like I said, 50% of host bone is available. So the porous acetabular shell will work. So this is an example, 48-year-old female, and then this is how you can actually overcome this kind of deficiency. Type 2B gets a bit more severe. There is superior-lateral migration less than 2 centimeter, but the teardrop is intact, there's no ischial lysis. But here, the superior rim is compromised. So you'll see these kind of picture very often. When you see that the acetabulum is misshapen and the superior rim is gone, and you'll see that the femoral head is articulating somewhere at the superior-lateral margin. And usually for 50% of the host bone is available, so you want to put a bone graft or a porous shell with a bone graft or an augment. So this is an example. You know, the type 2A, the cup has gone up, superior lateral deficiency, and then you put an augment with some graft in the floor and you can get away with it. Another example of type 2B defect, you see that it has gone up. There's erosion of the bone there. And sometimes when it is too big, you can actually use a cage. Particularly, I'll have no hesitation in using a cage in an elderly patient because a low-cost option. The problem with the cages are they are non-biological, so they don't last more than 5 to 7 years. But if you are dealing with an 80-year-old man, there's no need to put expensive implant. You can allow them immediate weight bearing, and you can even overcome pelvic discontinuity, which I'm going to talk about in a short while. So this was treated with the cage with a morcellized graft in the floor. Type 2C is when there is a medial migration, something like a bad protrusio. The teardrop is obliterated here, the medial wall is absent. So that is what where you need a lot of graft medially to restore or reconstruct the medial wall. So this is a type 2C defect in a patient with fracture neck femur. Somebody put a bipolar which actually went right through the floor, and this had to be grafted, and then you can put a cementless cup very successfully. Another example, and you can treat it, you can see that we don't touch that cement which is inside. And I've got a lot of stories to tell you about that kind of cement. But then for the time being, unless it is infected, don't touch that cement. You know, let it be. It is not going to cause any harm. It still lies there at the follow-up. Patient has got no problem. This is another example of type 2C, 54-year-old female. You see the total destruction of the medial. I think, and you see that we have put morcellized grafts. So I'm going to talk more about this kind of technique, which we have further modified and published. So this is actually going a step back, actually somewhere it is come, but the idea here is that to show you the morcellized graft which is put in the floor for all the cavitary defects, and you can have very good results. You can reconstruct all these major cavitary defects, and that was published long time back, actually now almost 12 years back in the Hip International, where we showed that they work very well when you put morcellized allograft in the floor. Type 3A is the superior lateral migration more than 2 centimeters. So now it's gone up and out. So what has happened is there's a rim deficiency from 10 o'clock to 2 o'clock. The teardrop is partly intact, and this is how it looks like. Now it becomes more difficult to manage. You may have to need the augments or the column buttresses. But again, once again, I'll say that the availability of the porous metal implants has become a big boon. So when you have a superior lateral acetabular deficiency, you can actually chase bone by using an oblong cup, which means that you put an implant which is in the shape of the defect which is there, so that's like chasing bone. You can augment the bone by TM augments or allograft, or you can replace the bone by a figure of 7 or a flying buttress allograft. So this is a acetabular fracture gone bad. You can see severe superior lateral migration, type 3A defect, major defect, and you can use a distal femur, cut it into a figure of 7. You can see that, this is the 7 you draw, and then you can actually position it on the edge of the acetabulum, and then put some screws, and this is the figure of 7 graft. You can actually put a bone graft here, which is called the flying buttress graft, which can be a femoral head graft, which many of you must have used, and it is quite something you're quite familiar with. Another example of type 3A defect, and then you can use the augments. You can actually put the trial augments, put it in place. So basically you are extending your fixation to the bone bed by using the special augments with osseointegrate, and then you unitize these augments with the cementless cup using the cement, thin layer of cement between the two, and then it becomes one customized implant on the table. So this is a follow-up of the same patient. The 45-year-old female known rheumatoid arthritis, see how bad the acetabulum is, become almost like a plague, and then this is the amount of metallosis you find there, and then of course you reconstruct it gradually by getting it out of the way, retracting femur out of the way, and using column buttress, which is a posterior column buttress, which you see that's a green colored trial you see, and then you see this. I'm not stopped using these less often because I've seen in many patients this irritates the abductors. The patients get the lurch or a bad gait. But whatever you do, this surface of the trabecular metal cup or the augment or the buttress which is exposed to the soft tissue must be covered by a layer of the cement. Otherwise, it can actually form so much of bone that posteriorly it can engulf the sciatic nerve, and then you won't know what to do. It just throws away so much of bone that in some cases a patient dislocated. So after 4 weeks, we couldn't dislodge the cup. It was so solidly integrated. So removal remains one of the problems. Soft tissue irritation and too much of callus causing problem locally can be issue with this, and this is how it has been covered with a layer of the cement so that it doesn't irritate the soft tissue. This is how it looks on the X-ray. So it's all supplementary fixation you use in these cases to give them a stable hip. Now this is a lady, this is again low cost solution, 52-year-old lady, tubercular arthritis. She had a hip replacement and she slipped and fell, and the cup came out, pulling out a part of the posterior superior wall. As it is, it was quite an osteoporotic bone. So she couldn't afford much. So this was, she had already spent for the cementless total hip and a short stem. So what we did was actually to put an augment superiorly where the defect was, and then we put a cemented cup. So this was possibly the cheapest possible option. The augment restored the continuity or the integrity of the superior dome, and then we cemented a cup, and it continues to do very well at the end of this is actually an old X-ray about 2 years back, but this is the latest follow-up I have that she continues to do very well. So not always, sometimes when we use augments, we use an ordinary cementless cup and use a trabecular metal augment with that and unitize it. You don't always have to use an expensive trabecular metal shell also with that. So that's how you have to play around with the affordability of the patient. So the type 3B, the worst one is the superior medial migration, more than 2 centimeters. This one is called up and in. So here the teardrop is completely obliterated and the rim deficiency becomes even more severe and goes from 9 o'clock to 5 o'clock. So that is the worst type. You can see this is practically how the acetabulum will look. Columns are no more supportive. The host bone is not enough for anything, and you will need a lot of additional armamentarium. So this is one example of a patient with ankylosing spondylitis. It is a severe deficiency. Then you could use an augment with the trabecular metal shell with a distraction technique. This one was actually a distraction technique, and this is the follow-up. And then again, you can use big jumbo cups, but this is actually one of the earlier ones. Now I won't do something like this, and I'll tell you why. Because what happens is whenever you go for a revision of the acetabulum, there's always ileum there, big ileum blade. So you see X-rays where there are 6, 7 or 8 screws going into the ileum. But unless you anchor the cup here, the cup will fail in abduction. So this inferior edge will pull out, it will gradually become vertical and it will pull out. So you have to put screws here in the pubis or in the ischium, something which we call kickstand screws. So today I won't do it. This is older X-rays, maybe 20 years back, and got away with it. Today I won't do something like that. So I'll show you some examples of a kickstand screw. So type 3B defect, again, severely deficient bone, and this one needed the TM buttress again and to reconstruct, and then of course you cement and unitize and cover the outer surface with the cement, and this is how it looks. This is a patient where classically this was done by me as a demonstration surgery of revision, and I said I need trabecular metal shell because I want to put screws down here. But I was told that this particular company was sponsoring, and if I use something else, the patient will have to pay. So I did something which you should never do. So I compromised and I put this, and surely enough, the patient came to Delhi to me to say, sir, you had operated this and this is gradually now moving. So I had no option. I said, I have to revise it. Now this is getting from bad to worse. And this is the classical example why you should not try to reconstruct a major deficiency without anchoring the inferior edge of the cup, because it will fail in abduction. So this was a huge defect now, and of course I used a cup cage construct to anchor the construct with the inferior. So I am now spanning the defect. There is a screw here which is going which is the kickstand screw, And then this has held on at a follow-up of more than 6 years and continue to do well. Sometimes with a very severe deficiency like this X-ray is actually a few days after the surgery. The surgeon tried to reconstruct a major defect with a cemented cup, and that I had no option except to use a total vestibular allograft. So for those of you, just to initiate you to the concept, you take a total vestibular allograft like this, you make a groove here, it's called tongue-in groove, and then you wedge it onto the edge of the acetabulum, so that gives some stability, and then you have to protect it with a cage. That was the first ever total vestibular allograft done in this country. Now these days we would just ask for custom-made implants, so that's a possibility now. So this is just a history, just into the pages, but to tell you that's another way of dealing with major defects. Special types include the pelvic discontinuity, so you can see that, you know, the radiological signs of the pelvic discontinuity. There will be asymmetry of the obturator foramina on the X-ray. This will go medially, the inferior part of the acetabulum will be seen medially, and then there will be a break in the two lines in all the Jubilee views. So one of the simplest way, like I said, in a non-affording old patient is to just bridge this discontinuity with the cage and then put a lot of graft in the floor, and you will get away with it. Another example of pelvic discontinuity, you can use this kind of biological cage. This was an octopus cage by DPU, which is not available anymore. Then we came across something. So whenever we were doing these reconstruction of acetabular cavitary defects, so it is very technique dependent. So if you don't impact it well, it will fail, and then you couldn't allow the patient to bear weight on it. So what we did was we innovated a sandwich technique where we put the morcellized allograft, then injectable biphasic bone graft substitute, then another layer of allograft, and then another layer of cement. So what it does is, in a liquid state, this cement gets into the interstices if you have left them because of the not so good technique. And then within a few minutes, it solidifies and becomes very hard. So it becomes a solid structural support in the floor. And even with the very big defect, we are able to actually make the patient bear weight at the end of 4 weeks or so. And we have actually then subsequently demonstrated the superiority of this composite biomechanically by doing experiments with the Indian Institute of Technology, and this work was awarded the Golden Jubilee Oration Award in Amritsar late last year. This is an orthopedic surgeon from Bangladesh. He came to me. He had primary surgery done in Kolkata. Severe defect, and you can see this could be taken care of by the sandwich technique and a cup cage construct. And now he is actually 5 years down, and this of course he was quite excited. This was his latest video from Dhaka. He's another one at 1 year. Now this is the latest one. He's quite happy. So this we have now recently published in the Orthopaedics. So the message here is that if you are doing something, try to do, even if you are doing it and it's a standard method, try to see what is the deficiency and whether there is some way to improve on that deficiency to get you better results. In the 45-year-old female, this was actually pelvic discontinuity, and this was treated with sandwich along with the pelvic distraction technique, and then of course this was actually revised by somebody else, and then he left the stem, and then you see there is no kickstand screw. The moment I saw this, I knew this is so this is what happened. It migrated, and now it has come back with a 3B defect, up and in, huge defect, and this was how it was reconstructed with the sandwich technique, and she continues to do quite well at the end of 4 years. And then she came and said her other hip was hurting, and then we saw that the polyethylene was worn off, and there was a big defect. Now this was osseointegrated cup, and you can see if I take it out, there will be no bone left here. So what we did was we made a window on top of this here, curated out all the defect, and then we filled it with the morcellized sandwich technique, filled up the defect, and then we thought we'll just replace the liner. But it so happened that the liner design had been changed by the company by that time. So this liner won't fit in. And I didn't want to now remove this cup because so well osseointegrated in a porotic bed. So I just cemented this, and she continues to do well at the end of 1 year. Even she comes in failure. will talk about. But I'm sure that we have reconstructed this bone stock here, and that will be a great help. So other thing is on the femoral side, I'll like to make special mention of one technique. So when you have to revise femur, a patient comes to you, he's got that 14 or 16 centimeter stem, and it has failed. And the first thing everybody wants to say is, I'll use a Wagner, I'll use a stem which is distal fitting stem, 5 centimeters longer. If this man is 30, 35, 40, you don't want to compromise his another 5 centimeter of bone. So I have seen X-rays in 50-year-old where there's a stem which is reaching up to the supracondylar area because of previous 3 revisions, and then it fractures at the supracondylar area, leaving no option except with the total femoral revision. So be conservative, and that message I'll give you again once now. So this is a young man, 35-year-old, this has failed. Now I don't want to go down, it's anyway longer than our usual primary stem. So what I did was, there was ruled out infection as always in these cases. He's young patient to preserve the bone stock. So this is what we did. So this is something called impaction allografting. So what you do is you do impaction allografting like I showed you for the acetabulum. You do the same impaction allografting on the femoral side. You have these special TAMs which are cannulated. You create a, this was hollow, ballooned out femur. Now you have actually impacted the morcellized allograft, and now you have made an envelope to accept the stem and the cement, and this is how it looks. It doesn't look very great, doesn't it? I mean, it's still, like I said, the impaction allografting is so much technique dependent, and this kind of thing I'm doing much less often than I do the acetabular impaction. But see how it goes at 6 months, and see how it goes at 1 year, and see how it goes at 4 years. Something which looked not so good immediately, it is consolidated, and now this patient is still having his intact bone, built bone stock. I would have actually condemned him to a much bigger stem eventually if I had just fallen for it and just say take it out and put a long stem. So that's what you have to think always. In a young patient, always think of the next revision. The other thing which we sometimes get is, I've got a few cases like this, a fracture of the pelvis with a failure of the for the acetabular component like this. Now this is a pelvic discontinuity, but then there is a non-union here also. So I can't bridge this and hope to get a stable construct. So we opened, and when we opened, we actually, of course this is the shortening which was there, there's a discontinuity, demonstrating it on the table. We ruled out infection. We wanted to put a cup and cage, but before that we first plated the ileum, got the stability here, and once we plated it, then we put a cup cage. And don't worry about this. When we put a cup cage construct, the trabecular metal shell cup should be as vertical and retroverted, only then it will allow a cage to sit on top of it. And then you are anyway going to cement a liner in the desirable position. So you should not worry about it. Put it in any position which gives it maximum possible bony contact. Keep it vertical and retroverted to allow the cage to sit on it. And this is the follow-up at 3 years. She was more than 70 years when she came. So this is what we have published, the cup cage construct using a Bush Schneider cage, because the original cage for cup cage construct is not available. So that was about managing bone defect. Now talking about the instability. So most of the instabilities occur because there was some interposition of soft tissue or bone or cement at the time of reduction. So you must make sure of that. So if you are able to, first reduction, dislocation should always try to reduce, put them in a brace, but then if it is, and look at the component malposition. That would be the commonest cause within first 3 to 6 months. So if something is dislocated after 3 months, after 6 months, it's unlikely that it was because of the component malposition. So look at the version of the acetabulum, version of the femur. So this was an infective subtrochanteric fracture. We put in a spacer after taking out everything, and then this dislocated anteriorly because the cup antiversion was too much. We reduced the antiversion and it became stable. So those are technical errors, and those have to be avoided. So that's why we keep on hearing about the special checks and special techniques to avoid that. Now this was a lady who had this was actually a proximal femoral replacement done, and that it caused impingement. So you should look at the impingement as a cause, soft tissue and bony impingement. Sometimes we have just found that there was some impingement between the cage and the stem, so we just took Midas Rex and just shaved away some part of the cage or some part of the trochanteric overhang in order to ensure that the soft tissue impingement is taken care of. Sometimes the absence of the abductors over the greater trochanter, when the components are very good, is the other cause. So this is again a case where there was a trochanteric fracture which was operated, the patient dislocated. When we went in, we found that the greater trochanter was there. And these cases, we have done the gluteus maximus transfer. That's a very effective technique. You can actually also transfer part of the iliotibial band to replace the gluteus minimus. And then you have the vastus lateralis here. You make a sleeve here, split it, make a V thing, insert this muscle attachment of the gluteus maximus transosseous here, and close this on top of that. So another case of infected total hip, went in, found the ball trochanter completely. You can use a dual mobility or some constrained cup, but then we thought the biological transfer would be better. So make a pocket in the vastus lateralis and put the gluteus maximus in that. Roughen the greater trochanter before you attach the thing to it, and then this is the complete reconstruction. Sometimes in a late dislocation could be also because of wearing out of the polycline, and then it will need revision of both the femoral and the acetabular components. And of course, dual mobility cup and the captured cup remain the useful technique. Now this is another very difficult problem in India, the stiff spine, ankylosing spondylosis, stiff hips. I have now started doing them by direct anterior approach because I can actually really monitor everything under image. But this will have a tendency to have excessive anteversion, and you have to reduce the anteversion in these cases, particularly if the spine is straight and you find that the pelvis is looking like an outlet view on AP. And then this was a case, we reduced the anteversion, but you'll see we have also, if the patient can afford, started using the S-ROM kind of stem. So the patient doesn't have to spend on implant. In case it dislocates, we can just knock out the stem, change the version and put it back again without putting any additional implants, and it can be stable after that. This is something I bought for AIMS, the EOS, and that's something which actually gives the whole body imaging, standing and sitting, AP and lateral, and that can actually really help us decide the relationship between the pelvis and the spine. Constrained liners are good, particularly for low demand elderly patients, not in young patients because they give rise to loosening, but they are a good bailout solution. You should always have some available for you for whichever implant you use. The next problem is, of course, the infection, which will cause failure. So they'll come to you for revision for infection, and the biggest problem in that is the culture negative infection. So that could be because of prior antimicrobial therapy, inadequate use of the available microbiological methods, inability to detect PGI pathogen. So we have had fungal infections, we have had non-tubercular mycobacterial infections. So all that you see as a culture negative may be something which is, like they said, that there's nothing called idiopathic. Same way, possibly there's nothing called a culture negative infection. It's your inability to detect the infection. So one thing which we have used very successfully and published is the sonication. So this is what happens. You collect your implant in a very special instrument, you add some ringer solution, and then vortex it, then sonicate, then again vortex it, and then again centrifuge for 5 minutes, take the aspirate and inoculate. And we have seen that gives much higher sensitivity and specificity than the culture of the periprosthetic tissues. So in future, in order to detect these failures, lot of which look like aseptic failures but are actually septic failures, putting at risk the reconstruction you do, we'll need all these methods. 72-year-old male, operated in 2002, pain in right hip, and this was something which we found that was staph epidermidis, and then this was when the tissue culture was negative, but the sonication showed rifampicin resistant staph epidermidis. So there are certain advances in diagnostics. MALDI-TOF was more for soft tissue infections, but now we have BioFire, which has a panel for arthroplasty infections. So a lot of institutions are now acquiring it. Of course, like I said, we have found the fungal periprosthetic joint infections. We have actually used 16S RNA very effectively in with the microbiologists to diagnose rare infections. This patient with fungal co-infection with staph hemolyticus was treated with fluconazole. They need fungal infection, need 2-stage revision, but then you need to have much longer interval between the 2 stages as compared to a bacterial infection which you're treating by 2 stages. Another important example, if a patient comes with periprosthetic joint infection with tuberculosis, it doesn't need surgery as a septic one needs. This was a complex revision. He had infliximab injection. After that he developed tuberculosis. It just healed with ATT. So you don't have to
jump the gun when you're dealing with the tubercular infection. Just don't operate on them. They have multiple sinuses and going in different directions. Very difficult to take. The only place where you should excise all the sinuses and do radical debrima is the non-tubercular mycobacteria, because there you can't eradicate the non-tubercular mycobacteria just by the drugs. You have to excessively debride and excise the infected tissue. The last part of my talk is about the young age, because now we were discussing so many patients with avascular necrosis of femoral head, either because of steroid or because of COVID or because of both. And we know that no implant will survive lifetime in these patients. And this is an example. This boy is 25-year-old, and he came to me with this picture, you know. Comes to me with this, with a failed hip and a broken stem. He had some childhood septic arthritis with osteomyelitis, and somebody operated at the age of 20 and put this total hip like this, and now at 25, he's got major defect here and a major defect here with a broken implant. Obviously, this was a very major reconstruction because of the cement inside. You know, this cement, we always do angiography for these cases. We did angiography, and then this was the removal of the implants. Major defect had to be reconstructed with trabecular metal shell and the augments, and then needed a reconstruction with a long stem on the other side. This is the follow-up, but see what he has landed in at the age of 25 years. So that's why you need to be very, very conservative. In contrast to this, I show you a patient which I operated more than 15 years back. That time the short stem which I used, the Proxima, was very popular, so I did this Proxima. This lasted good 15 years, and then she came back with a failed vestibular component. And we know that these cups, now we realize, don't osseointegrate very well. It could fail even after 15 years. So I removed that large head thing, and all I did was to actually put in a new cup, because that was the large head metal on metal. Put in a new cup, retained the same stem, and now she's good for another 15-20 years. She's doing very well. So this is a very, very conservative revision, because, you know, and even if I have to revise this, you know, I can just put a primary stem here, even at the age of 55. So that is the message that you should be very careful. The bone banking, which I learned, was a big boon, and I'll give you some examples, which is impossible to. This was a case operated in Bangalore. So this lady had a juvenile rheumatoid arthritis. So the surgeon took it up for bilateral hip replacement. So he did the right one first. I mean, it's not his fault. The femur was so narrow that even for putting the smallest size femur, he ended up splitting the femur. So he wired it, and then he tried the same thing on the other side. The same thing happened on the other side, so it fractured, so he put the plate on this side. So fortunately for that girl, this one united. Unfortunately for her, the left one did unite. So now, this is fractured here, and the ideal treatment for this would be to revise it with a longer stem. Now, if you can't get that size primary stem, where from are you going to get the revision stem of that dimension? So I discussed with her. So what did was, we took out the old plate, we put a new plate with the spider attachment for locking screws, and we put this morcellized strut allograft, and we injected the my favorite injectable bone graft substitute. And this is she's happy, Sunny Bhavna. That's her WhatsApp status. So this she has gone on to heal very well, and she's now actually fully active and very, very happy. Sometimes there's a massive loss on both the sides with infection. This is something I've never understood. The tumor surgeons remove this for a GCT. This was done at the age of 18 years for a Delhi University student. And then they put an implant which is neither cemented nor cementless. So it's just some shaft which is put into the bone. And then mega processes are known to be very, very prone to infection. So he came to this at multiple stages to control infection, and then use this proximal femoral allograft for this deficiency. If he was a 70-year-old, I would have just put a proximal femur replacing process and would have come out in no time, because this will need at least 4 to 6 months of protected weight bearing till it heals. Just to show you an example, this boy is now at 4 years, at 8 years, at 13 years, and he came recently to trauma center to see me, and this is his final position. And you can't actually see where the host bone is and where the allograft is. So these things do work, and they are biological solutions, and they are much better than metallic implants, which will get weaker with time. So this was also the first time a cup cage construct was done, so we published it. Sometimes we use the trabecular metal coin kind of thing. And again, this was proximal femoral allograft, and she is now, I think, about 10, more than 10 years down. This was actually 2006. So this was when she came with a 10-year follow-up. Sometimes things like this will happen. Very osteoporotic bone, there was a hemi replacement. Somebody tried to revise it with a long cemented hemi replacement, and there is nothing here. And this bone is very weak, and he has already caused a fracture. And the lady is old lady, comorbidities, bedridden when she's brought. So we just took everything out, put a reef stem, and put the strut allografts, and this is how it is. And then, you know, she is now, this is when she was standing immediately after the surgery, and this is during her follow-up. She came for a knee replacement at the end of 10 years, but you can see that. So we thought we'll use some special technique to do it, but she was found to be unfit because of very high thyroid levels, so it's still waiting for surgery. Failed fixation like this sometimes will need something like a proximal femoral allograft, which can actually be a good alternative for total femoral replacement. And this is how this young girl, she was just about 40 something, and she survived. Another word of caution, this was a pathological fracture due to CA breast. She had a neck femur, she was admitted with oncology. I did a cemented hip, and she had this fracture within 3 weeks because it was very aggressive tumor. So somebody put in a nail. So now she came to me like this, there's a nail, there's a fracture, and eaten up both. And again, to my rescue, I had this strut allograft, just wrapped them around and got her on her legs with a brace, just to let her live comfortably for whatever few weeks of life she had, because breast cancers, you know, are very aggressive. So having said that, all this experience also had a lot of complications. I don't want to give you an impression that these are not without complications. So this was a patient who had a very bad revision ankylosing spondylitis. He was very thin built, and you see, and everything was so close. So I was removing the scar from here to clear it for acetabulum, and I damaged the vessel. And then post-operatively, immediately we saw he was not moving his foot. We did an angiography. This was the X-ray, how it looked like. And since the pulses are not palpable, we did an angiography again, and we found that this was obliterated. So immediately, within an hour or so, the general surgeon was called. So he found the injury to the femoral artery, and he took out the clot, and then he sort of restored the vascularity, and he is now 3 years down, walking very well out of complications. So complications will happen, but you must always, so 2 things. Any hip replacement or revision hip replacement does not go out of the operation theatre without an X-ray. Just remember that. And no patient will be shifted to the ward unless the motor and sensory function has come back, and no knee replacement patient will leave the ward or the recovery without palpation of the vascularity. So you keep that in mind. Sometime in your life, you will avoid yourself a big embarrassment, which may actually also cause loss of a leg to the patient. So this was another patient who came. Now we had this experience of working on the vessel inadvertently when doing a complex thing. So when we saw this, we were worried. So we did an angiography, and the angiography showed that the screw was very close to the vessel. So what to do now? So we asked our radiologist. So they put in a Fogarty just before shifting the patient to theatre, and they said, if you inject 2 ml in this, the balloon will occlude the vessel. So they showed us, and then we took the patient in lateral position, kept the surgeon on the standby in case we rupture, we'll inflate it, then you repair it. Fortunately, it didn't happen, and we could do a major reconstruction. But then, you know, we published it for the sake of education, that, you know, you must not only be aware of these kinds of things when you are dealing with intrapelvic components, but you should also be ready to deal with it, because you don't want to lose the patient on the table. So this is a person who was operated by Dr. Ranawat in New York, and he came to me, he said, Dr. Ranawat has told me to come to you because he doesn't operate anymore. So we did, as usual, the angiography, and it showed us that the screws were very close to the vessel. So this was scheduled for Monday. So the Sunday, I asked my interventional radiologist to actually coil these vessels which were close to the screws, so which was done. And then you can see this is after coiling. So you see no blood circulation in the vessels which we were planning. You see the coil here, and there is no circulation distal near the screws, so there is no blood flow there. So I could actually go ahead next morning and confidently do this surgery without having to worry about a torrential blood loss coming from the abdomen, which I'll have nothing no way to know what to do about. So this is another last example. This was a patient who had this both sides done at the same sitting. So the surgeon did the right side. So this was bony ankylosis. So it's not at all uncommon to get lost when you are doing a bony ankylosis. So he ended up putting the cup here. He went ahead and did the other hip anyway, so that the patient could walk about. So this, we made a 3D model, and with this 3D model we made a 3D printed thing, and then we did, of course, the repair, and then we put this cup, and when we made the patient supine, there were no pulsations because the prolonged surgery, as it happens in the acetabular fracture fixation, for the retraction needed for placing that flange on the superior pubic ramus, we had caused thrombosis of the vessel, and that had to be taken out. And then that he recovered well, and then continued to do well. This is from his last year. He went for a holiday at a 6-year follow-up. This is the last example. A patient came to me. He said that I had this bilateral hip done, and I've been told that if we try to remove these acetabular components, he can die on the table because of blood loss. So we did the angiography. They showed that everything was far away. And when I removed this cup, there was bleeding. So I panicked. So the general surgeon was on the standby. He opened the abdomen and he found that it was just some venous ooze and there was no vessel which was injured. So I told him that the screw was close to the vessel, but there was no injury. So I said, now that you have opened it, I see that the other side has got screws like this, and I have to do at some stage, I have to revise this, and again I'll have the same problem. So we asked him to cut these screws. They were near the bowel, they were not near the vessel. So we made them trim these screws, so at least he had his laparotomy didn't go waste, and when that happened, we used these big cutters inside the pelvis to cut this will be familiar to the spine surgeons, and we cut these screws. This was his left side. And subsequently, I went to revise the right side. I didn't even look for any bleeding. Just removed those screws because I knew now from inside the abdomen that was away from bowel and away from the vessels. So, like I said earlier, we don't touch cement like this. One of my juniors put this spacer as antibiotic spacer as cement in the acetabulum where there was a medial defect, and it was still wet. It went and got stuck to the iliac vein. And when we went for second stage, when we were pulling out, it started bleeding. So that time I said, if you put something on the table and it is medial, don't take it out, it is stuck. Unless it is infection, then call the general surgeon. If it is something which was a cemented cup in place, which later migrated inside the abdomen, I'll just open it and just take it out without even an angiography, because there will always be a membrane. So that is the difference you have to see when the cement reached inside. If it reached inside in the primary surgery, then be very careful. If it migrated later on, I don't, and be always careful about the cementless component. They are actually, so we don't touch these, like I said, we just leave it there and do this. So just quickly, this was a patient with osteoporosis, went to revise, like I showed you, done by somebody else, is fractured. I put a Wagner, it fractured again, 2 places. So then finally, we had to put in a very long Wagner with cement, with circlage wiring like this. So when you do these kinds of things, always have a plan B, plan C, plan D, because things will go south sometimes without, with your utmost care also. So this is how it looked when it went. This is an interesting case. I just thought I'll tell you. He has been operated 16 times for infection, and now he has about 14 centimeter shortening, multiple surgeries and scarring, and a malunited thing. And this is his, scar. So lot of challenges. So we did an osteotomy. We did an osteotomy at the malunion. We put a reef stem, and what I do for lending is I release all the scar and put the shortest possible stem, and then put a head. Then keep on increasing the head size, and then every time it needs extra effort, then I take it out, leave the stem more proud, and again go through the same drill of short head, normal head, plus head. Then again take it out, again leave the stem inside, more proud this time, again the same. But with that also, I could actually correct only about 10 centimeters of shortening from these 16 surgeries. So it's still about 6 centimeters short, but then he is happy because he's got this new hip with which he had been going around for close to 20 years with multiple surgeries. Sometimes this will happen. So this was bony ankylosis on left side, this hip on right side. The surgeon thought not to touch it, so he replaced the right hip. This kind of pelvic obliquity you will find in angst, you will find in polio, you will find in childhood septic arthritis. So don't fall to the temptation of doing the easy side. So this is what happened. He did that, and just like the polio hip subluxates and dislocates, it dislocated. She came to me, I said, I will not revise this hip without doing this. So she wasn't happy. Then she reluctantly agreed. This was so bad, there was no anatomy. When I went in, I couldn't put in a cup. It was so porotic. So I left her as a girdle stone, and then I did this side, and then she went for COVID, and she came back after COVID to get the other side done. So this is the final situation. But she had a nerve injury. I couldn't put in the cup. She had a nerve injury which partially recovered to about 3/5 now. But then it was after all this time I put a hip on this side. So if you put a hip in a pelvic obliquity on the higher side, you will have problems. So this is another thing. We have seen a lot of cases with broken stem. This is a solution stem is the most common one if you use anything less than 10 millimeter, where the fracture occurs along with the fracture of the implant. So otherwise, we have a series of about 20 such cases. Many times when we remove it, the femur becomes very weak, so we have to use the strut allografts along with that. So this is what we described as a modified classification, because the UCS classification goes from A to F, and then we described a G, which is going through the prosthesis. So with this we subsequently published. So to summarize, the failure, which is the cause of the failure will decide how you are going to handle this. You should have all options in mind. Rule out infection in all the cases. Have a reconstruction. Think of the next surgery. Don't think of how to get out of it now. Think of the next surgery. So if you don't have allograft, doesn't matter. You can put a spanning locking plate. The idea is that you should be aware that this stem, if the fracture occurs from the tip of the stem, what are you going to do? So put in a locking plate, put 3 locking screws in the lower end of the femur, span it, put 1 or 2 unicortical locking screw, but don't leave it, unprotected. And then of course, the complications will always come to you. So in your career, whenever there is a complication and there is a litigation, God forbid, what experts and the court wants to know is, one, how was it detected? When was it detected? If you detect it promptly, like if we thought the pulse was not there, immediate ultrasound, immediate angiography, immediately explode. So if you had informed the patient in consent, if you recognize the complication in time, if you took remedial measure immediately, probably nobody will touch you, because complications are a part of surgery, and the more complex the surgery, more will be the complication, risk of complication, and the severity of complication. Thank you very much for your attention.
What a wonderful talk. Very apt for Katie Thomas sir as well. We really enjoyed, not only the delegates, I'm sure all the practicing surgeons here enjoyed your talk. I'd request Professor K.V. Rajendra to kindly present the medallion. And we're very happy to have Mrs. Katie Thomas, Sarojini is here. So thanks a lot, ma'am, for making it to the oration. Request Madam to come on stage, please. Thanks a lot once again. Now we'll break for 10 minutes for tea, and then we'll start with the academic session. Thank you.
requesting all delegates to come into the hall now. We're going to start with the next session. Good morning. Now we are going to move on to the next session for today. Moving on to the next session for today, which would be on hip joint examination. Inviting on the dais the chairpersons for the talk, Dr. K.P. Raju, Dr. Vanamali, Dr. Surendra Kamath, Dr. Vijay Goni, and Dr. Prakash Appa. Yes. Now I'd like to hand over the stage to Dr. Ajit Kumar, who will be talking to us about hip joint examination. Welcome, sir.
a little bit.
ಬಂದೆ ಅಷ್ಟೊಂದು ಮಾತಾಡ್ತೀನಿ ಅದು ಕೊಡೋದು
So very good morning. After that massive talk on hip replacement, we'll come to ground zero, ground level. Ultimately, the aim of all the exam-going PGs is to get through the exam. And as most of you all know, in most centers, the long case is generally the hip. Spine has unfortunately taken a back seat. So almost always be assured that the long case will be a hip examination. So this is not going to be a detailed talk because I think we are way behind time, and during the case discussion we can have more in-depth discussion. So basically 80% of your long cases, and ideally the examiners would expect you to be neatly dressed, well-mannered, considerate to the patients, and you need to be well equipped as well. And of course, most important is you be relaxed and be comfortable. Okay? So you have, I think in the classical case scenarios, I think in the DNB now it's only 20 minutes. There's no differentiation between your long and short cases, so you don't have that much time, but you need to make the best use of the time that you have. If you have any issues with the language, always ask for an interpreter, and if it's a female patient, always have a attender there. Write down detailed history. I'll just rush through all that, your physical findings, and you summarize and think of an appropriate differential diagnosis, if not the diagnosis, if it's a very clear-cut entity, and then a broad outline of the line of management. That's what is expected from an exam-going PG. You don't need to go to the extreme ends of management, whether it is the knee, hip, spine, whatever it is, okay? So these are all the things that you need to know. The commonest symptom in a hip case would be pain, right? Sometimes it may be a painless hip, but most often it's a pain, and then you need to go into all the aspects of hip. If you had read your Hutchison properly, all the various things that are associated with pain, you need to know the duration, the onset, whether it was gradual, whether it was very rapid, whether it was acute. All these things you need to know, the progression, the character, the severity, the radiation, and very important, the aggravating and relieving factors. Whether it is mechanical pain, whether it is arthritic pain, or whether it is some sort of an inflammatory, you get an idea from the history that you get, and diurnal variation. Okay, so often people jump about night cries and so forth. You need to know where it happens, why it happens. All those questions will be asked to you in the exams, okay? And whether at the outset, whether there was fever in this particular way. The next symptom that you have is limp. Again, quickly, whether it was right from the outset, like if it's a pediatric condition, DDH or CDH, whatever it is, the child would be limping right from the time the child starts walking. So whether it was at that time it was noticed, whether it was a slightly later date, whether it was during adolescence or in earlier adulthood. All these things you need to know, the mode of onset, the progress, and if it's associated with pain, and whether the patient is walking unaided or he needs a walking stick or even crutches. Some of them come to you in a walker, using a walker. So again, if the deformity, how long it's been, whether it was right from the outset, sometimes they notice the deformity more than the other symptoms, the onset, the progression, all of these things that you need to know. I'm rushing through all this, but you need to, in the history, I think we will be talking about it later on. A very important thing is, what is the current functional status of the patient? What about the activities of daily living? What can he do, what he cannot do? Those things are important. Is he attending to his job? Is he taking regular time off, or is he been off work for a few months? All these things you need to know, whether he can squat, use an Indian toilet, whether he can sit cross-legged for all these activities, and things like sometimes there may be just a fatigue pain or fatigue limp, walking distance and all you need to know, okay? So in the past history, sometimes you may have similar episodes in the past, so you need to be aware of that, whether there's been a history of trauma, whether it is a significant trauma. Many a times, a trivial history of trauma, we tend to add that to the, as the causative etiology, and then we run into trouble. A trivial history is often forthcoming, but you should have the maturity to sift the grain from the chaff, okay? So you need to know all that. So coming to the treatment history, whether he's been taking any medication, any long-term medication, particularly in inflammatory disorders or in tuberculosis, they would be on medication for a long time. So you need to be aware of that, okay? So any improvement, has that brought about any improvement in the symptoms? All these things you need to know. So comorbidities are important. Sometimes sepsis in neonatal history, it's important. You may not get a history of sepsis in the hip, but if the patient as a child was in the intensive care neonatal history and had to have antibiotics for a long time, you can be assured that the hip pathology would most likely be as a consequence of sepsis during that period, okay? So personal history, smoking is important, alcohol consumption, okay? Don't call him a drunkard, you know, he's an alcoholic. So that's a very derogatory term. Some examiners will ask you what is the amount of alcohol that you need to consume every day to be called an alcoholic, okay? So I think that may be brought out in the discussions later. I don't have time for all that, so we'll just rush through all that. So some cases, particularly if a patient is short-statured, you can ask about the family history. Developmental dysplasia of the hip can also be familial. You need to ask about that. Even, I think in our area, Perth is also, we have 2-3 siblings having the same problems. So you need to be aware of these sort of familial and bilateral conditions also, okay? So anybody with a limp or deformities in the family, that's important, right? Okay, so coming to general physical examination, most often for an orthopedic case, it's not so relevant, but in a few situations it is, okay? So we generally start off with the vitals, but the stature is important. Perthis are generally short for their age group, Perthis children. Sometimes you may, in a short case or in your even long case, end up with problems like that. And anybody with early morning stiffness or progressive young adult with diffuse symptoms, you have to examine the chest or the chest expansion you need to be aware of. Genitalia, I think what we need to be aware of is that the genitourinary system and the hip joint developed from the same mesonephric bud, okay? And I was caught out by Dr. Benjamin Joseph in my MS exams because the Perthis child that I had also had cryptorchidism, and I did not put my hand onto his scrotum. But there was a surgical scar, and I got away with that because I could remember what I read in Bailey Love. Okay, so that's a different thing altogether. But remember that the development of the hip joint and the genitourinary system has an embryological connection. Okay, so generalized ligamentous laxity is important. So coming to the gait. During our time, we used to describe gait at the end, but nowadays the examiners would want it in the beginning. So I'm not going to talk about the gait because there is a whole talk on that by Professor Matthew Verghese himself. So I will skip that altogether. But it's important that you be very sure of the diagnosis. If it is a little complex, you can say that you're not able to come to a conclusion because it doesn't fit into any particular definitive pattern. The examiners will be considerate with you, okay? So sequentially, inspection, palpation, movements, you're all aware of this, measurements, special tests, and the distal neurovascular examination, and you'll need to look at the spine, the opposite hip, and the knee as well, okay? You're all aware of this, so I'll not rush in, not spend time on this. So you're doing it from the front, side, back. And of course, if the patient is not able to stand for any significant duration, you're examining the patient in the lying position. So you can skip all this altogether, okay? So when you examine the patient, you got to start off from the head, the shoulders, how he is from the front, whether he's keeping the hip in a flexed attitude, level of the ASIS that you can make out, okay, the attitude that I mentioned. In the front, if there are any scars, sinuses, you can mention that. If there is any obvious wasting in the thigh, which often you do see in a long-standing hip case. And then whether the hip is flexed or he is able to weight bear equally on both the lower limbs, okay? And in the standing position, it may be difficult for you to mention about the level of the malleoli, but definitely when the patient is lying down, you need to mention that, okay? So from the lateral side, often we are not able to make out the tip of the trochanter, but you can make out the hollow of the trochanteric region. So you can say that the hollow is well defined, although I'm not able to see the tip of the trochanter, or on inspection generally you will not be able to make out, particularly in the obese patients. So any scars, sinuses on inspection is important. Coming from the back, again from top to bottom you can mention, but if you have already explained in the from the front, you don't need to go for the head, trunk on, but definitely about the spine you need to mention. About the arm distance from the trunk you need, or from the flank you need to explain, and then the posterior superior iliac spines, the gluteal folds, all these things, any fullness, any scars, any discharging sinus, you need to explain all that, okay? So, now coming to the examination proper, when you generally do this with the patient in the supine position, okay, and ideally you stand on the right side of the patient when you're examining. Even if the pathology is on the left side, make it a habit to examine the patient from the right side, okay? So, level of the anterior superior iliac spine is the most important thing, and then once you confirm that, all the points, how to get to the ASIS, how to judge that, we will come to in the case discussions. But then when you come to the hip joint proper, whether there is warmth, whether there is tenderness, again the specific areas will be discussed later in the case presentations. Now the pulse, whether it is equally felt or not, okay? Most often PG say the vascular sign of Nairath is negative. Nairath sign is positive, only positive, it's never negative. Or you just say the pulses are equally felt, okay? Only if it is not well felt, then it's a positive Nairath sign, okay? So coming to the lateral side, you palpate from, many examiners would like you to start off from the lateral epicondyle region of the femur and go up along the shaft, and where you come to the dip, that is the tip of the trochanter. You feel for any thickness, any broadening, any irregularity on the surface, particularly if there's been a history of trauma, you need to know that. If there's any history suggestive of a tumor, you may need to be aware of that, okay? Posteriorly, again, look for any mass, look for any wasting, and tenderness, often described about posterior joint line. You will be asked, how do you identify, where did you palpate for that? So you need to be aware of that. Again, we'll come to that in the discussion. And then comes the movements, okay? So most often, if there is a significant FFD, you finish off the Thomas test in that particular place itself. Otherwise, you can again tell it in the special test, okay? If there is exaggerated lordosis. So you identify the ASIS, you check for any fixed flexion. How you do it, we will we'll tell you later. Again, square the anterosuperior iliac spines to unmask any coronal plane deformities. And then the range of movements. If there is an FFD, at the same go, you flex further and see what is the extreme range of movement that that patient has. So if there's a 20-degree FFD, you say the flexion is from 20 to 80 or 20 to 100, whatever that is. Finish off the flexion at that go itself, because if you drop it down and again you start, it wastes time, it sometimes annoys the examiners, particularly if you are the last candidate on that day. So all sorts of discussions come in, okay? So always talk about active as well as passive movements, very important, okay? And then as regards the rotations, both in extension as well as in flexion. If there is a differential, We will discuss again why do you have that differential rotations. Look for axis deviations if there is a significant amount of flexion in that particular case. If it's a flexion is very restricted, you can't really comment about the axis deviation. But anything beyond 60 degrees flexion, you could actually say that the hip, there is axis deviation. Okay? So in axis deviation, you all know that the shoulder moves away from the, the thigh moves away from the ipsilateral shoulder. Okay? So coming to the measurements, you measure the limb length, you measure for the muscle wasting, all these things. Apparent length, true length, all of that you need to know. Apparent length is what you are measuring with the patient in a position of comfort from a fixed position, preferably from the xiphisternum, not from the nipple or the umbilicus. Okay, umbilicus generally, because it's variable. Xiphisternum is a fixed point, so you measure as the patient is in whatever position the patient is lying with the limbs identical. But a true measurement, you do it after squaring the pelvis. You measure one side, then the opposite side, you put it in the identical position as the fixed deformity, and then you take the true measurement. Okay? Right, so just to mention what is an apparent length that you measure from the xiphisternum, whereas a true measurement is always from the anterior superior iliac spine to the medial malleolus. Some cases you may have to take a differential measurement, femur separate, tibia separate, because there may have been a fracture in the past, okay, or some other congenital issues may have been there, so that you need to do differentiate. And also you need to be aware of what is the supratrochanteric shortening. Even if when you're taking a differential measurement, you need to be aware of that. Okay? So if your true shortening equals your apparent shortening, obviously that means the pelvis is square. So don't make a mistake. If you have said that the pelvis is square, both the ASIS are at the same level, then the true and the apparent measurements will be the same unless there is a true shortening. Okay? But if in a fixed adduction deformity, the true shortening will be more than the apparent shortening. So these are few things, because even if the examiner is not paying attention to the rest of the story, if you make a mistake here, he'll suddenly get up and go and examine or ask you to explain it again, okay? And in a fixed adduction deformity, the true shortening is less than the apparent shortening. So these few things, you need to be aware of that. If you make a mistake, then the examiners may not be that reasonable. Okay, so you need to be aware of what is Galeazzi sign. If there is a shortening on the femoral side, what happens? If there is a shortening of the tibia, what happens? How do you identify that? You need to be aware. Okay, so for measuring the Bryan's triangle, you have to square the pelvis and then you compare with the other side. Bryan's is always in comparison with the supposedly normal side. Sometimes you may be caught out because the other side, what you presume to be normal, may also be affected. Okay. To a lesser extent, maybe. Okay. So coming to the interpretation, if the base is shortening, that means there's a true shortening. That means there is an overriding of the trochanter. Obviously, the neck may be shortened, or there may be a dislocation. Okay. So sometimes you get these septic hips in pediatric condition. In a pediatric age group, they may have had sepsis, and then they've been limping all their life. In an adulthood, they come to you and the trochanter is high riding. Often there is a reluctance for the candidates to say that there's a reversal of the Bryan's triangle. Particularly if the shortening is 5-6 centimeters, definitely you cannot say that the Bryan's triangle, the shortening is only 1 centimeter. That is a very gross error, and the examiners will be very, very unhappy when you make that sort of a mistake. So don't be hesitant to say that the trochanter is riding very high. I cannot make out the Bryan's triangle in this, or there is a reversal. Like in this situation, this tip of the trochanter is far too high in the pelvis to say that, you know, the Bryan's triangle is just 1 centimeter short or whatever. Often this has been the case in the teaching programs that we have seen. So don't be hesitant to say that the triangle is reversed. Okay. Sometimes it may be difficult to actually gauge how much is the shortening, but when you measure from the ASIS, you can tell that's the shortening that you have. Okay. So these are just a few things. I think we don't need to know that. But sometimes if there is a protrusio of the pelvis or there is a old central fracture dislocation, the hypotenuse of your triangle may be shortened. Okay? And I think one of the ways to clinically know that is your Morrison's bitrochanteric test. One side, the affected side, will be shorter than the other. I think that may be clarified during the discussion. Okay, but many a times we tend to overlook Morrison's bitrochanteric test, but that is, the protrusio is one condition where that particular test will help you in your diagnosis. Okay, so Bryan strangle, like it's in bilateral hips, it's difficult, or you can say that you cannot make out because it's a bilaterally affected hip, and you have to rely on, I'll come to that, Nellerton's line. This is an independent test for both hips. So you can make out, you all know how to draw the Nellerton's line from the ischium to the ASIS, and the trochanter is always below. If it is at the level or overriding, then you know there is some shortening there, okay? So you can do this for bilaterally affected hips. This is independent of the hip, which side is involved, okay? Right, okay, so just run through all these for completion's sake. So generally the Schumacher's line, it meets in the midline above the umbilicus normally, okay? So if there is a coxa vara or overriding of the trochanter, it meets on the opposite side, like you can see here, okay? And if it is bilateral coxa vara, it will meet maybe in the midline but below the umbilicus. That's what you need to be aware of, okay? Normally it meets in normal hips above the umbilicus. Okay, so the Chien's test or Cheney's test, whatever you want, whenever there is a coxa vara or shortening, that side will be shorter. The parallelity is lost there. Okay, it will converge on the affected side. This is the Morris bitrochanteric test. Just quickly, ideally you have to measure it with calipers, but if you don't have, 2 record books or whatever you keep on that side and you have a measuring device, you need to help to measure that. Okay, so the affected side may be longer there, but in protrusio it will be shorter. Okay, the special tests, these are the 3 T's: Thomas test, telescopic and Trendelenburg. Okay, so Thomas test, again unilateral hip and bilateral hip. I think during the case discussions we will tell you. I will not hold up your case discussions for too long. How to test? Always keep your hand under the lumbar spine. Even when you're pushing the leg down, don't remove this hand because you don't know how much wavering happens. Okay? If at all you want help, particularly with the bilateral, you keep your hand there, get an assistant or some relative to help you out with extending the hip. Okay? So that's generally how that is done. You see the hand that's a bilateral one. You see the hand, you can see there, that hand remains there till you have confirmed how much it is and till you have explained to the examiner what is the true this thing. So you push the leg down and push the other leg down and see how much that is. In bilateral, easiest way, flex up both the hips and then you do sequentially one hip at a time. Again, keep your hand under the lumbar spine. It is difficult in bilateral cases, so you ask for help to hold the hips in flex position and then gradually drop one leg after the other sequentially. This is in pediatric patients you can do this, but not in adults particularly. It's very cumbersome to the patients. It's not easy to do in an obese individual, okay? So the telescopic test, you all know, flexion to 60 to 90 degrees, adduction, and then you hold with one hand and the other hand, one thumb is on the ASIS, your tip of the finger on the trochanter, and then you put axial force and you pull and push. Okay, so right. So in generally a dislocated hip or in a fracture dislocation hip, you can get this. Okay, in paralytic cases also you may get that. Okay, so ideally you need to have the patient to be able to stand independently for 30 to 60 seconds to actually say that Trendelenburg is positive or not. If the patient is not able to stand, you're lucky. You can tell the examiner, sir, the patient is in a lot of pain. I could not elicit that test. So that's okay. But you may have to correlate that with your other physical findings to tell whether the abductors are functioning or not. Okay? Right. So the sound side sinks. That's what you need to remember whenever you're doing the test. When the patient stands on the affected side, the sound side sinks. Okay? So just to, for completion's sake, what are all the other tests? The Stinchfield test. Now people talk about straight leg raising test and all that. So it's straight leg raising generally you talk about in a spine. Here you're just asking whether the patient is, the lever mechanism is intact or not, whether the patient is able to lift his leg up or not. Okay? So those DDH, Barlow's and Ortolani's, most of the time you will not be kept cases that young because the children will not cooperate and you will cause more discomfort, and ideally repeated tests are not recommended in DDH. Okay, so in CP, the prone rectus test or the Duncan-Eli's test you need to know. Ober's test in contracture of the ITB. Okay, the impingement is now a favorite exam case. So you need to know about flexion, adduction, internal rotation there. Okay, and of course, most important, in a suspected Angst-Pond, don't forget to do the modified Schober's test. Okay, so early morning stiffness, chest expansion, modified Schober's test, and a stiff hip, you have to give a differential of that. Okay, so with that I think I will conclude. None of my videos are running luckily, and Dr. Matthew Verghese is waiting next in line to finish off the gait there. So yeah, okay, at the end, don't forget distal pulses, the neurovascular exam, lymph nodes, and the opposite hip and spine. Okay. Then you come to the summary, brief history, summarize your clinical findings, come to a differential, the duration. You need to give the anatomical, the etiological, anatomical, and the pathological diagnosis, right? That's what is expected of you at the end of the examination. Okay. And then a broad outline of the management. If you have done very well, then Professor Rajesh Malhotra will ask you whether what bearing surfaces you will use, ceramic on ceramic, metal on metal, all those things can be asked. But that, if you are asked those questions, be sure you are in running for a gold medal. Okay? So keep calm and all the best for your exams.
Thank you so much, sir. It was a truly wonderful talk with covering all the important points on hip joint examination. Now I'd like to request Dr. Edward Nazareth, KOA President, to felicitate Dr. Ajit Kumar. Now the next talk would be on gait analysis by a man who needs no introduction. He's come all the way from Delhi for our IOA PG teaching program. I'd like to welcome Dr. Matthew Verghese for his talk on gait analysis. Welcome, sir.
Good morning, everyone. It's a pleasure to be here. And thank Dr. Mallikarjuna and my ex-resident Jasjeet for persuading me to be here. I've been trying to avoid travel for personal reasons. But I'm here before you, straight from the airport. Gait. Coming. For postgraduates, as you just heard, hip examination is going to be one case that you're going to do. And if hip examination is to be done, gait is a prerequisite for you to understand and analyze. Most students like to keep it at the end because they are scared. They're scared that they'll make a mistake and they'll start on the wrong foot. And if they start on the wrong foot, the whole thing can go haywire. Therefore, they hold it for the end. But in the end, many a time they forget because they've had so many back and forth questions. They forget to tell. Then the exam, oh, you didn't mention about gait. Oh, sorry, sir, sorry, sir. An apologetic gait description comes. So there are two ways of describing a gait in the exam. One is to have an eponymous gait, which is so obvious. A Trendelenburg gait, a waddling gait. So it's very easy to say. But at times you're not sure. Because the patient may have a combination of conditions and therefore it may not be a classical eponymous gait. Therein comes your difficulty. Then you have to go and describe the gait. So if you're not sure, it's safer to describe the gait rather than end up in another disaster. After all that you went through in the physical examination, the Thomas's test and the Morris's bitrochantric, you end up with the actual difficulty in describing the gait also. So most people do not know how to describe. So the first thing is, you have to know normal human gait. They say, the purists describe, to understand the pathological gait by observational gait analysis, you should have examined 300 consecutive known diagnoses of pathological gait. 301, not easy. So in the OPD, before you look at the X-ray, before you examine the patient, try to get to an understanding of what does this gait look like. And I keep doing it case after case. And then look at the X-rays, then you have an idea what this patient has. And you'll have a little confidence in making a diagnosis on the gait. That's important for you. So normal human gait, for every human being, for his BMI, for his height, for his weight, for his body dimension, you can make it a unique gait. So by looking at a person walking in the darkness or in the twilight area, you will still find, you can make it out, oh, that's Dr. Anil walking, or that's Matthew Verghese walking, or Dr. Mallikarjuna walking. So you can make out by just the pattern. They are all normal gaits. They are all normal gaits. There are variations in that normal gait which allow a uniqueness for that individual to be identified. And that normal gait is a repetition of sequence of events in your lower limbs and also associated movements in your upper limbs and your trunk. It is the initiation and cessation of gait which is in your conscious domain. Gait as such is a reflex repetitive activity. It is not in your conscious domain. If every step is in your conscious domain, that's a pathological gait. Every step, for a cerebral palsy child, every step is an effort. Every step that the child is taking is an effort. So every step is a conscious effort, is not normal gait. It is initiation and cessation that is in the conscious domain. Otherwise, it is a parietal lobe function and we keep repeating it reflexly. The animal kingdom, the quadruped world, they are far more stable. They are far more fast than the bipeds. What we have lost is stability. They are far more stable than us. They also are far faster than us. So I always tell children that are scared of dogs, don't ever outrun a dog, because you can never outrun a dog, because a dog evolutionarily designed to run faster than you. It can run faster than you. You can never outrun the dog. The only difference is that fastness of gait, whether it is a dog or a horse in a race course, it is fast running not because of quadriceps. Remember, it is fast running because of the hamstrings at the back of the calf. That's why this portion of the dog is, or the horse is the fattest, because it's the bulkiest muscle. It's the most powerful muscle which provides you the powerhouse for walking. Whereas, and that's why the expression hamstrung. In race courses, they have that horse is hamstrung, because the hamstring is pulled and therefore the animal is hamstrung and not able to run. The bipedal stance, now they're looking at genetics of evolution of bipedal stance, when it did evolve. 4.5 million years back, this is the first footstep of the hominids that are there. And as we evolved, we moved from this posture to this posture. From the crouch posture. So primates have a crouch posture. Human beings do not have a crouch posture. And therefore, how did we get that final gene to get that vastus medialis, which allowed the final extension of the knee? When students present in the exam, a hip case or a knee case, the vastus medialis, sir, wasting is there. So where do you look for the wasting? Vastus medialis. Why is it wasting first? Sir, it is the last muscle to evolve. But why should it waste if it is the last muscle to evolve? The reason is this. The last muscle is involved in the final extension of the knee. And therefore it is the first muscle, because when you have a flexion deformity of the knee because of a hip or knee pathology, that final extension does not happen and therefore it wastes rapidly. So this is what you need to understand. So there are logics behind everything that is happening in your gait cycle. But for a normal person to walk normally, there are certain prerequisites. And what are the prerequisites? You should have the ability to stand stably. If he is unstable, if he doesn't have the balance, he will not be able to walk. Second is, he should have the motor power, the power to progress forward or backward to whatever way he wants to. That's the means of progression. And thirdly, the way he progresses, everything is in nature is designed to conserve energy. Whatever we do is designed to conserve energy. If we have to spend more energy per step, then that's not a normal. Again, the same thing happens in a spastic child. The child may be able to walk little slow, like a slow walker. But the energy consumption of a spastic, to overcome the spasticity of the opposing muscle, which should relax in conjunction, does not happen. So the per step or per step length energy consumption is higher. So all three components, stability, motor power for progression, and energy consumption, are all key components of a normal gait. And when you're describing the gait, you want to describe, is the patient stable in his stance? Is he able to pre-position his different joints appropriately, or is he doing it inappropriately? So if a patient has got a foot drop, he takes it up and down. It's okay. But if he has got an equinus, the pre-positioning of heel strike is not possible. So the pre-positioning tells you whether there is a deformity of equinus or is it a foot drop which comes with swing phase. So they are completely different. The pre-positioning is the equinus which prevents a normal pre-positioning. So you need to know the deformities to tell you about pre-positioning. Whether the clearance is possible to move the foot forward, the swing phase, if it is not possible because of foot drop or equinus or some deformity, again, or knee arthrodesis, again you have foot clearance problem. And if you are not able to take a reasonable, if it is a long step, that's energy intensive. If it is a short step, try walking short steps. It's energy intensive, that's not normal gait. So every human being for his BMI has a normal step length. So that step length has to be understood by you, and again the bottom line is energy conservation. For description purposes, every gait is divided into two parts, a stance phase and a swing phase. That's pure description. But when a person is walking, he is not looking at stance and swings, he is just walking reflexly. Initiation has happened and rest is reflex. He doesn't think about it. But when you look at the gait cycle, you have these heel strike, foot flat, mid stance, heel off, toe off, and then the swing phase down. 60% is stance phase, 40% is swing phase. But purists say, no, it's not 60-40, it's 38, 62. It's approximately that, but it's the same thing. But then let's look at the stance phase. The stance phase, the first thing that you have is the heel strike. The heel is the one which strikes first, then the foot flat. Foot is flat on the ground, and then mid stance. So what is the difference between foot flat and mid stance? In foot flat, there is no load bearing on the foot. It is only when you have mid stance coming on that you have load bearing comes. So when you have load bearing, it is only then that quadriceps need to function to prevent buckling of knee. So foot flat does not need quadriceps function. It does not need quadriceps function. Foot flat is without quadriceps function. But the moment load comes and the CG is behind the axis of the rotation of the knee joint, you have the need for quadriceps to be initiated. So that is why the foot flat and mid stance difference must be understood. So first 10% is foot flat, from heel strike to foot flat. From 10 to 30% we have the stance phase. Beyond that you have the stance phase continuing, but there you don't need the quadriceps again. Just see that. I have heel strike, foot flat, mid stance, go on, my body is moving forward. As my body is moving forward, the axis of weight bearing comes in front of the axis of rotation of the knee joint, so it doesn't need the quadriceps at all. So you don't need the quadriceps throughout the range of the mid stance phase, remember that. It's only part of the mid stance when load bearing is there and the axis of weight bearing is, the center of gravity is falling behind the axis of rotation of the knee joint, that you need the quadriceps. Rest of the time you don't need the quadriceps. That's an important thing for you to understand. Then you have the heel off and the toe off. That toe off part is a very important part, because if you remember, look at the leg, the way it is designed. It is designed to have a bulky calf at the back, and like those animals, they had those hamstrings that were bulky. Here we have the calf muscle that is really bulky, which is balanced by very measly anterior compartment muscles. How did nature do that? Nature did that with lever arm efficiency. The anterior muscles are balanced by very long lever arm from the axis of the ankle joint to the toe, whereas the powerful calf is disadvantaged by a short lever arm. But this powerful calf is your powerhouse for gait energy. The push-off phase, the pushing off happens from the calf muscle, the gastrocnemius. So that happens from the gastrocnemius. So if you have a gastrocnemius paralysis in a polio patient, that gait is a terrible gait. The patient walks without any push-off. So that push-off becomes very important if gastrocnemius is paralyzed. For sciatic nerve palsy, it is paralyzed because of poliomyelitis or for any other reason. So you need to understand that. Then the swing phase. Swing phase, again, fairly simple. You move, I've moved from there, I'm swinging quickly to come to my body level. Why? Because I have to move quickly to make sure that my body is, parts are close to the center of gravity. Further away body parts are from center of gravity, more energy intensivity. So I quickly bring it to the center, stage of acceleration. Then mid-swing, and then slowly bring it back to the slow, because I want to conserve energy there also. Slowly bring it down to the heel strike stage again. So the swing phase again arbitrarily divided into 3 temporal time phases of acceleration, mid-swing and deceleration. Well, there have been debates on whether you should do this way or you should make the 2 phases of the stance and the swing phase have symmetrical phases, subdivisions. So which is initial contact, loading response, mid-stance, terminal stance, 4 components. Pre-swing, initial swing, mid-swing and terminal swing. But it never got popular, and gait cycle descriptions always have the same level. But as a postgraduate, your job is to recognize
what are the limits of range of movement for each joint to achieve normalcy of gait. If a patient has got a flexion deformity of restriction of flexion beyond 40 degrees, can he have a normal gait? So you need to understand that. Will this gait be normal? So if he has a deformity of the hip, can he have a normal gait despite a deformity of? Yes, it is possible. So if you know the pre-positionings and the limits of range of movement for a normal gait cycle, then you will understand. So it's important for you to know, in a normal gait, at heel strike, hip is at 25 degrees of flexion, 15 to 25 depending on the body build and the step length of the patient. 5 degrees of flexion, it's never full hyperextension. It may be a little degrees of flexion and 0 degree at the ankle. That's heel strike positioning. When you move to the next level at loading response, the ankle is 10 degrees, 15 degrees at the knee and 25 degrees still because the knee is gone into, you wonder how is it 25? It's 25 because there is 15 here. It's flexed there. So therefore it remains at 25. You move a little further, that's the comparison between the two. Just to help you understand that, the moment you have mid stance, hip is 0 degree, knee is 0 degree, ankle is in 5 degrees of a little dorsiflexion. So that's dorsiflexion at the ankle. And as you move further, you have hip in 15 degrees of extension, knee again in 0 degree, ankle in 10 degrees of plantar flexion. So the way that it moves, it gives you a clear idea. Then you have pre-swing. In pre-swing, you are toeing off, ankle going into plantar flexion. Knee goes into 40 degrees and hip is again at 0 degrees from 15 degrees. When you go further, initial swing, the angles are 10, 60 and 15. So can make out very quickly what are the limits. So you have to have 60 degrees of free flexion of the knee joint for a normal cycle. If you have that, you can manage. Don't worry. If you can't bend to 90, don't worry. 60 you can have a normal gait. From 60 to 90, if he has a flexion deformity any component, he will still have a normal gait, don't worry. You can reassure the patient, you walk normally, but you won't be able to squat. Yes, that's a problem. But you will walk normally. So that's a reassurance they can give once you understand this. So you need to have a little extension of the hip with 25 degrees of flexion of the hip, you can have a normal gait. You don't need beyond, you need all this only for squatting and sitting cross-legged and sitting on a chair. Rest of it is not for the normal gait cycle. So this is an important understanding. So if you were to look at this, again, I'm showing it again for repetition's sake, but when you do this repetition, that appears as if the person is walking. I have put everything together and animated it. It looks as if this cartoon is walking. That's exactly how cartoons are made. The cartoonist draws sequentially advancing movements of the same limb, rest of the body remaining same. I did the same thing and that looks a normal, it's a brisk normal gait because the video, the way it was animated, it became brisk. So that's important for you to understand how you evolve a normal gait cycle. We've broken down for analysis sake, but normal gait cycle is reflex, not in your conscious domain, is energy conserving, and you need to know the pre-positioning positions of the joints to be having a clarity. The second thing you need to understand about normal gait cycle, the pre-positioning of the foot. So for normal gait cycle, we need to have 3 rockers. The 3 rockers are at heel strike, the heel is striking the ground. The heel rocks on the ground like that. Then you put your foot down. So now the foot is fixed on the ground, it can't slide back and forth. When the foot is fixed on the ground, the tibia now rocks on the dome of the talus. Can you see that? The tibia is rocking on the dome of the talus. And then you have heel off. And from now what is happening? There is another rocker which is coming into play, that is at the tarso-metatarsal joint. So for a normal gait cycle, you need to have all 3 rockers operational and functional. Heel rocker, the tibial dome of talus rocker, and the metatarsophalangeal rocker, all 3 are critical for a normal gait cycle. All 3 are critical for a normal gait cycle, just remember that. So in observational gait analysis, the patient should be able to walk for several minutes. Preferably at least 15 steps is what we recommend in observational gait analysis. Don't get him to do 2 steps and analyze gait. No, you can't do that. Don't do that. It's a mistake. You cannot get a clue. Walk around 15 steps, select the affected limb, walk several times back and forth. Get him to walk towards you. Get him to walk away from you. Get him to walk from right to left. Get him to walk from left to right. All 3. Why? Because human eye has a certain limitation and your brain has a processing time. And for you to understand the true dimensions of components of the hat segment, the head, arm and trunk, it's called the hat segment. Head, arm and trunk segment and the lower limb component takes a little processing time. So you need to watch the hat segment, you need to watch the hip, knee, ankle, front, side and back, again and again, back and forth, till you get a clue, okay, this is what it is. So this is what the patient is doing. To get that hang of how to do the walking and how to analyze the walking, watch from side, front and back, over and over again till you're certain. If the patient cannot walk, then you say, sir, this patient cannot walk, it's too painful, I did not make it walk. Say that, that's okay. Or if he needs a stick to walk, sir, he needs a support. I need to give him a stick to make him walk. He couldn't walk without a stick. Fine. If he is wheelchair bound, is not able to stand, sir, he cannot stand, he cannot make him walk. No problem. Your gait situation is, you will look for other ways to score marks. But your ability to prove your strengths in gait is again back. Be happy that you are able to describe and narrate gait in a better way. Observe the speed with which he is walking, observe his stability, observe the consistency. So if he takes few short steps, then he walks fast. So spastic cerebral palsy children, that's a very large topic. I'm not going to take that now, but I'm just giving an example of consistency. What do I mean by that? So a cerebral palsy child will observe the environment around. So when he is starting the position, I see there is a table here, I see there is something here, and I can hold on to it. I have poor balance, so I'll walk slowly here because I know if I'm falling, I'll manage. But there's nothing in between till I reach them. So what will I do? Remember, slow cycling needs more balance. Fast cycling is intuitive balancing by the dynamics of momentum itself. So a coin rolls fast and it keeps vertical. The moment the coin starts rolling slowly, it falls. So slow walking is more difficult, and they will do that cautiously when they know there is a support. The moment they know it is opening, they will run. So the patient will come, sir, ye daudta hai. He runs, he doesn't walk slowly. That's a complaint these children will say, that's poor balance. Just from the history you can make out it's a poor balance for the child. He is not able to balance, and therefore he is stopping using the forward momentum of his gait to balance himself. That's the consistency thing which you need to look at. And if a spastic child has got a tight hamstring, he will take short steps. A Parkinson's patient with extraspinal spasticity of the quadriceps and the hamstring will take very short steps like that. The limitation of the step length is based on the body dimension of the patient, number one. Number two, the tone of the muscles, which are concentric contractures and eccentric contraction muscles. So a lot of people ask, what is concentric contraction and what is eccentric contraction? People don't understand. In physiology we were taught this, but we don't remember it. So if I have to climb my step from here to here, the quadriceps is concentrically contracting. So when I am climbing a step up, going up, quadriceps is contracting every time I am stepping up. But I am stepping down. Is the quadriceps contracting? Yes, it is. It is contracting. Flexion is happening, but it's a controlled flexion. That contraction of the quadriceps, which is not producing the movement it is supposed to do, but allowing the opposite movement in a controlled manner is eccentric contraction. So in muscle spasticity, when the muscles of the opposing group, the other phase muscles, so phasic muscles and non-phasic muscles, when they are both spastic, your step length will be affected. So you need to understand why is he having a short step. So when you're describing, he's having a short step, poor balance, rapid walking gait. You need to analyze every sentence has a meaning. Every sentence has a consequence behind it. So you need to understand that, and then the way you move. So many people you see, you just have to stand out on the street here. I think Bangalore will a lot of people walking. The way people walk, when you walk like this, when you walk like that, when you have all kinds of associated movements, the pattern varies, depends on how their brain is hardwired for that. So the upper limb movements is an important part. Many times children are diagnosed as having monoplegia. They are sent to me, sir, equinus hai, baaki sab normal hai. Right hand dominant child, left hand is also good, nothing, everything looks fine. What do I do then? Monoplegia as such is very rare, extremely rare. Monoplegia is extremely rare. It's a very rare condition. If you diagnose monoplegia, think again. So what do? I get the child out onto the corridor, get the mother, आप इसके साथ दौड़ो, दूर जाओ और दौड़ने के लिए बोलो. The moment the child runs, he'll do this. Hand is stuck to this. The associated movement of the paralyzed limb is not there. So that will become manifest, and even if you do upper limb surgery, Dr. Anil will bear me out on this, even if you do muscle balancing surgeries for this, this reflex activity of running and walking, of the associated movements, because that's another part of the brain. It's not the conscious motor function. It is a reflex function in another part of brain which is more primitive in evolution, and that remains. So they will have lack of associated movements. So please check that. That will be a clue to whether the child is hemiplegic, diplegic, or whatever. Then the question, gastrocnemius, yes, you have triceps surae is working. So you say, sir, he's got an equinus deformity because triceps surae is contracted. Okay, triceps surae is triceps. Gastrocnemius, two heads, and the soleus muscle. So we were taught in anatomy that the postural muscle. I crammed it up. I never remembered, understood. I remembered it to the postural muscle. Anatomy professors would ask me. I was not bad in anatomy, if I remember correctly. But I crammed it up. Honestly, I didn't understand till I saw this picture. When you see this picture, it's very clearly understanding. So when you're standing quietly, is your gluteus maximus working? I'm standing quietly. Is your gluteus maximus working? Why? Why is it not working? Your center of gravity is an inch in front of the sacral two vertebra. At that level, your center of gravity is behind the rotation of the hip joint. Hip is naturally stable in extension. You can't extend it beyond. If only the CG had been in front, which will happen if there is a flexion deformity, it will tend to collapse. Now, because the CG is falling behind the axis of rotation of the hip joint, your hip joint, gluteus maximus is not needed. Again in quiet standing. What happens in quiet standing? The final extension is vastus medialis. But is the vastus medialis functioning in quiet standing? It is not functioning. If you remember anatomy again, screw home movement of the rotation, internal rotation of the larger overhanging femoral condyle onto the tibia is happening. When that happens, it is alignment stable, it doesn't need the quadriceps. Popliteus comes in to unlock the knee. It unlocks that locked knee. A locked knee does not need quadriceps. So quiet standing, you do not need the quadriceps. Again, in that screw home movement, what has happened? In that screw home movement, the CG has come in front of the joint. That is why it is called alignment stability. CG is front of the axis rotation of the knee joint, so it won't buckle. But what has happened to the CG now? As you go down from above here, it is advantageous, it is behind, no problem. Here, again, it is advantage, it will come in front of the knee joint axis, it won't collapse. But in the ankle, it has come in front. So if it has come in front, what is going to happen? So if the weight is in front of my ankle joint, I'll tend to fall forward with the ankle going into dorsiflexion. To prevent that falling forward, the soleus muscle pulls your tibia backwards. It's a one joint muscle. It's not a two joint muscle. When it contracts from its insertion, pulls the tibia back and prevents the ankle from going into dorsiflexion and prevents me from collapse. So the only muscle which is active in quiet standing is the soleus muscle. The only muscle which is active in quiet standing is the soleus muscle.
It's fascinating, no? The way we analyze it and understand it. So it's only when the CG is behind you need the quadriceps, otherwise you need the quadriceps. So in different phases, you need to know which muscle is active. And that is the whole idea of understanding and analysis. Then the question of, is the patient walking or running? So if you have watched Olympic Games, when they're having these marathon walkings, they have videos all over. Just to check, is a player cheating? Is an athlete cheating? So a brisk walking can be faster than slow running. But you need to know, is the athlete cheating? How do you know that? You need to know the difference between walking and running. In walking, there is always a phase of double support. Both feet are never off the ground. Whereas if I am running, both feet are off the ground at one stage. So running has a phase of double swinging, whereas walking has a phase of double stance. It will never have double swing. So just by looking at the slow motion video, you can make out that is the patient walking fast or is he running slow? And for analysis, you need to know in which phase of the gait cycle which muscle is working. And that's what is reported in gait analysis. In instrumented gait analysis, you have a recording of which muscles are working, which muscles are not working, which joint is flexing, which joint is extending, which joint is moving the normal range, which joint is not moving the normal range. So the full pattern is understood in an instrumented gait analysis. So instrumented gait analysis has essentially 4 components that are analyzed. One, the video recording and the slow motion video, front, back, side, all over. Videos all over. There is a floor on which, a track on which the patient walks. And the track has force plates on it. A force plate is a transducer. When a person stands on that force plate, depending on, so at heel strike, only the heel will be recorded. Then the foot comes down, the rest of the foot comes in, and heel off and toe off, depending on how he is placing the foot, how he is moving the force, load distribution on the sole of the foot, it will get recorded in the force plate, transmitted as electrical energy to a cathode ray screen, and now of course an LED, LCD screens, and you can record it as a graph, how much the force is changing. So that's the second component. The third component is they have the joint position markers. So different parts of the body are marked. So there are little these markers. Can you see the little markers that are there? That will show you those markers are there. So we know by looking at this and how they move in space, how these markers are moving in space. So look at this child. She has got all these markers there and she's walking. She's got bilateral, severe equinus. So pre-positioning is clearly an equinus to equinus gait. There is no heel to toe strike. Bipedal gait is there. It is an independent gait. Again, remember, you cannot do instrumented gait analysis unless the patient can walk independently. So don't send a child who is walking with crutches for gait analysis. You won't be able to do it. They won't be able to do it. A child who is walking independently can be sent for gait analysis. So you look at these patterns and then you can make out in space how are these points made. So you can have a 3D dynamic recording of how they are moving in space, 3-dimensionally. And you can do the whole workup on a computational thing. So you look at the side, look at this. As the gait cycle is progressing, as the child's heel off is progressing, the equinus is increasing. It's clearly visible there. So we look at different patterns. And we also look at the last thing, the fourth component that you look for
is the EMG recording. So we have a telemetry of some of these things, recording which muscle is active in which phase. So you have the recording will always give you a graph of the normal versus the right and the left side separately. So you will have the motion analysis, you have the moment analysis, the moment of force, and the power generated analysis, which will be analyzed. This is Gait analysis. Was a very expensive setup, cost 2-3 crores, cost has come down to 50-60 lakhs. This is the Gait analysis lab in CMC Vellore. When I visited that, there I took their permission to take this recording. Again, you're not enough. You may have a broad base gait. Remember your high school physics? Broader your base, more stable you are. Less stable is the narrow gait. So anybody with a poor stability will have a broad base gait. So your distance in a normal human being is a 5 to 10 centimeter distance that is there. 50 to 100 mm is the gap between the distance between the centers of the two progression. So a normal gait cycle is defined as the time from heel strike to heel strike. From one heel strike to the other heel strike. That's a gait cycle. On the other hand, I have cadence. How many steps I take in 1 minute? That's cadence. Then you have the stride length. So stride length is the distance from toe to toe or heel to heel of the foot. So from heel to heel. That's from heel to here, that distance is the stride length. Whereas distance your foot travel from toe of one foot to toe of another foot is the step length. So there are different terminologies, familiarize you with that and be clear on what you're talking about. So the examiner might ask you, what about the cadence in his gait? What is his stride length? Is it normal? Is it abnormal? And again, speed, there is a standardized method for evaluating that. I've given the reference also, but we hardly ever do that. This is all for research work. So if you're doing a research work in a particular gait analysis, in a particular disease pathology, then you need to have this protocol of a 10-meter straight line walk, use the timing, start and end, and then look at it. Again, as I said, energy conservation is an important aspect of normal gait cycle, and every time your center of gravity needs to be going up, that's a energy consuming act. Every time your center of gravity is elevated, it is an energy consuming act. Every time your center of gravity is deviating from side to side, that's an energy consuming act. Because every deviation causes a lever arm multiplication of forces, so therefore an energy consuming act. So body walks with least excursion vertically and horizontally. Both are important for a normal gait cycle. Least excursion vertically and horizontally. That's important. So an abnormal gait depends on whether the patient has pain for whatever reason, has an impaired motor control, has an abnormal joint range of motion, and also has sensations. Remember, your motor control comes from biofeedback, constant feedback loops. So my ability to do a reflex walking is based on the fact that my brain knows intuitively, now it's in mid-air, now it's in mid-swing, now it is reaching the heel strike phase, I need to do this activity. The loop has to be intact, not just the motor loop, the sensory loop also. So a tabes dorsalis patient or a patient with syringomyelia or one of those conditions where there is posterior column problems, then you have a patient who will take a step, but he will take it beyond the normal because his biofeedback is not good, loop is not good, and he'll stamp his foot down. A high stepping, foot stamping gait is typical of a tabes dorsalis, very rare these days. So what do you see more commonly? A paraplegic, lumbar spine, cauda equina syndrome, selective paralysis of that group of muscles, and they'll have high stepping, foot stamping, because they neither have the sensory feedback nor do they have the motor to do the foot in the swing phase elevation. So that's what is important for you to understand. Again, don't confuse between the limp and a lurch. Limp is an English language dictionary word which describes any anomaly of normal walking pattern. So I have a limp. It is an abnormal walking pattern, deviation from normal. The reason may be whatever. It doesn't tell you that. The moment you use the word lurch, it's a completely different, it's a very technical term. Lurch is an axial rotation of the trunk during part or whole of the gait cycle. Okay, of the stance phase of the gait cycle. So,
am I running out of time? Am I running out of time? Okay, so I'll quickly give some examples and move on. So, limp is any deviation, can be because of any of these reasons. Okay, whereas a limp is never normal, again remember that there has to be some cause for it. Whatever be the cause, it is there. An antalgic gait
is, algesia refers to pain, antalgic gait refers to a gait trying to avoid pain, antalgic gait. So, what happens in an antalgic gait? So, what will happen if I have a TB hip on the right side and I put weight, it hurts. So, what will I do? I put most of my weight all the time on this side and keep this weight bearing to the minimum. So, stance phase has to be reduced. That's the first component. So, if you say antalgic gait and you say stance phase is equal, then you're completely off the mark. It has to be reduced stance phase is the precondition to step in and say this is an antalgic gait.
Okay, you have shortened stance phase.
So, when this is shortened, what is the corollary? So, if this has become 20%, then the swing phase has to be 80%, isn't it? The stance phase has become 20%, the swing phase has to be 80%. So, 80% of the load, this becomes the stance phase. From 60 it becomes 80, and correspondingly the swing phase goes up. Again natural, unique.
That's a natural corollary, isn't it? So, you always lurch to the same side.
Again, confusion among postgraduates, whether you lurch to the same side or the opposite side. So, when I have seen this in almost 25 years of examinations across the country. So, he has a lurch. So, he is an antalgic gait. So, which side is he lurching? Sir, to the opposite side. So, Trendelenburg side, where does it? Sir is lurching to the same side. So, the commonest mistake both guys make is a lurch to the opposite side in one cycle and a lurch to the opposite side in another gait cycle, which is abnormal. Please remember, human being designed as, consciously we may do all these energy catastrophes that we are doing now and seeing the consequences, but evolution doesn't look at it that way. Evolution conserves every calorie. So, evolutionary, if you look at the normal gait positioning of the hips and the center of, sorry, this is not working. The center of gravity is there. This is the head, center of head. This is the lever arm from here to here. When you're standing on this side, this whole side is unsupported. So, the center of gravity is eccentric. When the center of gravity is eccentric, this side tends to collapse. To prevent this from collapsing, the pelvis dipping, the gluteus medius from here starts acting from its insertion and pulls the pelvis back. So, that is what is happening. So, when you lurch to this side, what happens? Him standing on this side, you're lurching to this side. What happens? The center of gravity moves this side. Lever arm increases. When the lever arm increases, the counterbalancing gluteus medial forces increase. Total force on the hip is increased. So, pain will increase. There is no way a person in his right sense, unless he is a masochist, he would like to deviate to the opposite side. He will always lurch to the same side as the pathological side. Always. Whether it is an antalgic gait or a Trendelenburg gait, it is always to the same side. Lurch is never to the other side unless it is a conscious lurch you want to demonstrate something. But it is always pathological, always to the same side. Because energy conservation is the key component of every gait cycle. So, in the normal gait cycle, so when you lurch to the same side, what happens? This lever arm is now moved from this length to this length. Multiplication factor here is reduced. The counterbalancing force is reduced. There is a net reduction in force on the hip joint, and it is advantageous win-win position for the patient. That's it. A stick also the same way. If you're using a stick, either this side or this side. Will you use it on the affected side, TB hip on the right side? Will I use it on this side or will I use it on this side? If I use it on this side, what is happening? It is counterbalancing nothing, because nothing, no unloaded thing on this side. Number 2, ground reaction forces, Newton's law, come up, they transmit to my trunk, and this tends to push my trunk to this side, which means lever arm will increase, pain will increase. So even if you have told wrongly, patient will think, "Arey, isko kuch nahi pata, yahan rakhna hota." He will do it at the correct side because he is the one who is suffering pain. He will keep it at the correct side, always to the normal side, always to the unaffected side. Why? Number 1, this becomes a supporting limb for through the arm. It is a supporting limb for the trunk and this part of the body. Second, ground reaction forces help to neutralize the load on this side. So a double win here. So a stick is always on the normal side. So that's patient with DDH, left side, lurching to this side. That's the patient. She has a shoe raise. She's lurching to one side. The stance phase is equal on both sides. There is no pain component. She's a patient who's had a girdle stone on one side. Here is a patient who is walking. A bilateral. So when you have a bilateral waddle, it's called a duck waddle. So see a duck walk in one of those animal channels, you have that. We'll have bilateral DDH, bilateral coxavera, any bilateral instability of the hip will have a bilateral duck waddle. That's the X-ray of this patient. Severe coxavera bilateral. Here is this patient. Let's see what is happening here. Here is a patient who is walking. The stance phase is equal on both sides. However, there is a vertical dip in the trunk and the pelvis, and there is a lurch, vertical dip. So a lot of people say, if there is a severe shortening, you will have lurch. No. Every lurch adds to the energy consumption. So if, say, assuming my left leg is the longer leg and the right leg is a shorter leg. So if I'm standing on this, left is persistently longer. See what is happening. It's at least 5 inches difference in length, but there's no lurch. It's a vertical dip only. So pure short limb gait will only have a vertical dip up and down, but no lurch at all. No lurch at all. Okay, so this patient, but something else is happening. Can you see? He's not flexing his knee in swing phase. There is no flexion of the knee in sling phase. Can you see that? So he is having a vertical dip, he is having a lurch, and he is having no swing phase. So what do I analyze? By just looking at his gait, I can make out. I made his diagnosis just by looking at his gait. My patient. Okay, so he had a short leg, number 1. Number 2, he had a stiff knee. And number 3, he has some pathology in the hip joint which is causing the lurch. And that pathology is not painful. So all 3 I can make out just by observational gait analysis. That's the view from the side. See that? That's it. Look at his X-rays. He's got a girdle stone, pseudoarthrosis type with very short femur, with a stiff knee. That's what it was. Again, another one. Just 2 minutes, I'll finish. 2 minutes, sorry. See here, most of the time the load is borne on the left side. The stance phase on this side is reduced. And when you see him from this, to see lurch, see the patient from front and back. Never comment on lurch from the side. So there is a shortening component. There is a subtle lurch. When shortening is combined with a lurch, the lurch doesn't appear that much. So that is why you are told that if you have a lurch, do not compensate limb lengths completely. Leave a little shortening. Because as the trunk is going down, the lurch merges with that. And you do not have an ugly lurch. Okay, so it's important for you to understand that he's got a very subtle lurch, and when you look at his X-rays, this is what he had: a protrusio, an arthritic hip, which was painful, and an adduction deformity, all contributing to his gait cycle. I think I'll quit here.
Again, sensory loss of ataxic gait I've already described.
Always check for Romberg's. When I ask about Romberg, what is it done for? Sir, it is done for cerebellar ataxia. No. Romberg sign is a sign for sensory ataxia. So you ask the patient to stand both the feet to close together and you be behind him and ask him to close his eyes. If he is having a sensory ataxia, you will immediately collapse and open his eyes. So don't let him collapse, prevent that.
And
Parkinson's, both extrapyramidal lead pipe rigidity is there in Parkinson's. So the quadriceps is tight, hamstrings are tight, gastrocnemius is tight, anterior compartment, everything is tight. So he can only take short steps. Now short steps, and they always have a little crouch. When they have a little crouch, they have more energy consumption. So then they tend to walk fast. Festinaire is a French word which means to hasten. They seem to be walking as if they are trying to catch their own center of gravity. Festinating gait. That's a description for a Parkinson's gait. Arthrogrypotic gait. They have stiff hip, stiff knee, stiff ankle, everything is stiff. When you have everything stiff, how do you walk? Use your trunk muscles. In them, trunk is good, so what do? Use the trunk to swing the leg forward. Use the trunk to swing the leg forward. Classical penguin gait. So if you watch National Geographic, watch the Antarctica, Arctic, Australia, New Zealand series, you will find the penguin gait is typical of a bilateral, stiff hip, stiff knee, stiff ankle, arthrogrypotic gait. Lastly, don't forget to look at the footwear. A footwear gives you a clue to what is wrong. So I thought, here is a patient, I thought so, but you would think that his load bearing is on the medial side. So don't just go by just examining this, do both. So I would think all his load bearing, so he might have a valgus deformity. But when I looked at him, he had a severe varus. His whole weight was on the medial side of his footwear and only the outer portion of the heel was touching the medial side, and therefore it was one like that. Don't forget to look at the footwear and wear pattern of the sole of the footwear that the child is wearing or the adult is wearing. Always remember that. It may give you clues and understanding of how he is walking. This is a separate topic completely. Thank you very much. Sorry, I didn't look at the time.
Thank you so much. Thank you so much, sir. I think everyone here would agree that this was one of the most fascinating talks on gait analysis. Especially thank you for all the apt audiovisual and live depictions of gait you showed us. Now I'd like to request Dr. Putty to please felicitate Dr. Matthew Verghese. Dr. KP Raju, BOS President, to felicitate the chairpersons for the talk. Requesting Dr. KP Raju to felicitate Dr. Vijay Goni. Dr. Prakash Appa. Dr. Vanamali. And Dr. Dr. Surendra Kant. Now, before proceeding to the case presentation on hip joint, I'd like to announce for all the delegates that we have a PG quiz that is going to be held between 6 to 7. It's going to be a MCQ paper of 40 questions. For 60 questions, it should be over a time period of 40 minutes. It's going to be a team of 2. So whoever is interested, kindly register with the front desk. We'll be conducting the exam between 6 to 7. Thanking all the chairpersons. Now for the next session, we are going to have a hip joint case examination. Requesting chairpersons for this talk to come up on stage, Dr. Matthew Varghese, Dr. Edward Nazareth, Dr. B.B. Putty, Dr. Rajesh Malhotra, and Dr. Sridhar Murthy. The first case presentation for today will be by Dr. Rishabh.
Requesting all the chairpersons and the presenter to be loud and clear, and the chairpersons kindly stick to the time of the presentation. It is 45 minutes. Thank you.
Good morning to all. My name is Dr. Rishabh Goyal. I am a second year postgraduate student from Gulbarga Institute of Medical Science, Gulbarga, sir. I will be presenting a hip case today, presenting the case of patient named Bairish, who is 40-year-old male, who is resident of Bangalore, and is a electrician at same hospital. Is an electrician technician at the same hospital. Has come with chief complaints of pain limb since age of 3 years, when he was 3 years of age, and pain on the left hip since age of his 10 years, sir. Coming to chief complaints, sir. As I feel as it was a very early onset, I'd like to start with the birth history, sir. The patient was born to a normal vaginal delivery, which was uneventful at the time of birth and was discharged on time. But on the day 9 of his birth, the patient had developed a swelling on the left hip region, which his mother had, about the information about the patient given to him by his mother, which was untreated. Over the course of next 3 to 4 days, the swelling eventually burst and there was a purulent discharge from the left hip region, for which the patient had not taken any consultation. Only he was treated ayurvedically, and also some kind of powder which was applied on his forehead, on the temple, and was applied to the local site, which was continued for a period of 3 months. During this 3 months period, the child used to have on and off fever, swelling, and there was purulent discharge. The discharge was foul smelling, which was non-blood thin, does not have any bony spicules, sir, and was associated with on and off fever, sir, and the swelling gradually reduced over the period of next 1 year, sir. But the patient gives history that he initially noticed the limp around his left hip region, which was initially non-painful at his age of 3 years, which is gradually progressive over the time and has become painful over the past 40 years, sir. Over the past 30 years, the patient also has pain around the left hip region since the age of 10 years, which is dull aching in nature, which is present on walking for a longer distance, according to him for a 1 or 2 kilometers distance, which is non-radiating. which is not non-radiating. It is non-radiating, which aggravates on walking for a longer distance of 1 to 2 kilometers and relieved with rest, sir. Currently, the patient has come with both the chief complaints, that is, he has a limp around the left hip region which has progressed over the time and has become painful on walking for a longer distance, sir. Coming to negative history, there is no history of similar complaints after the age of 1 year on and off swelling, sir. There is no history of fever, chills, night sweats, weight loss or loosening of his undergarments or clothes, sir. There is no history of similar complaints in the opposite joint or the pain in the smaller joints or the other joints of the body, sir. There is no history of any other swelling or significant weight loss, sir. There is no history of significant trauma after this episode, sir. Coming to his functional history, sir, currently the patient is able to walk on a flat surface for a distance of 1 to 2 kilometers, after which there is pain and he has to take rest, sir. But his ability to walk upstairs and downstairs have reduced, sir, over the past 30 years. The patient is currently unable to sit cross-legged, is unable to squat or use an Indian style of toilet or ride in bicycle. That is joint abduction deformity around the hip region, sir.
You need not tell the what the patient has told, that only you have to tell. Did the patient tell you that is an abduction deformity? So only tell whatever the patient has told and don't give any inference in the history, okay, unless examiners ask you.
Most of what you have said, I get the impression is 30 years old, 10 years old. I don't know why he has come now. I am still groping. Why has he come now? Has he been picked up from a disability clinic and brought here for PG exam, or what is it? I do not know. I still am groping to know why is he here. No, it's not clear why is he coming to you now.
It's for the pain around his left hip region, sir.
30 years.
See here, now first, simple in 3 sentences you tell me, what are the issues in the history here and what is his disability? That's what sir wants to ask you.
Pain and limp around the left hip, sir, and difficulty in doing his daily activities for a longer duration of period, sir.
So has it aggravated now? Why has he come now? That's what he's asking. Why is the reason for coming now? Because see, it has a difference. It will make a difference to the management. If he still has the same problem with which he has been comfortably living for 30 years, he will not be inclined to do anything. If he has had some recent exacerbation of symptoms, you want to address that. That is the reason for asking that for 30 years he is living with the problem. Why has he come now?
Sir, because his pain and disability, the functional status is decreasing over the time.
Over how much time?
Over the period of past 30, that is what is in. There is no acute exacerbation, sir, but over the period of 30 years, his walking distance has reduced, sir. The functional ability to do his daily activities has reduced, sir. And also the pain
It is a progressive. His disabilities are progressive. This is very important thing to know.
Yes, sir.
Whether the disabilities are progressive. So progressive. Then
2 kilometers of walking is not too bad.
According to him, before he used to walk for 5 to 6 kilometers a week.
the other important things you would have at the what age he started walking, whether he had any problem during the school days, whether he was taking part in the sports and all that. That's very important to know.
The weight bearing was according to normal. There was no delay in milestones, sir. Only at the age of his 3 years, when he was a child of 3 years, he started noticing a limp around his left hip, and he was not able to actively participate in sports and other activities during his childhood.
That's important to know, that whether he had problem during his childhood, because whatever he had, there could have been a simple boil which was there, burst open and went off without affecting the hip. Okay, that's important. And he did not have the problem up to, according to you, up to the age of 3 years. Then only started limp. And he started walking now. I mean, you started walking now at the normal age, maybe 1.5 years age.
So you are not convincing. So typically at this point of time, the examiner will ask the patient why you have come and what is the problem now. Right? So don't think that if it's not happening here, it will not happen. It will happen there in the exam.
All of these things have, he does not remember exactly, but it has been progressive over the past.
Point in time where suddenly he told you that no more I can't use the Indian toilet. He's an electrician employed in this hospital. So did you ask any disability in the last few years where something he can't do which he used to do earlier?
Like climbing stairs and walking upstairs and coming downstairs.
For me, sitting squat and using an Indian toilet, that's a very critical time where things have aggravated. Could be from last 2 years or 3 years. I don't know. I'm asking you.
Even the limp what you have told, he is not using any assistance. He is walking freely without a stick. Only thing is, you are telling it is over a distance of 2 kilometers he gets pain. That is one. So it is not assisted gait. And at the same time, as I told, the disabilities. Earlier, was he actively involved in the sports? One. Actively he was sitting. Activities of daily living, was it coming in the way? Now, since when the activities of daily living, that is sitting, squatting and has come in the way? All this has to be told.
So what are the possibilities now, based only on the history that so far you have gathered?
I got some more information. According to him, till he was in the 10th class, that is almost up to the age of 15, he was almost normal. He was running like other children, playing, sitting cross-legged. He was using, even now he is using Indian toilet. He finds little difficult to sit for a longer time. And gradually now he is finding that he cannot walk as much he was walking. He is working as some food supplier here and is able to do the work. See, why when the examiner, as I said, he goes and asks and he finds some this one, if there is no language barrier, then it can have some impact. Okay, continue. This is for everybody, not only for him.
Examination. On the basis of history, what do you think it is?
It will be pathological on the left hip. It will be a sequelae septic arthritis, developmental dysplasia or a split capital femoral epiphysis. Because it is in childhood.
What is the age for slip capital femoral epiphysis? When does it present normally?
During the around 14 to 18 years of when the
And when did this history start?
You say it is a slipped capital femoral epiphysis. Why can't you say that the infection itself is a septic sequelae?
He started with that.
The differential diagnosis. Okay. Or anything else which can start at the age of 4?
I would want to ask that if you can say slipped capital femoral epiphysis, why not Perthes? Because if you're not taking into account the age at which it happened.
As per the history, you see it is definite, and you are you have put in the when you are talking, it is at the age of in childhood. I mean, when he is an infant, I suppose, he had a infection sequelae with pus discharging. Since then, he didn't come across with trauma or any other thing. Only thing is he had a limp and pain since 10 years, when he was aged 10 years.
No,
so
16 years.
You
10th class he is mistook for 10 years, but actually patient according to this started at the age of 15, 16 years only started developing the problem.
So why don't you confine to the pathologies at that age?
You can what say another the history when they ask, you can say that I can give this differential as per the history. I think it may be septic sequelae. It can be a Perthes disease. Okay.
Before the 5 years, another probably it is CDH. But since it is a discharging pus, at that time it's only an infective sequelae.
See, another clue is you would have, see, before presentation you would have examined the patient now. You know what is the diagnosis is. So your history likely to, you have to lead to the examiners to that, and you have to distill out the unnecessary things which are not relevant for your diagnosis. Okay.
I'm sure you mentioned Is the shortening progressive? Is the shortening progressive? Did you mention? The shortening. So the patient complains of shortening, whether it is because of, say, destruction of the hip, or it is because of deformity which is increasing, the apparent shortening may increase. So for any childhood pathology, you have to tell if the patient has perception about what is happening to the shortening. Is the shortening progressive or not?
Is he having shortening? Did he complain of shortening? No, didn't complain.
Didn't complain of shortening at all.
You have the advantage of hindsight. You have examined the patient. Okay, there would be scars, healed sinuses, adherent and puckered to the bone. They should straight away tell that, sir, the history is very typical in childhoods with discharging sinus, and from there, the way the sequence is, it seemed to be sequelae of septic only. Bringing in slip capital femoral, just because the age, adolescence is the age group when you want to show off. When you want to show off to your buddies that you can run faster than them. You want to show off to the girls around that you're better than any other buddy around. Okay, that's evolutionary. So he would have overstepped the limits of his joint, and therefore he could have pain. So you should have elaborated on that pain. Sir, the pain aggravation at 15 years was only a short while, only severe activity related, no rest pain, no other problem. Dismiss that. You have to lead the examiner. Don't fall into the trap. They will keep asking, yes, what else? They will say, sir, Perthes. Then what else? Slip capital femoral epiphysis. What else? Sir, congenital coxa vara. See, there is no limit to the thing that you say. You have to set the limit. Don't fall into the trap of the examiners.
Yeah, continue. General physical examination.
Sir, coming to general physical examination, sir, coming from head to toe examination, there is no sign of maltouch, there is no flax, and there is no easy proclivity of hair, there is no ictus, there is no pallor, the mouth is moist, there is no appearance of dental crease, there is no...
We get half an hour to examine you. And if you spend all the time in no, so you say, sir, general physical examination is essentially normal. But the examiner, if you say it's a septic sequelae or something, would ask for lymph nodes, would ask for something else. So any other thing other than is essentially normal. Systemic examination essentially normal. Coming to local examination.
Is there anything? Is there anything positive? No. Okay, go to local examination.
Systemic examinations are normal, sir. Coming to local examination, starting with gait, sir. The patient has bipedal, unassisted gait with a limp.
Bipedal, unassisted?
Limp on the left side and left towards the affected side.
Yeah, what is the type of the gait?
What is the type of gait?
Huh?
Suggestive of Trendelenburg type of gait, sir.
Trendelenburg type of gait.
Trendelenburg. ಯಜಮಾನ್ರೆ ಸ್ವಲ್ಪ ನಡೀರಿ ನೋಡು ಕೆಳಗೆ ಬಂದು ಮುಂದ್ಗಡೆ ನಡೀರಿ ಮುಂದೆ ಆ ಕಡೆ ನೋಡಿ ನಡೀರಿ
Can you just describe the gait?
ನಿಧಾನ ಸರ್
Sir, it is bipedal, unassisted, with limp on the left side and left towards the
You don't have to, it's a gait with, it's a limp. That's it. Beyond that, you don't have to qualify there. You straight away come to the lurch. Okay, so it's just a lurching gait. Can you just ask him to keep walking if he doesn't mind it? I'll just keep walking. Come here and keep walking. With every step, whole trunk is going down. So there is a short limb component. With every step, he is lurching significantly to this side. There's something else also happening. Notice that. With every step, he is also lurching backwards. He is lurching backwards. Backward lurch is always the indicative of gluteus maximus inefficiency. So there is something which has made that inefficient. So store that in your hard disk. So there is a lurch to the side as well as a lurch, posterior lurch. Okay, then what is happening to the limb? Why did you say it was Trendelenburg? What is happening to the unsupported side when he's standing on the affected side? The pelvis is dipping down. You can see the pelvis, every step on the affected side, the pelvis is dipping down. Can you see that? There it is dipping down. Every step it is dipping down. You can see it. So there is an instability component there. Okay? Then the swing phase flexion of the hip and knee is less. Can you see that? Compare the right side. The flexion on the right side of the hip and knee is more than the left side. The flexion on the right side is definitely more, on the left side is definitely less. That happens in shortening. So in shortening, the normal side has to bend more. Significant shortening. The unaffected side has to bend less. Because ground clearance is just by shortening itself give you the ground clearance. You don't have to do the swing phase ground clearance.
See, how you will compensate for the shortening here? As Professor said already, either by shortening the normal limb or by extending the abnormal. See, you will sometimes you do the equinus on the disease side.
You may do equinus also.
And also the flexion at the knee and the hip.
Okay. He is having short limb gait with a tendon component and with a gluteus inefficiency. Okay, fine. Stance space is not changed.
See, what is the inference that you are getting out of this gait? The information, as Professor said, gluteus maximus number 1, medius number 2, and also severe shortening. These are the three things that you already made a diagnosis in this case.
Coming to inspection in a standing position, sir. Inspection from front, both shoulders at the same level, sir. Left ASI appears to be at lower level. From the front, there is wasting of the thigh muscle seen, sir. Calf muscle evaluated, and the foot touching the ground, sir. Coming to inspection from the side, sir, there is exaggerated lumbar lordosis which was noted, sir. There is a scar mark of 1 into 1 centimeter over the left proximal thigh region with no active discharge, sir, and puckering of the skin around it, and the skin around it appears normal, sir. There is wasting of the calf and thigh muscle.
How the scar is it? Surgical scar or? It's healed by secondary intention. Doesn't look like a surgical scar.
The knee is complete extension and the foot is touching the ground. Coming to inspection from the back, sir, both the shoulder appears to be almost at the same level, but there is spinal deformity of primary curvature towards the right side and the secondary curvature towards the affected side seen, sir. There is wasting of the gluteal muscles noted, sir. The left gluteus fold is at the lower level. There is wasting of both calf and thigh muscles seen, and the foot is touching the ground, but it is in a equinus position, sir. And there are no from the posterior side, there are no dilated veins, visible pulsation. There is no fullness of the obliteration of the gluteal fold, sir. When the patient is made to bend forward, sir, in the standing position visualized from the back, the spine straightens, sir. Coming to inspection from the sitting position, sir, when the patient is made to sit, both the
Spine, what? He has having scoliosis.
yes, sir, there is, but it is not fixed.
So scoliosis disappears when he bends forward and disappears when he sits also.
Yes, and while sitting also it disappears, sir.
So there is two things here. Scoliosis that disappears when patient bends forward. It is a functional scoliosis. Scoliosis that disappears on sitting is a compensatory scoliosis. Okay. So here important is scoliosis that disappears when the patient sits.
Classically, Adams test, that's the name for the test that you did. Forward bending to check the reduction in the lateral curvature or scoliosis. Adams test is usually done in a scoliosis case, not usually done in this. Here, we just describe there is a scoliosis with the tilt or against the tilt, which disappears on sitting. You don't have to do Adams test, it's part of spine examination. Okay?
Unless, if suppose the patient is having hip problem with the scoliosis, suppose is a structural scoliosis, then only you will have to tell. Otherwise, in hip cases, you have to tell that scoliosis disappears when the patient sits, as sir said. Did you understand? Is it clear?
Do you expect scoliosis in this case or not?
Because of
shortening.
shortening.
Shortening of his limb, sir.
You said that anterosuperior iliac spine is at a lower level. Okay.
So what happens to the spine when it is on the lower level? When the anterior iliac spine is at a lower level, what happens to the spine?
Scoliosis.
Towards the opposite side.
Scoliosis with the convexity to which side? That is what sir is asking.
That's what he said, opposite side.
Yeah.
It is not affected or non-affected. It's always on the side where ASIS is lower. Always remember that. So in AD duction deformity, it will be on opposite side. In AB duction deformity, it will be on the same side. In shortening, it will be on the same side. It's always convex to the side where the ASIS is lower. Right?
Did you follow? Did you understand? If the anterosuperior is at a low level, in abduction deformity, anterosuperior spine will be at a higher level. And other side, it will be at a low level. So the convexity will be at that level. Very easy to remember.
If I have an abduction deformity like that, I cannot adduct the leg. So opposite movement is not possible. So if I have to walk or stand upright, this is energy intensive. I'll have to tilt my pelvis, so I turn the trunk this side. So this is again energy intensive. To correct this, I do this convexity to this side. Same size as exactly. So I'm giving you the analysis of why it happens like that. You tilt your trunk to this side to get the pelvis, ASI, that's why it's down, and then you turn the scoliosis to this side. If it's an adduction deformity, it is like this. So I have to do this way, and I can't get this leg off unless I do this. Then I turn this side. So you have to have the convexity to the other side.
Yeah, proceed.
Especially in a lying down position, sir, when seen both the ASIs at the same level, sir, from front, sir, there is no fullness of the trapezium, there's wasting of the gluteus muscle, there's wasting of the thigh muscle, there's no dilated veins are visible, pulsations, the knee is in complete extension, sir, the foot is in neutral and somewhat of in some degrees of external rotation.
Is there exaggerated lumbar lordosis on inspection when the patient lies down?
On standing, he had lumbar lordosis. On sitting, he has no lordosis. On lying down, does he have lordosis? He has. Can you demonstrate?
Okay. Oh, that is a soft couch you may not able to make it. Okay.
Still, you can get a clue, no? But there it seems to be. Yeah, yeah.
And look for the light at the opposite side, whether if I can see it or not.
There's no light.
Okay. Okay, fine. So on inspection,
doesn't seem to be there.
It is not there, or it is there. When you saw, it was there. Okay.
Inspection from the side, sir, the exaggerated lumbar lordosis is visible, sir, the light from the opposite side. There is scar mark, which is seen on the proximal.
You have already told once, isn't it? I don't think it has to be repeated. Doesn't change when the patient lies down. Only things that can change when the patient lies down is lumbar lordosis and position of the anterosuperior iliac spine. That you have to mention. Okay.
On lying down position, the left ASI is at a lower level compared to the right.
You said that on standing it is the lower level, but when lying down they come at the same level. It comes at it is at a lower level.
The medial malleoli on the affected side is at higher level, sir. The foot is in neutral and some amount of external rotation.
Anterosuperior spine is at a lower level and medial malleus is at the higher level. Maybe because of the presentation in the public. said it goes to the low level, I agreed. But once you said that when lying down it comes to the same level, then now you said again they are low level. It all looks like the same level. Okay, fine. But the limb is shorter, we agree with that. He's asking if the anterosuperior is low level, patella at a high level, medial malleus at a high level, is it possible? When it is possible? Anybody? When it is possible? When the limb is short, significantly short in the limb, it is possible, isn't it?
When the severity of shortening is more than the apparent compensated length, you will have this discrepancy.
Coming to palpation, sir, there is no localized of temperature of the affected limb, sir. Coming to palpation, sir, there is no localized of temperature. There is no tenderness over the anterior or posterior joint line. There is no tenderness over the scalpus triangle or the greater trochanter, sir. Coming to bony palpation, there is no broadening, thickening of the greater trochanter. There is no deep tenderness of the greater trochanter, sir. The indirect thrust tenderness, that the anvil sign is negative, sir. Coming to femoral pulse, there is
no thickening, but there is no difference in the size of the.
No, you said trochanter where it is, position.
The greater trochanter is above the.
Seems a little difficult to believe because a child who's had the pathology at 3 years of age is walking abnormally from 3 years of age, that the trochanters are same.
You said at the same level? No, it didn't.
No, I'm not talking about level, I'm talking about
size.
Thickness, irregularity, whatever.
Are you
broadening, no broadening.
Are you able to palpate and compare to the other side? It is normal. Trochanter girth is normal. It is not broadened, it is not thickened, only it is proximally placed according to you.
The femoral pulse is absent on the affected side. The Rajagopal and Neeraj positive, sir, and there are no palpable group of lymph nodes present. Coming to revealing of the deformities, sir, on doing the trauma state, there is a fixed flexion deformity of 20 degrees around the left hip, with further active flexions up till 90 degrees and passively 110 degrees. So the range of motion of the left hip of flexion is from 20 degrees to 110 degrees, sir.
So you mean that he has got fixed flexion deformity?
Yes, sir. Coming to deformity in the coronal plane, sir, there is a fixed abduction deformity of 20 degrees, with further 10 degrees of abduction possible, and there is no adduction possible. There is a fixed abduction deformity of 20 degrees of the left hip, sir, with further 10 degrees of passive abduction possible, sir, and further it is terminally painful, sir, and no adduction is possible in the left hip, sir. So the internal rotation is restricted and it is painful, where there is exaggerated external rotation, sir.
Now, you said that there is no exaggerated lumbar lordosis, and then you said that there is a fixed flexion deformity of the hip.
It is there, sir. Here he could not make out his hip.
Okay.
How much it is?
So there is 20 degrees of fixed flexion deformity.
20 degrees.
Actively you can do it with the passively the way to 150 degrees.
Is it normal? It's touching the abdomen.
Flexion is exaggerated. Compared to other side, it's more.
So flexion is normal, sir.
Normal. Stretching.
Anterior superior leg spine is at the same level.
Fixed flexion is there, sir. Fixed flexion deformity is there.
There is a 110 degrees, sir.
There.
Abduction is around 30.
No adduction.
No adduction.
Was there any telescoping? I'm just jumping the queue. No telescoping. Why did I ask that question? You understood the question? You see the discrepancy? Right? We are not trying to fit the findings in what you are saying, but what we are saying is, what you are saying is not possible. Because how do you measure the deformity, fixed deformity? We are not able to square the pelvis with the legs parallel. Then you put the limb, affected limb in a position of deformity, and then you measure the deformity when the pelvis is square. You got the point?
If ASIS is at the same level, then there cannot be an AB duction or AD duction.
Exactly. So I'll tell you what will happen at this stage. Suppose exactly this is what has happened in the exam. So what will the examiner do now? He'll give you a chance to examine again. He'll tell you, would you like to examine again? Would you take that opportunity? And what will you do if it is not, if it is different from what you measured earlier? What will you do?
So, when you have a doubt, sometimes patient, because of muscle spasm, because you're causing pain, you might lie in a tilted way. You may not have been observant of the way he is lying down, and one ASIS may appear to be lower. Precondition to define a fixed AB duction or a fixed AD duction deformities, opposite movement should not be possible. If you can adduct this limb, your own analysis of fixed abduction deformity is flawed. Then you do not understand the pathology of AB duction and adduction deformity. You cannot have opposite movement if there is a fixed AB duction deformity. So in this patient, they were showing exaggerated adduction. They were showing exaggerated abduction. So there's no question of abduction deformity, no question of adduction deformity. I don't even have to get up. Sitting here, I could see the adduction and abduction was exaggerated.
So let me again simplify it and reiterate what he said. A deformity is said to exist when the limb cannot be brought to its normal anatomical position. So if there is an abduction deformity, which means you cannot adduct the limb to bring it to neutral position. If you can adduct it and bring it to neutral position, there is no abduction deformity. Isn't it? That's why the opposite movement is always absent. Because you are not able to bring it back and bring it to anatomical position.
Is it clear? Anybody has any doubts here at this stage? Yeah. See now, when we examined, he doesn't have adduction or abduction deformity. In that case, you cannot say that anterosuperior iliac spine is at lower level or higher level. So if you have found out earlier, then go and examine again and tell the examiners that anterosuperior at the same level, he doesn't have any coronal plane deformities. Okay. Is it clear? Even if you have found out earlier that it is up, down, then you correct yourself. And sir said, what you will do now, sir, I will go and examine again. Get that chance because he is giving you a chance to come up. You always have to take, sorry sir, I will go and examine again.
See, that is why you are given 40 minutes. For example, just now they demonstrated you both adduction and abduction. Remember, by heart 10 times, in fixed abduction deformity, adduction is not there. In fixed adduction deformity, abduction is not there. Remember, and
okay.
why there fixed deformity? What anterior superior iliac spine low and high. It is the abduction and adduction deformity. So remember, and this pelvis moves forward and backward. It is in the fixed flexion deformity. So always adduction, abduction and flexion deformities are concealed, and rotation deformity, external rotation, internal rotation are always revealed.
Okay. So now external rotation is exaggerated and internal rotation is restricted by pain, or it is not, there is no internal rotation at all. Interrotation is there. Interrotation is there. Okay. Fine. You said interrotation is not there. That's what I'm asking. Initially you said painful. Painfully restricted. Okay, fine. Okay. Then next. No. He has corrected, sir, himself now. Sir asking why and yeah. Shortening, yes. Okay, fine. Agreed. Next. They said 45 minutes only. Yeah.
Coming to measurement, sir, there is 10 centimeter of wasting of the calf region, sir, and there is around 2 to 3 centimeter of wasting of the 10 centimeter high and 3 centimeter of the calf region, sir. There is reversal of the branch triangle, sir, and reversal of branch triangle with the.
Initially now you have to tell is there any difference between, there is no difference between apparent and true shortening in this patient, because there is no coronal plane deformities. Or you want to tell that there is a difference between apparent and true? No. Same, no? Okay, agreed. So when there is no coronal plane deformities, you do not get apparent and true all same. Now what is the segmental measurement? Have you done?
Yes, sir. The segmental measurement, there is supratrochanteric shortening with the reversal of the branch of 2 centimeters.
Of?
There is reversal by
2 centimeters.
Total shortening is of 2 shortening of 4 centimeters.
But infratrochanteric?
How much is infratrochanteric shortening?
So the infratrochanteric femoral length on the both sides is
It's same. Seems again a little difficult.
That's why I asked you in the beginning, can you have an ASI at a lower level, the knee and medial malleus at a higher level? Sir gave the explanation which you didn't catch at that time. And now again you're falling the same trap of the measurements. Right? We don't have to examine the patient. Just by these calculations we know where the problem is.
In long-standing cases, always check all the segments, not just supratrochanteric. Because chances are it is a septic sequelae, there must have been chronic osteomyelitis of the metaphysis also, growth of the physeal plate is gone, it has disappeared, so that's not growing. The femur is also osteomyelitic, so the limb is not used well. So whole leg becomes shorter, including tibia may have a half a centimeter, 1 centimeter shortening also. If you measure the tibia also, you might find it shorter.
And if you have a deformity, cross-check. Because it has to go towards exaggerated movements rather than any restriction of movements when you have this history. Right? So generally most of the movements are exaggerated unless there's a complication and there is deformities and contractures developing. Okay, that is the only way it can restrict. But if for a man who's been walking all these years, right, till the 10th standard without any pain and all those things, unlikely for them to have a contracture leading on to fixed deformities. So your thought process should be towards exaggerated movements, right? The moment you feel that there's a deformity and opposite movement is not possible, something major should have happened. Right? So you have to cross-check repeatedly.
Okay. Then go for the next part of the examination.
coming to special test, telescopic
telescopy is not appreciable. Tenelbach test is positive.
Coming to special line, sir, there is convergence of the when chin is parallel line, there is convergence towards the affected side, sir. Coming to independent assessment. Coming to the independent assessment around the hip region, sir. Nelton's line, when Nelton's line, the CT is upright in the Nelton's line, sir. The shoemaker line, it intersects below and opposite on the opposite sides of the umbilical, sir. The chin is parallelogram converges towards the same side, sir.
Okay, fine. You know, not told the examination of the gluteal region first.
No, he didn't tell. Did you, on palpation, did you find anything mass in the gluteal region? Nothing, nothing is felt. Okay.
That's important to qualify that.
Okay.
Globular mass. The expression is globular mass.
No, you move.
Rotate the thigh and see, does the mass move with movement of the thigh? Movement of the thigh. It's an expression that you have to use it every time.
Okay. So that is one important finding. Then you said vascular Narat is positive, isn't it? You said like that. Okay, fine. So now your diagnosis. Now you're going back. When they asked you at the end of the history what you think it is, you should have told, sir, for me it looks like a septic sequelae, because you have examined, you have presented, now you know that this is a case of septic sequelae or a DDH? Okay.
So the gait showed instability.
It is there. He said.
Any effort I can demonstrate. Yeah, the gross sharpening is there. You have a history of septic. So it has to match. So which means again cross-check telescopy, cross-check repeatedly so that you are not missing out on.
So one important statement he has said is that telescopy I could not appreciate. He said, he did not say that it is not there. Okay, it is a political statement, but still. So, sir, when sir said, I said, he said he has not appreciated. As the internal, I will tell him that he has not appreciated. Sir, it is there. Okay, fine.
Do you think your grip in the right hand is good enough for you to examine this?
Again, one comment here, he is finding difficulty to do it from the other side, right? It is not always mandatory to examine from the right side. For this, you can come on the left side, there is no problem.
Sit over the foot. Flex the knee again.
You flex the knee, support it.
When you have difficulty, you can stabilize the pelvis, keep this here. In a child, you can easily do it this way. But in a well-built, there, bring your hand there. You have to stabilize. Now put your hand on the, now see. Can you feel it going up and down? Goes up and down nicely. When you have difficulty doing this also, then what you do is you sit on his foot, stabilize, there. See? Can you see that? I think rest of them can see the knee moving up and down. Can you see that? It's a very simple way to do it in a bulky patient. Go on the same side, get the pelvis stabilized from there, put your hand there, and just wait to the limit, then go on. Now put your hand there and see what I'm doing. You see it moving up and down? Yes.
The other important thing is, in this patient there are exaggerated movements. That means there is a disconnection between the femur and the head. So in these cases, childhood, invariably you will get a positive telescopy. So you should try to elicit it properly and then present. Okay. No, it's okay, fine. Okay, show that was a little bit.
No, it's okay. Keep it on.
You think?
I was talking to some FRCS examiners, and I think we have the luxury here of our patients agreeing to this. They have a tough time. They keep looking for surrogate patients who are not real patients. We should be grateful to our patients who allow themselves for this kind of a public display. They just wouldn't allow it.
Is it clear? Okay.
Problem in severe shortening cases. So if you read the original article, the way to do it is, first of all, the patient should be able to stand for 30 seconds minimum, because that is the time it takes to do the test. Secondly, you should compensate limb length discrepancies by using blocks underneath the short leg, because your lowering of the pelvis will be viewed by both the pelvis together will go down in shortening. When that happens, you would think the lowering is because of a inadequate functioning of the abductors. So to prevent that fallacy, you equalize limb length so that the whole pelvis does not go down. That's the second precondition. Third, you should check for abduction, adduction deformities. Fourth, how much of flexion do you give? Literature is very clear on that also. You have to make the patient standing like this with a 30-degree flexion of the hip and knee, like that. And then check for, and your eye has to be the same level at the ASIS or the gluteal fold.
Okay, we have been talking about the trend lumbar test. When you cannot do trend lumbar test, patient is able to stand.
Not when there are coronal plane deformities. Okay.
Okay.
What is your now? Other hip is normal. Other hip is normal. You have examined. Okay.
Summarize your case.
Sacroiliac joint, do you have examined? So that has to be examined. Other hip, other knee, sacroiliac joint has to be examined in a hip case. Did you palpate for the lymph nodes?
Yes.
Where did you palpate? Huh? Where do you palpate? Is the problem in the hip, isn't it? Where do you palpate for lymph nodes in the hip? Anybody?
Usual trap.
Yeah, this is one of the questions which I normally trap them. Where it drains hip joint? Anybody? Huh? External? External ilia group of lymph node. How do you palpate? How do you palpate for external group of lymph nodes? Yeah. You have to flex because you said when you used to get synovitis, transient synovitis, we were asked to palpate because the axonal group of lymph nodes was an important thing. You have to flex both the knees, so that relax the abdomen, and just above the inguinal ligament you have to palpate. And inguinal group of lymph nodes, horizontal and vertical, are not drained by the hip. Okay, horizontal group are drained by the lower limb, and transverse groups are drained by the inguinal region. Okay.
Okay.
Fine.
Can you summarize your case?
Your positive findings, sir wants to summarize. Since childhood. No, what you have to tell is history. This 48-year-old gentleman now is presenting with the pain in the hip, which he had a problem from childhood. It is increased recently. And today he is brought for the examination from the department here on the hospital.
You're sure he has a flexion deformity? That's confirmed.
No, the inspection, from inspection, what you do is you start from there. Patient is having short limb. Okay. Sir is again now going to see for his flexion deformity. Sir is examining extension. It is present. Moving. Pelvis is moving. So it's not present. Okay. You have one. Okay, fine. See, when they are asked to summarize, you have to tell the positive findings. On inspection, he is having short limb.
Why would I double check? I'll check because other movements are exaggerated. So then I would suspect that maybe this will also be exaggerated. Okay?
Okay, then. With gross wasting of the gluteus and thigh muscles. Okay. On palpation? Positive. Yeah. You can say that he is having 10 degrees of fixed flexion deformity and further free flexion almost normal. Then he is having exaggerated abduction, adduction, exaggerated external rotation and normal internal rotation which is restricted by pain, and 10 centimeters of shortening with a reversal of Bryan's triangle, and there is infratrochanteric shortening also. How much you got reversal Bryan's? Total compared to other side. Other side, what is the base? 4. 4 plus 2 means 6. So we must be having 4 centimeters of infratrochanteric shortening. Did you understand? Other side base is 4. This side the reverse is 2. That means there is 6 centimeters of shortening. And total true shortening is 10 centimeters. That's another 4 centimeters you have to attribute somewhere, and that must be infratrochanteric. If you would have told that, you would not have gone and examined him, double checked. So what is?
And like it was said earlier, in a childhood pathology, even the leg may be shorter. So you must measure all segments individually, right?
So what is your diagnosis, anatomical diagnosis? Anatomical, there are only 4 or 5 things. Okay. Whether it is a unstable hip, first is a coxa vara, second the unstable hip, arthritic hip, then there is ankylosed hip, and synovitis which you normally don't keep in the exam. So of all this, you unstable hip. Normally maybe due to? Why do you say? Thompson's arthritis? You want to say that this is a Thomson-Smith arthritis? Septic arthritis is infancy, no?
Reversal of Bryan triangle, severe shortening, telescoping positive, RS sign positive,
exaggerated
movements. What else would you like to have before you call it Thomson?
It is a Thomson-Smith arthritis. What is the hesitation? That problem started at the age of 3 months, isn't it? His mother said 3 months. Okay. Infancy means what? We should not ask, but sometimes we have to ask. Infancy up to what age? Anybody? 1 year. So, septic arthritis of infancy is known as Thomson-Smith arthritis. Why? What is the problem? His cartilaginous is entirely gets destroyed in the infection. That is why.
You accounted for everything. What's the cause for the pain now? The instability, shortening, exaggerated movements, everything is equally. What is the reason for the pain?
What may be the reason for pain?
What is happening now inside the hip?
No, he is asking whether he is developing arthritis somewhere.
Do you think there's the head of the femur there based on your examination first? If not, or if it is there any changes happening in that? If not, give you an explanation for the pain.
So the way to answer that question which was asked, what has happened in septic arthritis of infancy, the ossific nucleus has not appeared. It is all cartilaginous. So usually streptococcal or H. influenza, one of those infections, the entire cartilage is lysed out. There is no head. So head doesn't form. That is why telescopy and exaggerated movements. Is a head there? No sir, it would not have developed because the entire cartilage for the ossific nucleus has been lysed out by the infection. The straight answer.
Yeah. He's asking whether there is painful hip or it is hip is almost maybe some because of the stretching of the soft tissues is getting pain. You said the same thing, no? You said something of that.
Painful unstable hip or painless unstable?
It's painless. His only interrotation is because you are trying to press, he is getting pain. Otherwise, he doesn't have much of pain, and he is also not complete. He is able to walk about 3 to 4 kilometers. He can do all the work. He walks more, then he gets pain because of this strain. Okay. So you can very well say that pain component, if you this one, that may be safe. But sometimes these type of patients also can have pain because where there can be false acetabulum would have formed, that can go into arthritis and can get pain. In that case, there will be restriction of the movements, arthritic hip. Here the movements are exaggerated. What you will do now next? Huh? X-ray. X-ray is there? This is what Ajit also presented in the same X-ray. Ajit also put the same X-ray.
Does it fit with your diagnosis?
Same X-ray.
Does it fit with your diagnosis? What is the diagnosis? No, answer is yes or no. Yes. First. Yes? Say yes. Wait for the next question.
What about the femur?
Is it a childhood pathology? On the X-ray, what is the sign of that? See the entire hemipelvis, see the femur, see the girth of the femur, everything.
Is the girth of femur same? Diameter.
Can this be DDH? One-sided. Head component is not seen. DDH would have seen some rudimentary head somewhere. It would have seen. It is not seen. Okay.
See the pelvis, see the
Obturator foramina. See that. Acetabulum. See the obturator foramina that side.
how is the acetabulum? Shallow, deep?
What you do? What you do now?
Very important question.
No, he said no, sir. He said no. What you do? You have seen the patient, examined him. What you will do to this patient? See, when these questions are asked, you should remember what problem patient has. Okay. What is his age? What problem he has? He is having shortening. He is having occasional pain, and he is able to do his work comfortably. Okay, almost work he is able to do comfortably now. Would you like to do something now?
And he has a intact sciatic nerve.
Sir is giving one more clue. Tomorrow we do not have list. Will you post him tomorrow for the surgery? He is fit also.
We have to do surgery for pain, deformity or disability. What he has.
Would you like to do, or you would like to see when these questions are asked, you should remember that all patients doesn't require surgery. Okay. We here sitting would like to know whether you are harmful to the society tomorrow if you give a MS degree today. Okay, that was one of our senior examiners used to say. My ultimate aim is to see whether the boy is harmful to the society tomorrow. If he is harmful to the society, I will not take the burden of passing him, and all the sins he would perform, that will fall my shoulder. So I do not want to pass. That was a statement was given by one of the senior examiners. So that is what we want to know.
I have another angle, whether he will, his patient will then come to me.
Okay, that is what. So do you think you would like to... Would you like to do something to him now? Okay. Suppose...
Because his kidney living is not affected, sir. Just the problem is he's having unstable hip, but there's no pain. He's able to carry out his daily activity.
He is having 10 centimeter shortening. You may not able to... How much of true shoe rise you can give?
I was waiting for Dr. Matthew to get up. How much shoe raise will you give?
Maximum, how much shoe rise can... Anybody? How much you can give shoe rise maximum?
How many of you think he'll wear that shoe?
How much of body compensates shortening? Normally body compensates for how much of shortening? Okay, 2.5, okay, up to 2 to 2 points compensates. How much of shoe raise you can give? That's normally just ask.
No. See, now he says that he has got about 2.5 or 3 centimeter shortening. How much of shoe raise you will give? Now, how do you elevate his limb?
It's 3.5 centimeters, okay. 2.5 shortening, okay, fine. He's having 10 centimeters of true shortening. And when there is an apparent and true shortening difference, the amount of apparent shortening, if you can cover up, then patient probably will not have problems. Here, shoe raise may not help him.
Yeah, when you are compensating for a limb length discrepancy, you never compensate for true limb length discrepancy. Because to the patient, his functional shortening is dependent on apparent shortening. So it is apparent shortening that is taken as a reference for compensation. Many years back, there was an orthopedic clinics of North America on symposium on limb length discrepancies. There they had clarified up to 2 centimeter, 2.5 centimeter body compensates without any long-term consequence. 2 to 4 centimeter you may add on a limb length compensatory elevation. Beyond 4 centimeter you may think something else to be done, added on to whatever. But if the patient is comfortable, you don't do it. If the patient has got a gluteal inefficiency, you always leave 1.5 inches uncompensated. So the answer to the question was, will you compensate fully the real limb length? No, sir. I will compensate based on his apparent limb length discrepancy, leaving 1 inch and 1.25 inches short. But his question was, will he use it? The problem with all shoe raises is they are very heavy. What does Nike and Reebok advertise? Lighter than air. Even if you have a Reebok, you go home and take it off because you like to be without that encumbrance of a footwear. So these people, poor people, and home anyway they will be bare feet. In South India, shoes are always outside. Even in apartment, they are outside in the stairwell. They don't go inside. Inside is managing anyway, but outside, if it is so heavy, he won't manage. He won't wear it. You have to be very clear on principles of limb length discrepancy. And consent of the patient is a big thing. In the US, they have the Little People's Association. People that are short-statured. So when Elizarov became popular and the Palais group became very widely known and everyone was going to them for limb lengthening and both legs, both thighs, everything was being lengthened. The Little People Association, when you interview them, they'll say, would you like to be at a higher level? Your problem is being tall, not my problem being short. It's a state of mind. So talk to the patient,
discuss with him, he may need nothing.
Suppose the examiners will ask you, suppose would you like to, suppose later he comes back with pain and severe pain, what you do? They may ask.
When would you refer him to Dr. Malhotra?
Finally they will ask you when you would like to do a total hip replacement in this patient. If you would like to do, what are the problems? What implants? All these three things they will ask. Why? Is the age is the criteria to a THR?
You wait for him to get 60 or you will wait for him to come and demand a better quality of life and a better walk? It has to be as per his demand. Wait for him to be 60. Would you turn him away if he comes with problem?
Would you like to do a pelvic supportive osteotomy? It is already, nature has supported. See that lesser trochanter is all side in the acetabulum. Okay. Nature is already given a pelvic supportive osteotomy. You do not require to do one.
Many years back, in the 40s, 30s, 40s and the 50s in Europe and US, they used to do a fitting of the lesser trochanter into the acetabulum. It used to go by the name of Lawrence's bifurcation osteotomy. Okay, so it is, nature has already done it here. The lesser trochanter is abutting against the edge of the acetabulum. Over a period of time, that becomes painful. So your answer should be, sir, he is managing 2 kilometers walking. He is managing everything, including squatting and sitting cross-legged and going to an Indian toilet seat, which will be a limitation if I do a THR. He cannot squat, he cannot sit cross-legged. Therefore, I will wait. How long will you wait? When pain becomes unbearable, when it influences his activities of daily living, when he needs to take painkillers every day. And at times it may be aspirational. When I tried to convince a 32-year-old woman with a problem, would you like to wait? Her blunt replied, Dr. Saab, I want to dance now. I don't want to dance at 50. Her answer was straightforward. That aspirational thing also, you'll have to counsel her whether she'll be ready for dancing. May not be able to ready for dancing in a short while. So you have to be prepared for all, eventualities.
And the other thing, you'll have to read about THR, what THRs you do, what are the problems you get, and what are the implants you use in this type of surgeries.
So one question for you, sir. If now it's already shortened and he has lived for 45 years, now you want to correct it. No, in case you want to correct it, you keep little shortening and correct, or you will equal to the other side. So I'm talking about biomechanics. I'm talking about biomechanics for tomorrow.
One is, it is technically impossible to equalize 10 centimeter. We must also remember
risk of sciatic nerve palsy,
lateral
popliteal palsy.
Yes. So that is the risk. So you have to counsel the patient about that. And one of the things which we keep on doing is when we put the trial inside, we palpate the nerve, and even if we are able to reduce it without femoral shortening, if the nerve is tight, we'll go ahead and do a osteotomy. The third thing you must always remember is, if somebody, I have corrected 12 centimeter of shortening in an adult who got a fractured neck femur at the age of 50, and the femur is upridden by 12 centimeter, I had absolutely no hesitation in pulling it down and making limbs equal, because the nerve doesn't contract inside. So this patient had achieved normal length of the nerve. Now many times by mistake, people confuse that with the lengthening in CDH. So when in CDH patient, the length has never grown to the adult size. So there you cannot equalize. The maximum I would equalize is 4 centimeter or less. The other thing which you can do here is, when you take him under anesthesia, you can, or otherwise also, you can just pull it, because it's a lax hip,
see if you can pull it down, and that will give you an idea as to how much you will be easily able to bring it down, and eventually how much shortening will you have to leave. But in a case like this, I really doubt that I will be able to equalize it completely, and I'll counsel that accordingly. Second thing is, it may sometimes be difficult to bring it down to the acetabulum. So in that case, again the subtrochanteric shortening may be required to actually relax the pelvifemoral muscles, otherwise it will not reduce. If you are not getting an adequate offset, many times you will see people will put a hip, greater trochanter will be near the ilium, but they have not done a shortening. So they have reduced offset, which will cause instability. If that is happening, I'll again do an osteotomy, shortening, and then put a longer head to get the greater trochanter away from the ilium. So those are the technical things you have to keep in mind. But short answer to the question is, it may not be possible to equalize in a childhood disease, and I would counsel that it will be decided by the tension in the nerve, and it's unlikely to get more than 4 centimeters.
Is there any doubts? Two ways of looking at it to clinically decide. If there is significant telescopy, see the amount of telescopy that you can do, that will be the amount of compensation, plus safely about an inch or an inch and a half. That much stretchability is there in the nerve. Beyond that, you're asking for trouble.
Okay, fine. Your presentations are all right, but some clinical signs you should have been a little more careful. And you always have to get a clue. Clue means not from the others. When you know that this is most like a Tom Smith arthritis, they should have a telescopy and should have all the movements should be exaggerated. That you should remember.
I'd like to thank all the chairpersons for this session. I'd like to request Dr. Rajesh Malhotra to felicitate Dr. B.B. Putti. I'd like to request Dr. Edward to felicitate Dr. Sridhar Murthy. Now we will be breaking for the lunch session. It will be for about half an hour. Requesting everyone to come back in exactly half an hour from now. Lunch will be served in the 7th floor of the hospital. A reminder for all the PG students to register for the quiz. Yes, sir. It's a cash award for the winners of the PG quiz, for the winners and runners up. So.
quick, but much needed break there. We're going to dive right back in. And I was looking through some questions, so we're going to talk about some of those questions here as we dive back into it. And Matt let me know that I had actually forgot a critical step because I don't actually have very specific notes here. In fact, I have no notes. I'm just going to walk you through what I knew I wanted to talk about today. And so I'm going to pull back over, excuse me, our Power Query editor. There's a couple really important questions I want to talk about. First of all, let me fix our original fact table. So if I go back over to my original fact table, once we duplicate that and we break off all of our different dimensions into separate tables, we then need to come back and just remove all of those extra attributes and columns that we don't need inside of our fact table. We don't need them there anymore, right? So I'm going to go through and remove a bunch of that information. So we choose columns here. I think somebody asked about that. And so I'm going to go down the list and I'll get rid of the need product, all of our ID columns. We need to keep campaign, so I'll get rid of it. I'm going to keep product goes to segment code because we can get all that information from the product, right? Manufacturer goes, we'll keep unit cost and price because that'll give us our cost of sales. Zip code is going to go, email, sales, state. There. So very, very small. A lot of times fact tables are not very wide, but they have a lot of Alright, so hopefully okay. And then before I forget, I have a very special thing that I want to share with the group here today, and it is primarily just thanking Peter for his contribution to all of these trainings. And so, Peter, you are going to be awarded with the Certificate of Top Technological Superiority. It's awarded to you for earning the distinct honor of Student Motivation Plus. So if you want that, I'll send it to you in PDF format, put it on your LinkedIn, put it in the office and Skype room.
Sí. Check.
We're getting a lot of questions about data modeling, a lot of awesome questions. Maybe we can do some kind of follow-up event where we do a Q&A. That would be awesome. So let us talk about that internally and keep your ears out for that. What I would like to do now is kind of dive into what I heard about
Check. Hello.
Check.
Next session would be on hip case discussion. I'd like to invite the chairpersons for this session. It will be Dr. Rajesh Gupta, Dr. Vanamali, and Dr. Anil Bhatt.
Good afternoon to all the dignitaries on and of the dais and all the delegates. Myself, Dr. Saga BC, I'm a second year postgraduate student who is studying in Gulbarga Institute of Medical Sciences. I thank you for this opportunity given to me to present this case. Here is a 38-year-old male patient by the name Yogesh, who has come from Ballari. He works as he has his own business, which includes traveling to.
I'll stop you here. This is not the business you have to say first, you know. What is the chief complaint?
Complaints of pain in the left hip region.
You have to go very systematically, right?
Yes.
Then you will not forget anything. The profession will come later on.
Here is a 38-year-old male patient, Yogesh, who has come from Ballari with complaints of pain in the left hip associated with limb since around 2.5 months. Coming to the history of present illness, patient was apparently all right about 2.5 months ago. Later he developed pain in the left hip region, which was insidious in onset, gradually progressive over a period of 2.5 months, which exacerbates with the movements of the left hip region and decreases with rest and is also associated with limbs. Patient was there is no radiation of the pain from the hip and there is no referred pain. Patient was able to do his daily activities, that is going on about his business while riding a scooter, and he is unable to do that activity since around 15 days. Patient has difficulty, patient can only mobilize for around 15 minutes, after which he has to take rest because of the pain in the left hip. Patient has difficulty squatting down, patient has difficulty sitting cross-legged, and patient has difficulty climbing stairs. There is no history of fever as such. There is no history of significant trauma to the left hip. There is no history of weight loss or night cries. There is no history of multiple joint pain in other joints or in the small joints of the hand. There is no history of any contact with tuberculosis.
So, what you missed here, was your chief complaint?
Complaints of pain in the left hip. Sir.
Only pain?
Associated with limb.
What do you mean by associated with limp? Are they different complaints or a single complaint?
Those are two different complaints.
If they are two different complaints, then you have to tell us differently the two things. You have not, talked anything about the limp.
He has limp since around 2.5 months, sir.
So simultaneously pain and limp was there?
Yes.
Or limp developed later? Or you are not sure?
I'm not sure.
It means you have not taken the proper history. Once you are presenting a case, you have to be sure. You want to again ask the patient?
Sure.
Ask.
Okay. Sir, patient
What is your name? What is your name?
Sagar, sir.
Sagar. So when you ask for the limb, right, what are things you would like to ask? As sir said, we want to know the sequence, correct? Did the pain start first or a limb started first? Does it make a difference in the history? If the limb starts first and then the pain starts, like the previous case, remember? Right, so there's a limb which started first and then pain comes later, so the interpretation is different. Compared to now what the patient told, that pain started first and then the limb started. So that gives a different meaning. Second thing you should ask is whether the patient himself noticed the limp or somebody else noticed the limp for him. That also makes a difference sometimes. Okay, they might not be aware that they are limping. Somebody would tell, why are you limping? They might ask. Okay, then that knowledge comes. Understand? Okay? Right, go ahead. Yeah.
Coming to the past history, sir. There is no history of diabetes mellitus, no history of hypertension.
Positive history, whatever the positive findings. So when this patient, you started taking the history, what etiology you related to in your mind? Adult patient.
Adult patient.
Suddenly with 2 months history of pain. What did you think?
Could be, the pain could be because of any trauma.
No, but you said there's no
There is
trauma.
no history of trauma.
So what did your thought process was what? That what did you think could be the etiology?
Can be an infection.
Infection, okay.
There there could be decreased blood supply, could be avascular necrosis.
Okay, so you thought all those things. Okay, proceed. Any other major history, positive history in family, past history, personal
In
history?
personal history, patient gives history of cigarette smoking for around 15 years.
15 years.
Around 12 years, 15 cigarettes per day. And he also gives
15 cigarettes per day for the last 12 years.
12 years.
Okay. Morning, Dr. Ajit was talking about alcohol, cigarettes, smoking and all those. Do you know any data, anything which you can tell specifically when they are more prone for any development of complications?
Smoking years and
How many smoking years? It's not smoking years, it's pack years. 20. Alcohol?
he has taken around 400 ml of alcohol per day for about 15
So
years.
every day 400 ml
For
or
about-
up to?
For about 12 years.
No, he has taken,
Yes.
but I'm talking of the standard literature evidence. Okay, 400 ml again, up to 8 to 10 years. So if somebody asks you, if you tell what he's an alcoholic or is a smoker and all, if it have to be related to your eventual diagnosis, just at least read 1 or 2 literature papers about these things, right? What is a generally accepted cutoffs? Okay, if it is smoking, it's about 20 pack years, and if it's alcohol, 400 ml daily, at least for 8 to 10 years. If it is steroid, do you know anything? Okay, at least 2000 milligrams prednisolone in the duration of 1 to 3 months. So these are the ones which give very high risk for developing complications. Okay, and there are enough papers and literatures. So these 3 things at least go and read, because you will get hip as a long case, and eventually there might be an avian case in your diagnosis. Okay, right, go ahead. So significant personal history is these 2.
Yes, sir. And he also has a history of COVID-19 infection, for which he has taken.
What?
A COVID-19 infection.
Is a COVID positive patient, was a
Was a COVID positive patient.
How was he treated?
He was treated in home quarantine, sir.
Quarantine.
He was not hospitalized, and he has taken only medications, and he said that
No other
did
drugs, nothing. Which
no
means
injectables.
basically no steroids or any
No
of
basic-
these
no
things.
steroids.
Okay. Right.
So from the history, the next question will be, what is your probable diagnosis? This will be the next question of the examiner. Only from the history. You have few findings, you have something in history. Now what is the first, second, third, fourth diagnosis at this age? You have to take age into consideration. Quickly.
My first diagnosis could be avascular necrosis of the hip.
So then, once you say this, then there will be question, what is in favor, what is against? In history only, right? So first, avascular necrosis, good. Second?
Could be an infective pathology.
Why you say infection? What type of infection it could be?
It could be a chronic, subacute chronic.
Subacute septic arthritis. Subacute pyogenic, you mean to say? Okay, carry on. Third.
Could be monoarticular rheumatoid arthritis.
Why don't you say tuberculosis first? Tuberculosis is still very common in India. Why can't you say that first? Before subacute pyogenic. Four.
Monoarticular rheumatoid arthritis.
Anything else? So this diagnosis will revolve around these 4-5 things, right?
Anyway, you are a very brave man, Sagar. I wouldn't accept any of these things. Ideally, for me, avascular necrosis is not a clinical diagnosis. First, because of it's a purely radiological diagnosis. Second, the duration of 2 months, history only, right? Second, infection you said, right? Again, no strong. Do you have any strong history to back up that?
No. He has no history of fever.
Yes. Septic arthritis, obviously you can't tell in an adult patient like this, right? It's a usually hematogenous thing, and it's usually in children. It can't be in an adult unless it's a grossly immune-compromised patient. Okay. Third, monoarticular rheumatoid is again a diagnosis which a lot of people might not accept, so be careful with that, right? Tuberculosis is probably one thing I might accept in the sense that because of the amount of the incidence and the prevalence and everything in our country. But again, single joint involvement, this age group, so maybe yes, but otherwise, okay. So because we ask you, you don't have to rattle 1, 2, 3, 4, right? You just have to, based on the history, you can tell some feasible diagnosis. But stating an avian as your first diagnosis, a lot of examiners might, I see a lot of people nodding there. Our exam faculty. So
I don't know whether you were present in the previous presentation. Even in that, Matthew sir, he highlighted that don't start jumping on telling all the diagnosis what you know, because you need to defend those things whatever you utter. Now, which of these among these can you really defend?
That's why I asked you when you started the history, what was your thought process about probability etiology? Right, the moment patient starts telling you the history, you should be wondering what is it. Correct? So honestly tell me, what do you think of?
Could be arthritis of the hip, secondary to some other.
What doesn't match there? For you to say arthritis, what doesn't match? It might be arthritis, but what doesn't match? The main thing is the duration. Okay, fine. Go ahead. Any positive thing in general physical examination contributed to this particular condition?
No, sir.
Nothing. Pallor is not there?
No, sir.
Okay. Local examination.
Coming to the
Akshay is staring at me. I need to finish it within 30 minutes. So I'm just rushing.
Local examinations are coming to the gait. Patient has antalgic gait, sir.
Make him walk by the time.
Yeah, talk to him, tell him what you want to know.
You continue with your...
ಒಳಗೆ ಶಾರ್ಟ್ಸ್ ಏನು ಇದೆಯಾ ಒಳಗೆ ಶಾರ್ಟ್ಸ್ ಇದೆಯಾ ಓಡಾಡಿ
patient has decreased transpation on the left side.
ಇದು ಸ್ವಲ್ಪ ಮೇಲೆ ಮಾಡ್ತಾರೆ ಇದು ಪ್ಯಾಂಟ್ ಅಲ್ಲ ಅದನ್ನ ಫೋಲ್ಡ್ ಮಾಡಿ ಪ್ಯಾಂಟ್ ಕೆಳಗಡೆ ಎಷ್ಟಾಗುತ್ತೆ ಅಷ್ಟು ಮಾಡಿ Why do you say it's antalgic gait?
He had decrease in the transpation on the left side, sir, with some increase in the swing phase, followed by lurching of the upper torso to the same left side.
How much you made him walk for you to get that antalgic component out? This much might not actually show the antalgic component a lot of times. So be careful with that.
The patient said that after taking less for a longer time, it tries to walk.
That's okay during the examination. Sometimes you make the patient walk a couple of times, you won't get this antalgic component out. Antalgic comes only after certain amount of walking always, unless it's very badly painful. Good. So ideally they say about 10 meters. Okay? Even when you are examining, when you are given a case in the exam, make sure you make them walk. The treadle component, the antalgic component sometimes comes out later. Not when we make them walk just few steps. So when you have time, make sure you make them walk at least 3-4 times in the room, in the classroom or wherever examination room where you've been allotted the case and make them walk. So sometimes it gets revealed. Okay? Otherwise you might miss out on a major gait pattern.
Coming to the attitude of the patient,
attitude of the limb, not the patient.
Attitude of the patient in supine with both the hands by the side of the body. The hip is in extension, knee in extension, and the ankle in a blanketed position.
So you're telling us inspection in the supine position. Standing there was anything?
There was
no major findings?
No major findings.
Okay. Sitting there was no major findings? Okay, go ahead.
Even in supine position, both the ASS are at the same level, sir. Patella are at the same level. Medial malleus are at the same level, sir. Coming to
attitude is hip in neutral position, knee in extension, ankle in. So that is the attitude part of it. Okay.
Coming to inspection from the other side, there is no exaggerated lumbar lordosis. There is no scar sign.
One thing. Once you are saying, you have examined the patient in toto, you don't have to say, from the side, from the this, from the this. You have to combine all the findings and talk in one go. Right?
I think so. The postgraduates always are put into this thing when it comes to some institutions. They teach them you have to. But remember, in exams you don't have time to tell front, back, and other things. So try to minimize. Don't argue. That's all. Suppose somebody says that this, why are you mentioning this? Just stop there. If somebody is asking why you are not mentioned, probably you need to continue. So you need to probably all of you have to get that flow. That's all.
Don't miss out on things because a lot of times they start with the ASIS and go down, but they will eventually would not talk about lumbar lordosis. Right? That is why all these methodology has come, sitting, standing, lying down, side, all those things, so that you don't miss out on the findings. But otherwise, if you can do it in a nice flow, it's fine. Yeah.
So always remember to go from proximal to distal. You will not miss anything. If you see lumbar lordosis, talk of lumbar lordosis first and then you go down.
There appears to be some wasting of the parts of the muscle.
What about lumbar lordosis? Okay? There is no lumbar lordosis.
There appears to be some wasting of the parts of the muscle.
Again, don't use the word some mild.
No, there is no lumbar lordosis. You should not be telling that word at all because normally there is lumbar spine is lordotic, isn't it? So there is no exaggerated lumbar lordosis. The terminology is very important.
Okay. Is there wasting or no wasting?
There is some wasting. There is wasting.
That's all. Wasting of the
left thigh, sir.
Okay. Then
there is wasting of the left calf. Quadriceps as well as gluteus maximus. There is no wasting of the gluteus maximus.
So if you have combined all your findings as sir was telling, then you should not miss the gluteal wasting. But if you say, no, sir, I'll tell later when the examination from the back, then you will have to mention it. Okay.
There is wasting of the quadriceps muscle and there is wasting of the calf muscle and there is wasting of the gluteus muscle as well. Coming to palpation, sir.
No, there are so many more in the inspection.
Both the medial and the there is
nothing else. Wasting limb length.
There is no limb length discrepancy.
You should mention on. Okay. Then.
There there is no obvious external rotation deformities appreciated in inspection.
You already told the hip is, the limb is in a normal attitude.
Yes.
Okay.
So what is positive on inspection?
Except the wasting, nothing else. Okay.
Nothing else.
Palpation.
There is no scarring, sinus.
See, you made a mention about septic arthritis, isn't it? You made a mention. No, we have not taken it, but you made a mention, and you are not mentioning Scarpa's triangle. It doesn't go well, isn't it? So, not only if it is you are suspecting septic arthritis, that's not the only reason, but there are certain things you should not be missing in your inspectory findings. So whether we are expecting you to tell what is the status of the Scarpa's triangle.
So whether you tell us about ASIS and did you tell? You told. ASIS same level.
ASIS is at the same level.
Scarpa's triangle.
There is no fullness, there is no redness, there is no swelling or sinus discharge from the Scarpa's triangle. Both the patella are at the same level. So except wasting there is nothing, right? Go on.
No, again, so now you have to see on from the side.
There is no supratrochanteric fullness.
Are you able to make out the trochanter first thing?
I was not able to make out that.
So you need to make a comment of that. During your inspection, are you able to see the trochanter?
I'm not able to appreciate that.
Okay. Then? So are you able to appreciate that? No.
I'm not able to appreciate any prominence in the trochanteric regions.
Okay.
Sir is asking you very specifically, when does it become prominent? In which, suppose a limb is in a particular position, the lesser trochanter, the greater trochanter becomes more prominent, isn't it? So that gives you an indirect idea that there is some rotational deformities, isn't it? So that is what he is trying to highlight. So you told that there are no limb discrepancies except for wasting, no other finding in the. But if there is wasting, your trochanter has to be more prominent, isn't it? They don't go together.
Posteriorly?
Posteriorly, there is no scoliosis of the spine, sir. Posterior iliac spine, the dimple of venous and the gluteal folds are at the same level. There is no flexion at the knee, sir. And there is no mass which can be appreciated through inspection on gluteal aspect.
Even if there is a mass, I don't think anybody would appreciate it during inspection analysis. Anyways. Okay.
Coming to the palpation, sir. There is no localized temperature over the left hip. There is tenderness over the anterior joint. There is no tenderness over the trochanter. There is tenderness over the posterior joint, sir. I am able to palpate both the femoral arteries with equal volume. And there is no swelling of the inguinal group of nerves.
Trochanteric palpation.
There is no broadening of the trochanter.
Start with the level always.
The level of the trochanter on both the sides is normal on palpation. There is no broadening or thickening of the.
Not normal.
You have to use the word palpatory branch shows no upward shift or downward shift of trochanter. So these are the sentences you use. That saves you a lot of time. That also conveys the message to the examiner that okay, this is what has been mentioned. So palpatory branch shows no upward or downward shift of trochanter.
Start with the level of the trochanter. Are they at the same level? Is it one is on the affected side? Is there any change? Then the palpation itself, the thickening, broadening, irregularity.
There is no broadening. There is no thickening, sir, which can be appreciated in
posteriorly.
Posteriorly, there is tenderness over the posterior joint line, sir. There is no appreciable mass which goes with the movement of the left hip.
So only positive finding is joint line tenderness.
Anterior and posterior joint line tenderness.
That's all. Trochanter is normal essentially. ASI is the same level.
ASI is at the same level.
Okay. Go on.
Coming to the movement, sir. There is active flexion of up to 100 degrees.
You first tell, is there any fixed deformity? You establish the fixed deformities and then go on to the movements. So we know that there is a fixed deformity of certain ranges, and beyond that there are some restrictions or whatever. So otherwise you should make a statement that there are no fixed deformities, coronal, sagittal, rotational deformities.
Assessment of deformity
There's a reason, right? So once you fix the deformity, the range, then you know what is the next part of the range of movements.
Patient is internal rotation is restricted from the neutral position.
First thing, do you want to make a statement there are no fixed deformities?
There are no fixed deformities.
Then you start with each component.
Flexion, active flexion is up to 100 degrees with further flexion of up to 10 degrees possible, sir. So the total movement, the total flexion is about 0 to 110 degrees, sir. Extension of up to 10 degrees is possible.
This is active.
Can anyone from the crowd can come and then demonstrate some of the movements what he is telling, so that in the post-prandial I know everyone is sleepy. Someone volunteer?
Tunnel movements are painful.
We'll catch someone who is actually sleeping. Randy. No, you. No, unless you're watching something there. I thought you were sleeping.
Someone from the last row. Please come.
You were watching something.
Violet shirt.
Okay.
You know, it should not be only discussion between the chairperson and the this thing. You have to, this program is basically for all of you. So you should be getting some doubts. Okay, carry on.
So is there any difference between active and passive movements? If you want to differentiate active and passive?
We ask the patient to flex the hip, sir, if he is able to do it.
No. In this patient, is there any difference between active and passive movements?
There is around 10 degrees of flexion which can be achieved passive.
See, it depends on how you've been taught in the institution, whether you want to say active first and passive. Absolutely no problem with that. But generally when we do the examination, we expect you to say the passive range of motion.
Why do you think coming to that point, why do you think you have to test active first and then passive? There is definitely a reason why you have to tell the patient to do an active movement and then only proceed to a passive movement. Anybody in the crowd? Did you understand the question? So whenever you are testing for the movements, you should always ask the patient to do his active movements and then proceed towards the passive, because passive is elicited by the clinician. Active is performed by the on command. So you know how much of restriction the patient has, how much of painful movement the patient can have, so that you don't exceed that when you do your passive movement. You understand? So always you have to do the passive movement after the active movement.
Secondly, when you are doing, the active and passive, active is excluding some other pathology also. What is that? Active flexion is excluding some other pathology. Sacral-like giant also. Okay?
So each situation, the interpretations are different. In this case, it is because of what Mali was telling them. In a nerve injury, it's different, right? You have to you have to tell about active and passive, the difference. Okay, so each has its own interpretations, right?
Patient has active flexion of up to 100 degrees with.
So how much is the passive?
Passive is around 110 degrees.
Around when you start tell that what you have done.
It's 110 degrees.
0 to, you should tell the range of motion. Don't say 110.
0 to 110 degrees.
The range of the passive range of motion, if you want to qualify that, is 0 to 110 degrees in the right side hip flexion. It is painless throughout, or it is painful internally. I didn't feel any crepitus. There is no spasm, and there is no signs of instability or any of. So this is how it should be entirely. So I won't ask any more questions. You tell me all those things.
The passive range of motion in the passive range of flexion in the left hip is around 0 to 110 degrees.
Again, when you use the word around, we think you have not done accurately. You have not used a goniometer. And some exams might ask you to remove your goniometer, show where you keep it.
Is 110 degrees.
Be confident, tell sir, passive range of motion 0 to 110 degrees.
0 to 110 degrees, which is terminally painful. Active extension of the left hip is 10 degrees and is terminally painful. Abduction of the left hip is 0 to 40 degrees and is terminally painful. Adduction of the left hip is 0 to 25 degrees and is terminally painful. patient is unable to do internal rotation from neutral position.
Patient is unable to do active. So
Passively, I am unable to elicit internal rotation because of pain in the left hip joint. External rotation is from 0 to 60 degrees.
So it's coming to 0. There is no fixed deformity. It's only a restriction. But there is no absolutely no internal rotation.
No. It is painful. 0 to 60 degrees.
60 degrees. What is the normal range of external rotation?
Around 45.
So you mean it is increased?
It is
in this patient. Everything was painful and restricted, and suddenly one movement becomes exaggerated. Why is it so? Does it fall in the... Can you demonstrate?
So we can do external rotation in hip pin extension in the log roll, or we can
always come tell the patient what you are doing and then tell them.
External rotation of the right hip, sir. And this indicates the internal rotation of the right hip. Ideally, the patient must be exposed to look at the ASIS whether it moves.
Otherwise, you can put your hand on that. The moment you flex, the hip is, the pelvis is fixed, but still to make sure that the pelvis is not moving, you can use your other hand if you are able to manage it. Yeah, we are interested in the exaggerated thing now. So make sure you don't cause pain. Okay. Flex it. You have a 110 degree flexion, right? Flex it nicely to 90 degrees. 90. No. That is quite painful for you. Already told us to stop. Go slow again. What are you seeing? Just show the audience. Come down, go back to the extension. Okay, slowly do it. Anything else is happening along the
deviation of the left.
So would you interpret that as exaggerated external rotation? Is it possible? Possible. So to be careful, if there is an axis deviation, you might assume that it's going into more external rotation. So is there an axis deviation?
Axis deviation is present.
Why do you say that?
Because normally the knee must either go to the ipsilateral shoulder or the opposite shoulder. But in this case,
it will never go to opposite shoulder. You'll be able to push towards the opposite shoulder easily. But generally it goes towards the same side shoulder, and easily you can push it towards the opposite shoulder. But here,
the knee is getting rotated outwards.
It's not the limb, it's not the knee. Knee can't alone go somewhere else. Okay? The hip is, yeah.
The hip is moving outwards.
The limb shows a tendency to move away from the ipsilateral shoulder. Okay. So, but Sir's question is still unanswered. Is it exaggerated? For that, you have to hold the pelvis, make sure the pelvis doesn't move, and then you check the rotation.
Finally, what is the take-home message? It's exaggerated, not exaggerated. It's not exaggerated. So what is the range now?
0 to.
Can you just demonstrate once more? What is the range?
Yeah, keep it there now. Place your hand on the knee. Don't cause pain. Stop with the... Yes, that's the correct way. Get it back. Yeah. It's about 40.
Yes.
Show the other one. I mean, do the opposite movement. Do the opposite movement. It's already moving. The pelvis is moving. Are you sure there is no deformity? You came up to the neutral.
I came up.
Okay. Yeah. In this patient especially, we would want a little more information on the rotations.
We can do it in extension through the log roll method. We can do it with the hip in extension in log roll method.
Any other?
In prone position.
Did you do? Can you do? Nidana. No over ಹೇಳಿ ಎಲ್ಲ ಟೈಮಲ್ಲೂ which is the normal side. Do first on the normal side. What do you want? What information sir will ask? What information you might get now?
Whether there is any difference in rotation.
A differential rotation. So you need to know what is the normal side first. Which side you want to stand? This side or that side? Okay. Where's your hand? Yeah. On the he has pain, right? There's a difference. Okay. And again go to the other way. It's a like a dial. Straight away you can see when he sits, hangs it down, everything is fixed, pelvis is fixed, everything is fixed. You can see both the lower limbs like a dial, and you can increase it. Anyway, do the opposite movement, like as sir showed. Go up slowly. Okay. Restricted. Next. Opposite movement. More, yeah. Better. Okay. So, was the rotation more here or less here?
Rotation was less here.
Less. 10 degrees, almost 10 degrees less. So, there is a differential rotation. Okay. Neramal. Side ಅಲ್ಲಿ ಕೂತ್ಕೊಳ್ತಾರೆ ಆ ಕಡೆ
Is there a deformity? If the legs are, if the thighs are held neutral and the legs are hanging vertical, there is no rotational deformity. If there is any rotational deformity, the leg will be like this or like the other way around. It will be suspended non-vertically. So that's the first information that there is on flexion, there is a deformity that is there. Number one. There, you can do the same thing here. We wanted to check internal and external rotations. So here it is, you are able to cross till 5 finger breadth here. Bring it there. I do the same thing. But clearly see the difference. So I don't have to do the angle also. Just from how much of the opposite leg is crossed, I get the clue.
This is my and sir's favorite method, but last time I think we had some people in Calicut did agree for this. So it was published long back, 1970s actually, for these children. Okay.
Coming to measurements.
Yeah.
There is
no, but you didn't say opposite hip movement at all. In comparison, how much is restricted to the affected side? You said flexion is 110, opposite is 120. Normal movement. So there's a 10-degree flexion restriction.
Yes, sir.
So in the unilateral case, we have to bring the difference. Okay, fine. So all movements are painfully restricted. That is very, very important for you later to tell your diagnosis. Okay.
Coming to the measurements, there is no discrepancy in the apparent length. There is no discrepancy in the true length. He has no supratrochanteric shortening on measurement of branch triangle. His segmental measurements are normal. His segmental measurements are, there is no difference in segmental measurements in the femur as well as the tibial component.
It's a lucky day.
There is 3 centimeters of wasting on the left thigh and 1 centimeter of wasting in the calf muscles. not able to appreciate any gluteal waist.
What's the importance?
It indicates the chronicity of the disease. From the back in, you must ask the patient to stand and then appreciate from the back.
So after your
measurements, neurovascular examination normal,
Neurovascular examination is
special
normal.
test,
Special test, telescope is negative, sir. Trendal lumbar test is positive.
Positive.
Positive, sir.
Okay. Why do you say that? What happened?
When I asked the patient to stand on the affected limb, that is the left lower limb.
Was he able to stand in the first?
He was able to stand for around 30 seconds, sir.
Okay.
You could see dropping of the right-sided gluteal fold at a slightly lower level.
Okay. Do you think it fits into your entire examination now? The instability component? You got a positive clinical result. No, I don't dispute that.
No.
Okay.
Do you get an antalgic gait with a trendal lumbar positive?
So, why we are asking is, if you got that finding suddenly, you should recheck a couple of times, front, back, A size levels, gluteal folds, 2-3 times you have to do. So if you are confident, we will accept, but then we will ask you to demonstrate now. And we will have to check.
And you told that you are going to look at the gluteal fold. Gluteal fold, these things shouldn't come in the exams. What exactly is Trendelenburg's test? You're going to look for? Yes. Isn't it? So gluteal fold, probably all the new additions to it. Standard, whatever is mentioned on a standard basis, you have to be mentioning those things as a standard test. So how do you perform? Can you demonstrate the Trendelenburgs in this?
Matthew sir, I know. No, the gluteal fold. The original description is actually from behind. So, a little.
Actually, what Asdas also writes is from the behind. So you have to sit at the level of the thing, and then see the thing. When you are looking for Trendelenburg.
No, you found it positive? Because you have to expose the patient completely if you really want to do that in a good way.
When I asked the patient to stand on the right lower limb, there was no sinking of the pelvis on the left side. But when I did the same test, when the patient is standing on the left lower limb, I could appreciate some amount of sinking.
Okay. We'll take it positive. Okay. Opposite hip, spine, knee.
Opposite hip, spine, and knee are normal. So there is
normal. Okay.
Lymph nodes.
Inguinal group of lymph nodes are not palpable.
Okay. Your clinical diagnosis.
Again hip, inguinal.
Clinical diagnosis.
He is a 38-year-old male patient with 2.5 months.
No, we didn't ask to summarize. Clinical diagnosis.
Arthritis of the left hip.
Arthritis of the left hip. Primary or secondary?
Secondary.
Secondary. What type of arthritis? Inflammatory, infective, degenerative?
Inflammatory.
There is nothing like secondary inflammatory arthritis. These things you have to be very clear. Right? Okay, we'll start with the component, break it down now for you. Why do you say it is arthritis?
Because the terminal range of motions are painful and restricted. There is no fixed deformity. Terminal movements are painful. Movements will be restricted and painful.
So all the range of motion.
The whole range of movements must be painful. There is good range of free movement.
all the range of motion is painfully restricted terminally. Classic description for that would be what? If the movements are restricted terminally, painfully, what is it called? What is it? So classically described for synovitis. Okay. Now the question comes, how much of that range of motion is remaining in this hip? And also there is an additional axis deviation with differential rotations and restriction of one range of motion, especially the rotation. So that is how you need to answer there, telling that one of the movements is restricted grossly, which there is no internal rotation. Right? There is a differential rotation, which means there is a change in the femoral head shape somewhere. Okay? That's why I asked you how much of the opposite hip percentage has reduced. That is what you need to quantify. It might be painful terminally, but then half, 50% or 40% of the opposite movement is lost. Then you should substantiate it might be arthritis. So you didn't still come into the secondary what arthritis? Is there a degeneration? Tell confidently. Yes, secondary degenerative arthritis probably would be an acceptable one with the differential rotation and rotational deformity restriction. I don't know.
So you can explain or you can defend yourself by telling that probably it is still in the stage of early arthritis, where only the internal rotation is affected. Rest of the movements you have still have some range of movements which is left and its pain is comparatively. Yeah. That is one explanation. The other thing what Anil pointed out is there is a differential rotation which is, and also there is a axis deviation. So all these things goes in favor of probably there is something which is happening in the head.
Any other differences you have? If you don't have, so this is one question straight away you say no if you are very sure about what you have and you don't have anything else. The moment we ask you start telling one or two more unnecessarily, it's not required. So do you have anything?
No.
Oh, okay. What do you want to do?
I would like to give a plain idea of the pelvis with both the hips in AP poses.
Okay. When you saw the X-ray, when you were taking the patient, you felt that there was arthritis? That time when you saw the X-ray, when you were taking the... Yeah, read the X-ray.
This is a plain radiograph of a 38-year-old patient which shows the lower lumbar vertebra with the sacrum, both the pelvis, the hip joint, the femoral head, neck as well as the proximal femur.
Does it confirm your diagnosis? First thing, sir?
There is
So start reading. So when you don't know the diagnosis, the smart way is to start reading the findings. Start from acetabulum, go down, or you want to go from proximal femur to go up. Anyway, whichever.
The acetabulum contour is maintained, sir. Along with the femoral contour is maintained. There is no evidence of obvious sclerosis on the left side. There is no evidence of subchondral cysts. The femoral shaft angle is maintained along with the proximal femur.
Joint space. Next.
The joint space appear normal on the left side as well as on the right side. So there is no decrease in the joint space.
All parts of the joint space.
Anything which is striking compared to the right and left?
There is some sclerosis on the inframedial aspect. Sclerosis.
Do you think the femoral head is covered completely the same way on the right side compared to this side?
There is some subluxation laterally.
Come stand here in front and you will appreciate that.
There is some subluxation on the lateral side. It's not completely covered on the left side as compared to the right side.
So, do you see the medial joint space?
Medial joint space is increased, slightly increased on the left side as compared to the right side.
Okay. Any change in the density of the femoral head? Shape of, you start here in the middle, then you start comparing continuously, then you will see this.
There is some flattening of the femoral head.
Okay. There is some change in the shape of the femoral head.
On the left side as compared to the right side.
Yes. Then see the density, see the matrix of the head itself.
There is some radiolucence in the head of the femur on the left.
Point it out. Point it out. Okay.
There is.
Yeah. Any other view you want? Happy with one view?
Does it give any
48 seconds.
I will take. Yes, sir. The sectoral sign and the axis deviation can be.
So there is some change in shape of the femoral head. There could be more synovitis component into this because of the joint space and everything. Plus, it's going towards Mali was telling early arthritis. Okay. What would you do next? Any other imaging you would like to do?
Like to get an MRI of the.
What classification you know?
Picket and arm classification.
What treatment would you like to give right now?
Currently good.
It shows stage 1 stage.
Comes under,
what stage they had written in MRI report? Sir is asking. Okay.
Stage 2B because
They wrote stage 2B. Okay. Bilateral involvement on MRI? Yeah. No, you want MRI basically for that also, right? You want to see the bilateral involvement. Okay. What would you do now? Patient 2.5 months, disability has set in, pain is there, and he can't. What would you like to offer to the patient? He stopped, you said he's not using his two-wheeler now. Night pain? Any night pain? Use the word night cries. I want to stop you there. Don't use night cries for an adult patient. Nobody will get up and cry. It's only for children, tuberculosis. That was why it was described. So you say night pain, which disturbs the sleep for the patient. Okay. No night pain. Okay.
Sir, this comes under class 2 of cut and all. I would like to preserve the hip by doing core decompression. I would like to get MRI.
Sir? MRI is a report. Actually, you have the report? Bilateral. No, read it out. Stage 2B bilateral. That's what this is.
Stage 2 indicates that there is presence in positive.
Is there a fracture?
It's a subcontinental upset where there is stage 2A conservation. There is which
yeah, but there is no major collapse or anything, any
there is no collapse of the pulmonary or now there is any incompetence.
I asked you any other views you want.
Lateral.
No lateral. No lateral. So what are the options you are thinking of? Any medical management you know? Bisphosphonates. Okay. Then? The expert is sitting there. Sir, just to summarize. For the treatment.
No, I mean, 2A, up to 2A, I think nowadays even bisphosphonates people are trying out. That's, it works. The spectrum is quite different. Not all avians behave the same way. So, if you know that core decompression is up to 2A, it works well, that's good enough. If you say bisphosphonates, I think they'll be quite happy with that. But beyond 2B or 2B and 3A, people are doing redirectional osteotomies to get, that all depends on how much of the head is involved. If it is a small sectoral area, you can, people are doing rotational osteotomies for that, so that works. Ultimately, in 3B and 4, if it is not, you wait if the symptoms are not too great and then offer a total lip replacement.
I think the philosophy is now to wait for the patient to come back for total lip, so till then you can give the bisphosphonates and see how the stage progresses, how soon are, and of course other things, not to sit squat and all those things, activity restriction and everything.
The one other popular procedure popularized by Dr. Magoo and others is so-called reverse bone grafting. They have refines which they core out the cancellous bone up to the defect, up to the affected area, then drill that area, curate out that area, and then the same graft that they have taken from the channel, pack it into that area. That's popular, so if any examiner from Rohtak or that area, you better explain this.
Bone marrow aspirate concentrate.
Okay.
Bone marrow aspirate concentrate.
Anyway, you just stick to what your institution does, what you've been taught. That will be the standard answer. As long as what you've seen, that will be the safest thing.
Having said all this, there is no hard evidence for any of these. Neither the first foraging operation for fibular grafting was 1960 something. And since then they have been doing this for avian, and they have tried. Campbell also talks about vascularized fibular graft. Though how that vascularized remains vascular once you put it into a big hole into the femoral neck and the head is something which is debatable. There is no hard evidence for any of these things, including the last article which came up from India, Indian Orthopaedic Association journal. It is there, which talks about bisphosphonate, vitamin D, and B12 and a combination of all those things. Again, the end point of this outcome is based on total hip replacement. But if you follow up avascular necrosis natural history, it may last 10 years or 15 years. So using a THR as an outcome in 5 years or 10 years is not a reliable method. So until we have reliable, the problem is you can't compare. Every case is different. The extent of the femoral head involvement is different in every case. So anterior sector, posterior sector, whole sector, 100% involvement. How much of the head is involved? You have to quantify, look at the time duration, and the physical activity of the patient, and then take account. So you may have all these questions being asked by the examiners, but remember, there is no hard evidence for any of these. You can look up Cochrane database on this. You will not find hard evidence on any of these. The ICMR has set up a committee looking at PRP, stem cell research, because ICMR is now charged with all stem cell use anywhere in orthopedics and related conditions. There is a committee set up. I'm aware of it. I'm part of it. That's why I know about it. And we are looking at everything. And we haven't found any hard evidence for any of these things. So until the ICMR comes out with the final guideline, you should know the guideline. Definitely the Indian Ministry of Health guideline will be coming out. But that will take quite some time. But as of today, we don't have hard evidence for any of these. But you should know all these, because any examiner, say from Rohtak, he might ask you about reverse. Somewhere else might ask you about vascularized tubular grafting. Somewhere else will ask you about code decompression. You should know all these and also the outcomes. Okay. And you should also know about the Hinduja article and also Dr. Bakshi's article. But all these have been tried, but no clear evidence.
Safe is for you to say what you do in the institution, right? What you have seen, and of course with the backup of the knowledge and the evidence, your internal will be there, he'll help you out with this.
Anil, one word. Again, what I am saying is not for the exam. I agree with Matthew that there is no level of evidence. And the other things of the surgeries are anecdotal reference. Bisphosphonate publications are there, particularly more with denosumab, and there were some more chemical agents were tried, I don't remember. But recently, the vascular endothelial growth factor has been studied, and a synthetic stimulator of that has been tried. Unfortunately, I don't remember the name, and the studies are going on showing good effects. I mean, this is the thing is, it is a, see, when Murthy told about bone marrow, it is going to be a PRP extract, then PRP came, from PRP the various fractions are coming. After a lot, vascular VEGF, vascular endothelial growth factor, is relevant because it is primarily a vascular problem. So as I stated, the question is, you can't isolate a single vascular growth factor. This is a chemical stimulating that. I forgot the name of, and I am not able to remember, but the study is encouraging.
Okay. Good, Sagar.
Thank you.
Thank you.
Thank you to the chairpersons for this talk. Where I'd like to ask Dr. Surendra Kamath to felicitate Dr. Anil Bhatt. And Dr. Rajesh Gupta. Thank you, sir. So moving on to the next session, it will be on talk on spine examination. Inviting the chairpersons for this talk, Dr. Mohan Shivaram, Dr. Rajagopal, Dr. Srinivas Reddy, inviting Dr. Srinivas, Dr. Rajamani, who is going to be giving the talk on spine examination.
Good afternoon to you all. I think all of you are fully flooded in the hip. I think for a change they have brought spine at the end. I think nowadays all the young men rely more on Google and then YouTube for exams. And sometimes you use That's why I'm not going to give you the regular clinical examination of the spine which you have got then access to all these medias and the doors. And over a period of time, what I felt the candidate is missing or what is expected of the candidate, either in degree or the national examination. I'll give some tips and then we'll go to the examination section where in discussion rather than in this. And spine examination usually boys get scanned in a spine case, sometimes boys get scanned, oh spine. No need to get scanned. Whatever whether it is an orthopedic case or a spine examination case, if you have a systematic approach, you will not miss anything and you will not be far wrong. And what you need to know about the spine examination is the basic neuroanatomy, not like an anatomy which is supposed to be known by a neurologist or a researcher. You are supposed to know about the basic neuroanatomy, comparing to the spine and spinal cord. And spine examination is a combination, nothing new is spine examination. It is a combination of orthopedics plus neurological examination, which includes inspection, palpation, movement, measurements, and other system terms. This is a regular, something like which all these 2 sessions in the morning you have to do it. And the same thing is spine also. In addition, you have got some special tests for spine and then basic neurological examination. And basically one thing is listen to the patient. Whether it is an orthopedics or only the spine, you listen to the patient and they give the diagnosis. You interact with the patient. Target-oriented interaction has to be there, and the patient will give you the diagnosis. Not only in this, but also in orthopedics also. Sometimes you meet the patient is assisting the patient for exams. Maybe visiting the center for so long, if you ask them, they give you the diagnosis, they need not also. So that also happens sometimes. So talk to the patient, listen to the patient, have a good interaction, they give you a diagnosis. And most of the times there are 2 things based in the exam based. One is the pain, another is the paralysis. That's what commonly in the cases are kept apart from the deformity they want to touch upon. Because the other is many sense. So when regarding these 2, you have to know about this thing only. This can be only by the interrogation in the patient. You can make a diagnosis. But basically you must know what is the difference between radicular pain, radial pain, referred pain and radiation pain. And particularly radiation pain comes along the nerve. Commonly we have a sciatic nerve, part of the back, comes to the region, back of the leg, and then to the foot and the rate or the medial side or the lateral side. And then referred pain, there is no segmental or no institution. Girdle pain is the same root pain involved in the thorax and abdomen. You must know this. Then the claudication is another very important, it is a clinical enigma even for experienced people. You will not have any findings most of the times. You will have pain, claudication pain. But even in clinical examination, the majority of the differentiation between the vascular claudication and the neural claudication is by history. What only thing is examine the patient after some exercise, probably you will have the pulse will be different. Otherwise, everything may be normal. Then you say lumbar consistosis and diagnosis in the examination, and the examiner will ask you what findings you have got. You will keep quiet. But when the examiner while talking to you, he will ask the patient to walk for some time, and then the examiner will be weakness. So whenever you have neurological claudication, differentiate by the meaning, by the history plus pulse, and then ask the patient to walk for a while and then examine again before you present the case. That's why when you present the case, everything will be normal. When the examiner presents the case, after some exercise, probably he will demonstrate some deficiency in those situations. So these are all the things mainly you come across in spine case, but these are all the things mainly can be interrogated and then come to the history. For example, a radicular pain comes on the medial side of the foot, probably it is F5. The more on the lateral side, it will be S1. That's on the patients, but then we give the diagnosis by MRI side. Even sometimes, even nowadays, patients will come to the MRI and say that they have seen in our chambers. Sir, I have got F5 years old, whether you give their endoscopy secretary. That much they are aware of it. So, talk to the patient, sometimes they will give the diagnosis. Then, regarding the paralysis, you have to ask what is the onset, what is the progress, whether it is motor or sensitive or both. For example, caries spine, any paraplegia due to the caries, mostly sensation will be intact, mainly motor involvement. And then you ask for all the three has to be tested, motor, sensory, and the visceral. All the three components of the spinal cord has to be tested. And the diagnosis, when you get the case, paraplegia and quadriplegia, you have to tell about the etiology, and then you are supposed to tell about which vertebra is involved. You have to find out which tendons and the landmarks are there or posterior, and then you have to there are 33 segments are there. And then it is, you have to find out according to the clinical level of vertebral level. You have to calculate what could be the probable cord or it could be cord equine. For example, there are 33 vertebrae are there. The spinal cord do not extend till the coccyx. It stops with the L2. So you calculate the segment by clinically vertebral level, and then correlate +1 for cervical and then +2 for upper dorsal, and this basic formula is there which you will not in undergraduate level. So you calculate the vertebral level, then you calculate whether it is spinal cord or the cord equine. Then there are already 31 nerves are there. You must know this basic. Then you must know sensory. Most of the time they will conclude percentage of spine case, they will say sensory area sensory loss is there. Sciatic area sensory loss is there. You mind it is not the referral system the case is given to you. You are going to be then allotted a spine case. So you talk about the dermatologist or you talk about whether it's anterior column or posterior column. That is what is expected out of you. Don't get confused yourself medial area, lateral part, radial area. They don't confuse the peripheral nerves with the spinal cord. Then coming to the motor, you have to see whether it's an upper motor neuron or lower motor neuron. It is very clear that. That is mainly the reflexes, spasticity, etc., which is very basic. Then blood and bowel. This is what you have to interrogate the patient, whether it is a flaccid type of bladder or spastic type of bladder. You are not allowed to have urometry in that examination, but you have to ask the patient whether he can hold on or continuous Jubilee. This last one bladder is mainly by the interrogation you can find out the conclusion. And then whenever you give a disproportional case, which this somehow or other you may get to look from outside. It is a L4 or fetus or L5 or this. Just we'll ask you, why do you say it is L4 or fetus? Why do you say it is L5 or this? Which is what? That is the question we ask, nothing else. So basically, you remember the anatomy, there are 7 cervical vertebrae there, but 8 nerves are there. So in the proximal cervical, the root is going, the C1 nerve goes proximal to C1. So naturally the C8 will be distal to the C7. So the T1 will be next to that. And between the cervical and the lumbar, you have got only one nerve which is going transversely. But sorry, cervical. For the lumbar, you see one existing nerve, one traversing nerve. This is you should understand. And then when you ask why you say this, when you say the L5 is good this, then the question is asked why you say. You have to say whether there is one sensitive component, one motor component, one reflex component. Mind it. For example, L5 is good this. Why you say L5 is good this? You must say FHL is weak. You say you have to say sensory numbness is over S1 segment, and probably ankle is lost. The same thing L4 L5. Why you say L4 L5 is what you say L5 is? You say aegis weakness is there, sensory weakness is there on the L5 segment, and there is S1 is not involved. Something like that. Why you say a particular disc and a particular root is involved? One you see whether one motor is examined, one sensory segment is involved, and one reflex. All these 3 things is essential to give you diagnosis of a radiculopathy in that particular disc. This is very important. And you have to know about the development. This is nothing new. Probably you are studied in your first year. You must know about this. So we don't expect what is full endoscope, what is minimally invasive. We don't expect all these things to your level. You know what you read in this your first year MBBS. If you answer this, probably we don't ask much. We don't expect much from that. But there should not be any flaw in this dermatology that you are examining. How to examine? Go from normal to abnormal area. Always easy to locate. And then talk about whether it is, as I told you, what column sensation, anterior column sensation or posterior column sensation, you go with the dermatome level, not confused with the peripheral level. And this level is very important. In the limbs you can say M1, S2, D, medial side, lateral side. But these things are very important. Nipple area M4, T4, Zipisternum T7 and umbilicus T10. But common confusion will happen in several places when you have C7 involvement is there. Supraclavicular nerve may overlap over the clavicle. You are not supposed to have a sensation the infraclavicular level which may be supplied by the supraclavicular nerve which comes from above C5. So that is one area regarding sensation there will be a snag in that. You have to remember that. Then coming to the motor examination, apart from tone and bulk, majority of the time say you ask the patient to lift up the they say it's normal. Don't do that. Examine the hand grip. T1, patient will be able to lift up wrist, but hand grip will be poor, maybe at the level of T1. So do not forget to examine specifically the hand grip. And then tell about the Malhotra levels. This is the Malhotra service level. Once again, do not repeat again. The majority of the time, quite often, it's repeatedly attending classes. You come and present already, muscle is not working. Please don't do that. And then muscle power, you must know how to test. In proximal, always you mention about grooves, hip flexors, extensors, abductors, and adductors like that. Distally, individual muscles, for example, I told you EHL, FHL, something like this. So distally, you have to test the individual muscles, and proximally, you have to tell the grooves, flexors, because more than one node is supplying a particular group of muscle. Not one muscle is doing the action. There are 3 or 4 muscles doing, there are 3 or 4 nodes supplying one, so you have to examine the grooves. That is distally, only one node to supply a particular muscle. So you test that. You need not start from 0 or 5. Start with grade 3. If grade 3 is there, go 4 and 5. If not, you come down 1, 2, I think. So it is simple to start with the grade 3 and then either progress 4 and 5 or come down. That is the clue you are supposed to have. This is what the chart is simple to remember. 5, 6, 7, 8 and T1. All the groups, the same way lower limbs also. You must know this is basic. What is the Malhotra, the suffering, the flexors and extensors. Then this is Beaver's sign. This is very, very important. Upper limb, lower limb, we have got the specific motor level. But in the thorax and abdomen, we don't have any motors. Most of the time they say whether they say the Beaver's sign, they say yes sir. Then the question will come whether it move up and down. Sometimes they will say move down. It cannot move down. Either it will be stationary or it can move up. If both proximal to D2, distal to D1, both are paralyzed, it will be motionless. Umbilicus will be motionless. Sometimes the distal to D10, the umbilicus will always move proximally. Never say the umbilicus is moving downwards. It is not possibility at all. So don't forget to see the Beaver's sign. If you do have a problem between the dorsal and the lumbar, whereas D1 proximal, you have got muscles to examine. Distal T2, you have got muscles to examine in lower limb. In between, rely on Beaver's sign to find out or to locate the motor. So Beaver's sign is very important in examination. Then coming to the reflexes. I am not going to tell all the triceps or these things. These are all the reflexes which you should not miss. Balance, there are many ways of testing the balance. Which I am not going to detail. You can go see the YouTubes. All these things are there. But diversity sign, I am going grade 2, planning on the other toes. It is upper motor neuron. Let's not doubt. Then movements, especially in cervical myelopathy. You already plus the IVP joint of the middle finger, all the other fingers will go. Something like birds, you have got this movement in the upper limb and inverted reflex. And then the cremastic reflex. Whenever there is a corticose spinal tract is involved, corticose spinal tract is involved, cremastic reflex will be absent. And then the last superficial reflex is abdominal reflex. Majority of the time, probably you will give the case of cerebral area. So in the Cerebromelia, either abdominal reflex will be absent. So these are the all four reflexes are more important than as like any other reflexes which we commonly do, superpediatrics, severity, biceps reflex, knee jerk, all these things. Apart from that, these are other three four reflexes which is very important. And then coming to the bladder, as I told you, you interact with the patient, they believe whether it is incontinence or it is spastic bladder. Most of the time they are not very clear. It is very simple to remember. Literally neurological bladder, there are 45 types of neurological bladder, this is said. That is not our bother issue, neurologist bother. You bother about two bladders as long as you are concerned, whether it's an upper motor neuron bladder or lower motor neuron bladder. It is very simple. Upper motor neuron bladder is a spastic bladder. Lower motor neuron bladder is a plastic bladder. Failure to store. The accidental bladder is distended, it gets spasm, contracted, it gets interrupted. That's an upper motor neuron bladder. So it is proximal to D11 because center is S2, S3, S4. As I told you, the vertebral level, the spinal cord level usually do not correspond. That is why the definition is very proximal to D11. It is a spastic type of bladder. Simple to remember, it is failure to store. Where it is a lower motor neuron bladder, it is a plastic type. Failure to empty, there is no tone at all, so it is plastic. So it is Zonas syndrome or a cardiac event. Where it is no tone is there, it won't distend it, so distension with overflow. The treatment is simple. When it is a plastic is there, drugs are there, motor templates, you can have a motor stimulation, motor is there, you can implant advanced measurement, advanced treatment. And this one utilizes spasticity. Drugs are there. So if you understand basically it is a spastic bladder or plastic bladder, everything is very simple. These two things only it is expected to give from this one. Apart from that, what you should not miss in general examination is the limb length. Morning I told you. And the measurement, of course, arm span, whole leg span, all important for Tarala syndrome or Marfan syndrome, which I am not going to much. And the cutaneous markers, sometimes maybe we get it in a short case for you in the examination or regular examination. Cutaneous markers like knees, how many criteria are there, so many black marks are there, hair is there, all these things will give you a clue that there is something wrong with the intradural or intraspinal problem. And then finally, do not go carry away with that this is simply a scoliosis. This is a case of impact myopathy. So you examine the hands and examine whether the sensation is involved or not. If the sensation is intact and the muscle is weak, deformity, it's a classical case of myopathy or syndrome. So you examine the patient, general examination, these are all the things that are essential to rule out other problems. Then coming to the nerve root stitch test, usually we do it in a scientific now. That is SLR. You can do it with Darcy question. And that is you flux the heel joint and then finally you Darcy flux the angle. There are so many tests as you sign or I am not going into the detail of those name wise. So but Darcy flux the ankle joint is very important. Sometimes patient is not able to lie down flat. Don't simply say I am not able to find. There is another way of doing SLR. Making patients like this, keep it in, extend the knee joint, and then you Darcy flux the ankle. This is another indirect way of doing an SLR when the patient is not able to lie down. That's what we call it as a seated SLR. And then this is femoral nerve stitch test. Very rarely you get a case of high upper lumbar LTL space where femoral nerve stitch test. You must be very cautious in this patient because this may have a psoas spasm due to psoas abscess also. Identity. You must be very careful. So to differentiate between a psoas abscess and the femoral nerve stitch test, you can do femoral nerve stitch test like this, which will be able to this one. Then the next is the examination is sitting. Morning, you know, in the case, we saw how to differentiate scoliosis due to spine or scoliosis due to the lower limb problem. Maybe the patient sit up. If the patient is going to sit up, the scoliosis vanishes with the problem in the lower limb. The scoliosis per se regarding the spine limb per se is even up to 60. So to differentiate between the steep and spine, whether the scoliosis is due to which one, make the patient sit up and see if it is there, then going for Arnold's test. Straight away you are going for Arnold's test. You do the examination sitting and then go for Arnold's test. Then just expansion measurement is very, very important. When you have a hip case or a spine, you see ankylosing spondylitis. It's very, very important. If you check this ankylosing spondylitis, both hip joints is involved. Whenever a bilateral hip is there, please check this acromion joint and then chest expansion. Probably you may give a case of ankylosing spondylitis. And then foot examination is also very important. Both ways. Foot problem may be due to the spine, or foot problem may be due to the proper pathology in the spine also. For example, one side varus, one side varus. One toe is missing. This is absolutely a congenital. Either both varus and varus will not occur in the same patient with a congenital. Probably it may be an arthrogryposis deviated. Or there may be a spinal problem. Otherwise, both the pure simple congenital problem do not occur on one side varus, one side varus. You see that it is the one toe is missing. Probably this patient is not whole length of fibula is missing. So always spine problem, between the foot problems always look at the spine. So this is spinal dysrhythmus, where you get a small swelling in the lower junction. This is a spinal dysrhythmus. There is a lipoma inside patient, there is a lot of deformity. In fact, we trace from the back. Fail to see in the back. See in the foot, there is opposite deformities on both sides. As I told you, regular congenital not possible. So such probably something where the spine may have an answer. So finally, spine examination is nothing new, don't get panic. Know the basics, simple basic anatomy with a systematic approach so that you don't miss anything. And of course, radiology to confirm the diagnosis. Don't say simply MRI always. There are many things which cannot be brought out by MRI. For example, segmentation defects, very difficult sometimes unless the clever in any of this is pointed out. Otherwise, simply X-ray you can locate the segmentation problems or the medulla. So do not underestimate the X-ray, because majority of the time what it is you do the examination straight away is MRI. Please don't do that. Start with the basic X-ray, special view, lateral view, special views, and then going for a MRI. Don't straight away jump into an MRI. Then of course the last one you make a precise diagnosis and proper planning. I think with that I stop rather than go into interact with the spine case, rather than going for classical, you see the alignment, you see the curve around the side of what you can see in the YouTube very nicely rather than me talking. Thank you.
It was an excellent presentation by Rajkumar sir. He has made it very simple. Just I want to just tell you about the things. Always as a postgraduate student, I also felt spine is very difficult. Thing is, when we compare other joints, like in hip joint, it's quite symmetrical, both the side and right side and the left side. But in the spine, what happens is from the C1 to L5S1, joints differs. The orientation of joints, facet joints. In the lumbar spine, it will be in a sagittal plane. If you come to the thoracic spine, it becomes in coronal plane. So to understand the joint anatomy itself, as sir said, understanding the neuroanatomy is very important. Once you understand this anatomy of the joint, at each level, we have 50 joints in the spine. Both 25 this side, 25 right side and left side. Once you understand this anatomy, it makes your surgery or treating the patient much more simpler. And whenever we had a discussion of the hip joint arthritis, same arthritis affects these joints also. You take it rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, all arthritis affects this joint also. How the joint behaves, hip joint behaves, the same way our facet joints also behaves. So one thing I want to tell you people that as a postgraduate, you have to know about the anatomy, facet joint anatomy, at least lumbar spine, facet joint anatomy you should know.
Thank you, sir. Now we proceed to the next session on spine examination.
everything good is compared to before. Now the postgraduates are ready to present the spine in the exam. Otherwise, previously they will comment and say, I don't want spine. So I have even changed many times like that. Now that problem is not there. But the problem now is invariably spine is there as a short case also, particularly in DNB. That is a little difficult.
Especially in DNB, they are keeping spine cases. Now spine itself is a super specialty.
Controversial subject, but deformities like scoliosis are kept even in DNB some areas. But as such, they are now ready to accept the students postgraduates. That's a good thing. That's a good thing. A good step change.
As a postgraduate, you should take up a spine as a specialty. So most of the time which I have felt, what I have seen is, most spine is hijacked by the neurosurgeons. I want more of orthopedic surgeons to get into the field of the spine and take it as a specialty. And trust me, it's quite easier than regular orthopedics.
I can tell you, over, I think almost more than 30 years, 30 to 35 years, number of people who have failed due to spine is much, much lesser than people who failed the hip. Ajit, actually I want to tell you after your hip, this thing, very, very nice talk. Just want to tell Dr. Matthew in Trivandrum, I think, demonstrated you were talking about the vernier calipers for measurement or something. Matthew does it with our goniometer beautifully. So you said that the vernier caliper and demonstrated as usual. Matthew is different from none of us. That was it's not a vernier caliper, but it's a long goniometer. You can use it like that. Anything you want to say, Matthew?
Why do you say it is a radicular pain?
So because she tells us the pain starts at the posterior aspect of the neck and it's shooting back which goes up till the tip of the nose. And it's also coming to that the pain is also associated with tingling sensation of both her hands, and coming to the lower limbs, the pain is associated with tingling along with numbness of both lower limbs.
Both lower limbs, as I told you, the whole lower limb is both whole lower limb is numb, or in specific area the patient says.
She feels that the whole lower limb is numb and heavy.
Okay.
things. One, just what he asked you recently about the radicular pain. Fine. One test is axial and radicular. But if you are saying it's a radicular pain, along with it, the intensity of the pain is also important. You should specifically ask. And one time you said the pain is progressive in nature, then you said it is relieved by, excited by exertion and relieved by rest. Am I right? And then rest is relieved by physical activity. I just didn't hear it properly. Physical exertion, I heard.
The pain for upper limbs is exaggerated when just a household shows physical activity.
Upper limb is more by activity of the upper limb, you mean. Okay, and what do you mean by rest for the spine? Because the spine is at rest only when lying down. You said it's not relieved by lying down also. That's what you meant? It is relieved or not relieved?
Since the past 1 month, all the symptoms have activated. So since the past 1 month, even on lying down, her pain is not relieved. So she's got pain around the
That is relevant to axial pain or the radicular pain? Because if you are talking about a pain in the back, even with radiation, if the pain is after walking, I would rather ask whether you sit down, bend forwards, is the pain relieved? That is more relevant because the spine takes rest only when you are lying down. At any other stage, it is loaded. That is one thing. And along with the progression, this pain has been progressive. In what way history indicated to you that the pain is progressive? She used that word, then it's fine.
1 year back, when the pain initially appeared, it was on and off. But now she's having it continuously throughout the day. So in that sense, the pain has been...
So from intermittent pain, it became continuous pain. Because the pain is progressive, it needs relation to the activities. Also, it is not just the intensity of pain. She could walk more, she would be walking less, her physical activity is less, she is not able to go out of the house. Something you have to combine with, is there a limitation of her activities or modification of activities of daily life?
Activities once again, whether she is walking, climbing up, climbing down.
Yes, sir. Since the past 1 month, she's complaining of clumsiness and weakness of both her lower limbs. She's finding it difficult to
After walking.
Even while walking, she's finding it difficult to stand up and walk without support, and she needs someone's support to walk. And while walking, she feels that she's about to fall down.
Okay.
This has been appeared only since the past 1 month.
See, what releases the pain? When pain aggravation also, there will be some factors which will get the relief of pain.
She's been taking on medication.
No, activity oriented, not on medication. For example, I told you, bilateral pain, for example, radicular pain already, you didn't say whether it is pertaining to one particular nerve root. You say both lower limbs. That's where you have to delineate. One particular nerve root means only one nerve is involved. When both lower limbs are there, probably it could be more than one, something like a coordination. So when the bilateral pain is there, your system must be still more oriented to activity oriented, something like climbing up, climbing down, this is more painful. Walking, pain, then take rest, then pain gets relieved, she is able to walk for the same distance. So when the pain is there on both lower limbs, very vague, you must look into that also. Activity oriented, activities which release the pain, you must highlight on that. Is there anything like that?
Only on rest the pain reduces. On lying down, the pain reduces to a certain extent.
Sitting and all do not reduce the pain.
She's in pain even when she's sitting.
Then after, say, how long after the rest she is able to walk again? Then not ask it. You must ask it. How long after the rest? Whether she is, for example, 100 meters she walks, she felt, clumsiness means you have to be very clear. Limb is weak, become weak and then seek rest, or it becomes spastic and then release because you still upper limb also. That's what I told you. It's target oriented. It could be a problem of the neck which manifests both lower limb first or simultaneously both. So you must be very careful when you have a history both upper limb and lower limb is involved. Okay? Yes. as I told you, pain, you will have a presentation either pain or paralysis. A lot of information has to be done with regarding pain. Okay.
Pain associated with early morning stiffness, relieved on activity, as sir said, okay, indicates that joints are going for arthritis. Okay, so with the movements, the pain will come down. Early morning stiffness with backache, low backache, it's a classical thing of facet joint arthritis. You can come to a conclusion, to diagnosis with proper history itself.
One more thing about the pain. She is 60 years old, am I right? 46. Okay. Is the whether the pain is continuous or intermittent? See, intermittent doesn't mean that continuous doesn't mean that pain cannot increase and decrease. But pain is there all the time. It may go up, come back to the same, but never goes back to no pain. In a continuous pain, it is particularly when you are dealing with it's either from an infection or a malignancy. All others are intermittent. They come, go, at a certain stage, it might become permanent, but there is a definite gap. Particularly if it is an elderly person, it's very important. It could be degenerative or primary or secondary.
She also complains of tingling and numbness about the lower limbs in the past 1 month. She doesn't complain of any fever or loss of weight or loss of appetite since the past 1 year. There is no history of any trauma or no history of heavy weight lifting, no history of fall. There is no previous history of similar complaints previous to the 1 year visit.
Any disturbance about visceral functions? Bladder and bowel?
She complains that there is increase in the urinary frequency, but there is no urinary incontinence or bowel incontinence that she is observed in the past 1 year.
Broadly, can you, what do you understand? We are not asking for a diagnosis. Whatever is said, where will you go? Is it not traumatic or is it degenerative? Is it infectious? Is it intermittent?
Probably a degenerative cause.
Is it instability?
No, sir, because she is complaining that her radical limb is more predominant than her lower back pain, so most likely not an
What would be the classical pain of instability without neurology?
Pain that
What kind of pain? Yes? Pain? Correct. Okay, it's a girdle pain, not radiating down, but with this history you really cannot pinpoint, you can think of. Carry on the examination.
One more thing is just said about her. She's on walking, she feels a clumsiness. Okay, the clumsiness, she cannot feel the sensation or less. That means the tracts of the spinal cord are involved. So the clumsiness word, when we use it, we always come to a conclusion this, somewhere the cord is involved more than your nerve roots. Yeah, this has to be kept in mind, right? And other personal histories like smoking, it becomes very important, especially we are seeing among smokers, these problems are more.
On a general physical examination, she's a middle-aged female who's moderately built and conscious, oriented to time, place, and person, and cooperative. She has pallor, no icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. There is no nystagmus or involuntary movements like hemibolism, chorea, or athetosis. No squint, and no voluntary or involuntary tremors. Coming to the examination of the spine from the back. On
the gait.
She has a spastic gait, and she assumes a stoop posture when she stands up, and she's got a spastic gait, which is assisted.
Make her to walk.
Not
Especially when you are examining the lumbar cases, just you have to see either there is a limp or a wrist. Okay, whenever the list is there, it indicates that patient is suffering from list with radicular pain, indicates that patient has got somewhere the disc in axilla of the nerve root. She stoops forward. That indicates that our spine is not balanced. When we take the sagittal balance, okay, when we draw a plumb line, okay, that's in sagittal balance what it says, it's not balanced so much.
Another thing I want to mention, that Ajit mentioned during his thing, that things are not what it was in 20 years back. Today, just the relevance to you demonstrating her gait. Today things are different. We are happy that we are having a patient to demonstrate. Like I said, in other countries they are disappearing. But everything you do for the patient, you might have taken her consent before examining. Explain to her. Everything you do, you have to explain to her what you are doing. Take her consent, then only you do. If it's straight line racing test or what test you do, even gait, it's our responsibility to do that. And reassure that we are not trying to do any harm to her, meaning that I think the disease will not decrease. This is going to be essential for all of you, not just the examiners also, noticing whether you are explaining to the patient. During DNB, there is special marks for counseling. How will you counsel the patient during what rounds we can ask you? That's all to teach you that we have to take the patient completely, even for each test. Please remember that, and it is equally important in your practice.
On inspection from the back, there is no short neck or web neck. There is no swelling or scoliotic deformity that was seen on examination. There is no visible paraspinal spasm, and there is no visible step deformity that was seen. And there is no obvious pelvic obliquity that was observed on inspection. On examination from the lateral side, there was the patient had assumed a forward stoop posture. There was no exaggerated lumbar lordosis or kyphosis. And on examination from the front, bilateral shoulders were at the same level, and the chin was in the central position. Posteriorly, also see for the inferior angle of scapula and bilateral PSI at the temple of venous level.
Anything else you see? 36, 26, 38. Any change in that?
For the trunk arm distance.
Normal?
Yes, sir.
Okay.
Trunk distance is equal on both. On palpation, the patient has tenderness over C4 to C7 spinous processes, and also tenderness over the L4 L5 spinous processes.
The most commonly asked question is, how do you elicit tenderness in the spine? What are the different types? Just tell your colleagues.
So there is direct tenderness wherein we palpate directly over the spinous process. And then there is lateral rotated tenderness wherein we palpate, give pressure and give a rotated movement to analyze tenderness. And then there is direct thrust and also the annual test.
Which method is the most sensitive method to elicit the tenderness?
So usually direct tenderness is more sensitive for any pathology that's happening in the posterior part of the vertebral body of the vertebra. And when we give rotated tenderness and if there is pain, it usually indicates pathology involved in the body of the vertebra, anything anterior to the pedicle.
When you say gross tenderness from C4 to C7, long segment, same thing in lumbar. Is it associated with any paraspinal spasm?
No, sir, there was no paraspinal spasm.
How will you find out whether there is any paraspinal spasm?
We look for the central furrow, if at all there is any deepening of the central furrow, or if at all the paraspinal muscles are becoming more prominent on.
Any other way of finding out whether there is any paraspinal spasm or not? Anybody? Flo? You should not go asleep. Just wake you up. Any other way to find out paraspinal spasm? Apart from inspection, he said, why I asked this question? He said there are 4 segments. When there are 4 both segments are painful, it must be associated with some difference. That is usually difference in paraspinal spasm. See, when you stretch the muscle which is having a spasm, it will become more prominent. That is basic. So you do still more flexion of the cervical spine, probably patient will have resistance automatically will become very prominent. That's another way of testing it. Okay.
I don't know if you, those in the back heard it. The previous question asked by him is a regular question which invariably will be asked to you. How do you elicit tenderness? He answered correctly, no problem. Second question about the spasm. Many people do not know how to elicit a spasm. That is different from spine compared to other areas. Same test is there by a name of the person described for the hip and joints. Here it is different. You already answered that. You didn't hear, you have to ask.
There is no local rise of temperature, there is no palpable swelling or no palpable deformity, and there is no palpable step anywhere along the spinal cord. Coming to the range of motion of the spine. Of the cervical spine, the patient is able to touch her chin to the chest, but she is not able to extend her spine to look at extend her neck to look at the ceiling. And the patient also finds it difficult to touch her for lateral flexion of her cervical spine, where she is unable to touch her ears to the shoulders. Lateral rotation of the neck is also restricted about 0 to 30 degrees. Further, passive rotations is associated with painful spasms.
You should know about the normal range of movements in cervical spine. For example, when you say yes, you should know which joints is acting. When you say no, you should know which joints are acting there. Okay. And this is about the axial cervical spine. And when you come to the subaxial cervical spine, so that's C3 to C7, should know how much the rotation occurs. Where does the maximum rotation occurs?
Yes, sir. Atlanto-axial and Atlanto-occipital movements are fine. Normal. Yes. C4 to C7 segments, spinal process. Yes, sir. If whatever her movements that is on lateral flexion, suppose 0 to 30 degrees, she is able to do. Spurling's test, we stand behind the patient, sir. And then we ask her to extend her neck completely, and then
please look, whenever you do a test, look at the patient. Is an exam anywhere in the world for anything. You are doing something, when the pain comes, you have to stop. If I were examiner,
so we extend the neck and then we give a lateral flexion of about 30 degrees and then we give a downward force. Any pain that's elicited on this movement is Spurling's positive. Pain that is radiating, basically the radicular pain is reproduced on Spurling. And lateral flexion. On Spurling's, Spurling's is positive for her. She gets radicular pains. On the outer aspect of her, my Yankal Tosin Nokkano, Noppekadun Chapali. Ekadun Noppi.
Don't do that again. Twice you have done.
So just at the same time, just ask her like she feels any radicular pain in the fingers. If she she says that's thumb finger or in your index finger, this goes for a C6 dermatomy movement. Okay, say simple. This is good C6. This is C7. This becomes C8. Okay.
same way what we do in sciatic nerve stretching test, the same way also we have got a medial nerve stretching test and this thing we have want of time I didn't cover that. Okay, go ahead.
When the patient enters your OPD with what the sir said, with this attitude, indicates that definitely he has got cervical disc problem. Okay, and keeping this in this attitude, the nerve roots relaxes more and there will be a relief of pain in that position.
Not only that, he is deloading the spine. These are muscle spasms. If it is due to an infection, it's a continuous one. If it is here, as it is stimulated by your loading of the spine. In these cases, if you deload the spine, if you take the weight of the head off from the neck, the pain comes down. So whenever you do movements where the muscles are put to movement, the pain comes down. That is the reason of various postures giving the pain. Because in all that, in some extent, to great extent, you deload the spine.
As sir said about the muscular pain also, you should keep in mind, especially trapezitis mimics like your cervical disc syndromes. Okay.
Movements of the thoracic spine, rotating movements of 0 to 40 degrees is present both on right and left side. And movements of the lumbar spine, she is not able to touch the floor with her fingers on forward flexion. There is about 8 centimeters gap between the tips of fingers and the floor. Extension of the lumbar spine causes pain, and lateral flexion of the lumbar spine, she is able to reach, the tips of fingers is able to reach the knee, which is acceptable.
Is it normal or reduced?
Extension is reduced.
How do you say reduced?
Extension of the lumbar spine is 0 to 25 degrees.
Because this is why specifically he asked this, because you got the luxury of comparing the other side in the hip and upper limbs. Here we don't have comparison. Each one has got their own standard. Then you must ask how long how far you are doing, now what you are doing, that you must ask. Not just like that touching each. So for example, can you touch your great toe? Can you? Try. I can't. It doesn't. So this final examination, moments is individual standard is there. Not like other joints where you can compare the other side or right side, other side. You can't compare here. So ask the patient whether it is there. What was the movements you were able to do, whether she was able to squat or she was able to put down the straight. Now is there any restriction is there? You must come out like that. Not just like that 40 degree, 30 degree. You can't set a standard. They have own standards.
Degree. You only said that. Later. Can you measure, like you say, hip 10 to 40 degree abduction, like that? Can you tell here? That I can. You can. How do you measure? Anybody? This question was asked by one girl long back, I think about 20 years back in one of our teaching programs, one girl from Andhra. She is now a consultant. She asked, how do you measure the cervical spine movement? I did not know. Quite some time back. Then I went back and read the book. It is given in the book. But that is different from what we do it today. That is given in the book. Today, by goniometry, you can measure all the goniometer. It is given in the book. In the last presentation, somewhere also. They can do. But like I said, there are no two spines. But you still, in the follow-up, it is very useful. And secondly is you are not expected. Basically, nobody is going to question you on that. But there is one more movement. In always we talk in, say, hip joint, active movement, passive movement. How about here?
Any passive movement more than what she is able to is associated with pain.
Okay, passive movement is what you did. I mean, what you ask her to do is active. And there is a passive movement described in the book. But again, it is not necessary at this stage. There are three movements, active, passive and resistant. It's very difficult to do a passive movement. It is possible. But we will not go into that. But you have just mentioned this all are active movements. Okay, Kaya.
And on modified Schober's test, there is an increase in the...
Anybody wants to know about how to do Schober's test? Because today all the postgraduates know. So I am not going to ask him. Was your person sitting in the back and sleeping, not allowing us to sleep? So you should at least ask questions. What is the result? Since they don't want to know, we will not tell them. Okay.
And there is no limb length discrepancies. And modulus robust it increases by 6 centimeters. So the two points are 15 centimeters apart. On flexion, it's between 21.
I should say that it showed normal movement. That is, from 15 it should become 21 or more. If you want to tell, if you want to tell the examiner you did, say if test was 20 centimeters, fine, he knows that you have done, and nobody is going to verify that, I can tell you.
They come and verify at least if you have a mark, otherwise you can't just say sir 10 centimeters. Some examiners will come and see whether this fellow has done it or not. Yes.
Why so much interest on that? If they know that test is there, what does the Schober test show you?
Flexion and the low.
What is that? What is that? You measured something. That what you measured is not flexion. What you measured is the length. So what does it show you? It is only in the lumbar spine. So if I want to show the movement of the whole spine, how do you measure that? How do you do it? Is it possible? It is possible. How? Same way only, start from the tip of the most prominent cervical vertebra to the line you made. And flexion and extension. That's what the. Why then this lumbar spine? Because in the ankylosing spondylitis, the restriction is more in the lumbar spine and early in the lumbar spine. This test came for that. And then we probably think this is less, all other movements will be less.
Go ahead.
Coming to special test, Sperling sign is positive and Hoffman sign is positive. Lermit sign did not.
Hoffman sign positive. Demonstrate.
Can you demonstrate?
చేయవండి లూజ్గా పెట్టుకోవాలి ఏం చేయకూడదు సరేనా
This side? Both sides.
లూజ్గా వదలండి ఏం చేయకూడదు
Okay.
Explain what happens.
Yes.
Explain so that they see also. So we ask to leave the hand free, sir. We stabilize proximal interfacial joint, and then the distal interfacial joint is flicked, which will cause flexion of the other knee.
He told me this is something like a balance scale in the lower limb. See that? See all the other fingers are going. Go, yes.
Come to special test of the lumbar spine. Straight leg raising test was negative. And coming to neurological examination of the spine.
Everyone should know about straight leg raising test. What is straight leg raising test? What is cross leg raising test? Okay. When it's positive, within 0 to 30 degree, what will happen? 30 to 70 degree, what will happen? These things are very basics. Okay. Right.
She told us she doesn't have that radical pain on lifting up to 70 degrees.
Except the knee joint?
You
pass it into it. You dorsiflect. You keep extending the knee and then dorsiflect. See, that's what I show you. When the patient is not able to lie down, you make the patient sit like this, keep the knee extended, and then do the dorsiflexion. If you once again pass it, the patient will lean back. The principle is stretching the sciatic nerve, that's all. So, SLR is negative. Agree. Seated SLR.
Described as one of the method to make out a person who is not having, but he already knows when you lift up the leg, he must say you. So that painful. So it was described by a person, I forgot his name, and the fight test to. It's called Mallikarjuna. That fight test is described by. I told somebody names I forget now.
neurological examination, higher mental function. Her consciousness, orientation, time-based person, and cognitive functions and speech is within normal limits. Cranial examination did not show any abnormal deficits. Motor examination, there is no obvious muscle wasting of the upper or lower limbs. Bilateral is the same, sir. And tone, upper limb tone is normal, bilateral lower limb tone is spastic. Upper limb tone is normal, bilateral lower limb tone is spastic. Power, upper limb powers, C5 and C6 myotomes normal, C7 that is from this elbow extension, the power is 4/5. And power of the lower limbs, L2 to S1, the power is 4/5. Yes, reflexes, abdominal, coming to superficial reflexes, abdominal reflex is mute, and plantar reflex shows Babinski positive, and bilateral upper limb, her biceps, triceps, supinated reflex is exaggerated, lower limb, her knee and ankle jerk is exaggerated, and ankle clonus is positive. Coming to sensory examination, in the upper limb, see from the C6 dermatome up to downwards, sensory examination of both the anterior and lateral spinal column, that is touch, pain, temperature, and pressure is reduced. Her in the lower limbs, her proprioception and two-point discrimination is reduced, and anesthesia she is not able to, is also absent in the lower limbs.
Individual dermatomes?
Yes, individual dermatomes from upper limb and lower limb. From C6, she's got radial sensations.
Okay. Both sides?
Yes,
bilateral, symmetrical. Symmetrical. All sensations is radial. Okay.
And it involves in the posterior column, in the vibration sense, anesthesia, two-point discrimination, proprioception is absent.
Yes.
She's not able to tell. Yes. I'll make it fun. నేను ఇది పైకెత్తాను, పైకెత్తే పైన అని చెప్పాలా, కింద కింద అని చెప్పాలి, సరేనా? కళ్ళు మూసుకోండి, కళ్ళు మూసుకోండి. ఇప్పుడు పైన కింద ఉందా? ఇప్పుడు పైన కింద ఉందా? ఇప్పుడు
I know what Matthew is looking for. Yeah. Stand up there.
పైన కింద ఉందా ఇది?
How you hold, that is where you hold, how you hold, that's all important. You know, you just hold up the joint and then try to move. Don't try to hold the tip of the finger and tip of the toe and then try to move the entire toe. That should not be done.
Check for the proprioception by the position sense. So in this,
you stabilize the proximal phalanx here, and you could do it this way. This is the commonest mistake. Many of these patients, they may have loss of proprioception, but they may have deep touch sensation present. There are different tracks. So when deep touch sensation is present, when you push here,
she would sense the pressure
and identify who is being pushed below, so it's going up. If pushed above, so it's going down. So you do not do this in the dorsolateral direction. You do it in the mediolateral direction. Stabilize this and then do it like this. And the way to do it is flip it up and down and then ask her, is it up or down? Ask her whether it is down. So there is a 50% chance that she may guess right. So you do 3-4 times. Because there are only two choices, up or down. So it's very possible, randomly she may get every time right. It is possible. So we need to do it 3-4 times. Up she says. Obviously she is guessing. Okay, so now you know she is guessing.
Down.
Down.
Again down.
So that's the way you do it 3-4 times to be sure that she can make what I should. Because the stabilization is important, where you hold your finger is important. Because otherwise patient will get the pressure sensation and will answer correctly.
Go ahead. Time is getting late, make it fast.
Yes, coming to visual examination, there is no anal tone is intact. And,
how are you tested? You are tested?
Not because we took with the history.
No. Tone is intact, you can't say by history, you can say incontinence or something. Tone, unless you were PR, it's not possible. Don't say like this by history, no. Okay. You say simply say I didn't have low or I didn't do PR. Don't say, otherwise you will be in trouble. How to test? No. Okay, yes. Yes, go ahead.
Examination of
conclude your history and positive examination points. Yes.
She
come to diagnosis. What do you think?
Probably a compress.
Plantar extensor. Okay. Yes, make it fast.
Compressive myelopathy involving the cervical spine. Looking at the lesion.
First thing, you just come to a conclusion. Either there is a spinal cord involvement, proper cord involvement, or even nerve root involvement. Two things are possible, only things. One is either radiculopathy, or you can have to think about myelopathy. Okay. So the patient gives a complete history and examination wise, upper motor neuron lesion is there, tracts are involved. So the most your diagnosis should go towards your upper motor neuron cord involvement. That's the myelopathy. Involvement of the proper cord itself. Next proceed. How you want to proceed? Then as sir said, level, you have to know about the level.
Sensory level is at the level C6 and motor level at C7. So probably the vertical level at C5, C6.
C5.
So you know about that rule, how to predict the cord level and the bony involvement level?
Cervical spine we had one, sir. Thoracic spine, one from T1 to T6 we had 2. From T6 to T9 we had 3. And T10 would be L1, L2 and T11
right.
Okay.
Which is the highest? Sensory, reflex, periodic, anything else, and then cut the bony level, and then look for the complications, if there is anything else. Whatever, if it is tuberculosis, cold abscess, if there is something else, whatever complication.
Myelopathy sensation is intact.
No, sensation is reduced. From C6 levels is reduced. Motor from elbow extension.
What sensation is reduced?
Touch, temperature, pain.
Temperature you tested? Don't just like that say, because each one there is a very important sensation. Which one will go first, which one will recover first. So just like that, the same way you get caught up. The same like you told you, anatosis is intact, you told, you got up. The same way, if you don't test it, I have not tested temperature, simply you say that. Because there are points for that, because among pain, among 2-point discrimination, which one to go first, which one to recover first, everything is there. So just like that, don't say temperature, everything is tested, no. Okay? Yes.
Yeah, what do you want to do?
Possible,
Yes, possible
possible
diagnosis.
Degenerative.
All right, okay. So what do you want to do?
Degenerative myelopathy, you want to keep it as a diagnosis. Okay, how you want to proceed. And don't use the word compressive. So if you use the word compressive, so we might, the examiner will think that you have seen the X-ray or MRI scan and all. Okay. So keep it as simple myelopathy, degenerative myelopathy, okay, or degenerative cervical disc if radiculopathy is there, involvement is there.
Okay, what will you do?
X-rays of the cervical spine.
One question I ask you, why the pain was they started in lower limb and then upper limb, something like that. Any idea?
If at all there is a compression of the cord from the anterior aspect, the lower limb would be involved.
No. I'll come to you later. Tell you. Go ahead.
This is the AP and lateral view of the X-ray of the cervical spine, which shows loss of normal cervical lordosis on the lateral view, and reduce this spaces between from C2 to C6.
See, when you first see the lateral, this is not a true lateral view. Okay. So what you can appreciate the facet joints there? The joints have gone for arthritis, most of the joints. First thing you should know how to count the cervical spine. So the most prominent one, which one is the C2 there? Okay, I have a pointer. Just okay. Can you show me the odontoid process there? Yeah. Take a pointer and just show it to your colleagues. Okay.
This is C2.
C2 spinous process. Show me the C2 spinous process. Yeah, that's one. Can you appreciate the odontoid there? So next thing is C for C7, spinous process.
This is the most longest.
Okay, for want of time, you see the alignment, you teach each and every vertebra, both AP and lateral view, you concentrate, see the perivertebral shadow, and then alignment anterior body line, posterior body line, facet, spinous line, spinal junction, and then the AP view, both alignment, you see the face, everything you see. Anything you see abnormal in this, for want of time, we are just pushing off. Anything else? Any inference of this?
See, just I want to add, see, you have to see for the lordosis of the spine. Minimum 10 degree of lordosis should be maintained. Otherwise, to plan your surgery, if you're thinking about cervical myelopathy, either we have to go from the anterior to decompose the spine or from the posterior. Minimum 10 degree of lordosis should be maintained in the cervical spine. When you see your lateral X-ray, okay. If it's not there, then you have to go anterior itself. When lordosis is maintained, you can go from posterior and decompose the spine. One thing. Another thing is you should learn how to locate this cervical rib in AP view. You know how to identify the cervical rib? Okay, when you just when you see the transverse process of your thoracic spine, okay, they are projected upwards. But C7 transverse process is projected downwards. If the rib is coming from that C7, it comes from the transverse process which is projected downwards and outwards.
You see the T1, you see here. It's going up. This is going down. Okay, go ahead. Yes. Yes. Go ahead, next what?
Next, what do you want to do?
MRI scan.
Do you have
MRI scan?
MRI is there?
Lumbar spine X-ray is all.
Lumbar spine X-ray.
And you should have this one flexion extension view also to know the stability, cervical spine stability, lateral views.
MRI is there.
X-ray would fit in the diagram.
What do you anticipate in MRI? The pain that it comes. Lumbar spine, X-ray is there. Anything? Once again, you see everything, all parts of each vertebra you have to see. You see the face, you see the eyes, you see the nose, you see the mouth, alignment, everything you have to see. Anything you see here?
This mild
What do you feel? What do you say? There or not? What do you anticipate? What do you anticipate? Something you have to anticipate and then see. Maybe there is different.
Thinking towards a myelopathy. What do you think?
What would be there?
Cord signal changes.
Pardon?
Signal changes in the cord.
Changes in this.
Straight away, without any other reason.
Due to hypertrophy of the
what will you say? You said degenerative compressive myelopathy, what you told. The question was don't say like that. So you said, then next you say because the cord changes is there, that's why you got upper motor neuron signs and whatnot. What could be the reason for that? See that?
See, once you said about the myelopathy, the degenerative myelopathy, okay, then you will come to the conclusion next you have to divide. Either it's a compressive one or non-compressive. If it's a non-compressive, you just straight away send it to a neurologist. Okay, he will handle the thing. Okay, if it's a compressive one, then your role comes. So your role is basically to decompress the spine. What's there now?
Yes.
the longitudinal ligament is.
Pardon?
Okay, you are seeing that posterior longitudinal ligament. First thing is whenever you see the MRI scan, now it has become a very basic to know about the MRI scan, types of images, and you should read this is a T1 image or T2 image. You should know how to differentiate between T1 and T2. Okay, this is a T2, the mid-sagittal section they have taken. So where you are seeing that especially your PLL, posterior longitudinal ligament, has got a very important role. It is a main stabilizer, like what always I say to my fellows and students, how you have a calcar in the femur. Okay, main stabilizing thing. So like that spine we have a posterior longitudinal ligament. It has got thickened. Okay.
Anything else you want to see? That's all? No, you want anything else? Make it fast. One be axial, sorry.
What is this condition called as? Thickening, ossification of OPLL.
See, you don't want to see another view.
Axial view.
See, never in both the X-ray and this one, never come with only one view. In the X-ray, don't come with something with an AP view. You see both views, you need a specific view. The same way you see the axial view also. Axial view is there.
And also the important, as sir said, so you have to see the axial view and also the CT scan to confirm your OPLL. Okay.
If you suspect OPLL, you have to take a CT. Why?
Because we ossified, so it will be.
Bone lesions, simply bone lesions will be very brought out by CT. MR is not sufficient to confirm that. So bone lesions always take CT. Soft tissue problems always take an MRI. So if you suspect OPLL, going for a CT. Okay, with the OPLL, what will you do?
Stop. See, it's, if you know to read this, like this is MRI scan, have a pointer pen system. Okay, just see. So this becomes your spinal canal. Okay. So this is your vertebral body. This much is your OPLL. This is ossified posterior longitudinal ligament 1. And this is your cord which has been compressed in the spinal canal. Fine. So this becomes your joints and nerve roots escapes like this. And this is your vertebral arteries. Yeah, it's okay.
Yes, go ahead.
Require decompression.
Decompression. Very good. Anterior, posterior? Anterior. Okay, that much is enough for you. There are a lot of things we can go on and discuss. Anterior, posterior, problem, this and that. If you say compressive myelopathy, do a decompression. Anterior, posterior, something you have to tell and justify. We don't argue why you say anterior, why we will discuss. We have got a separate we will discuss. You say compression myelopathy, you decompression. Anterior, posterior, whatever thing you say, we accept and then we leave it as far as you are concerned. But when we talk, we say why anterior, why posterior, this and that. And one point to be remembered is lordosis. If there is a lordosis, always go for anterior, don't go for posterior. That's a simple fact. So you do decompression. I think with that, for want of time, we will shut down. Decompression is there. Once, depending upon what you are going to decompress, you have to add up stabilization. And always spine says mainly one to two things. Decompression, stabilization, and fusion as and when necessary. These three things you remember. Okay. Thank you.
Quite good. Quite a good job.
So now I'd like to ask Dr. Rajagopal to felicitate chairpersons. So use may I request Dr. Rajagopal to felicitate Dr. Rajamani. Dr. Srinivas Reddy. Dr. Surendra and Dr. Surendra Kamat. we'll have a 10-minute tea break before we start the next session. anyone who's interested in taking cases for tomorrow, please give your names today, so that tomorrow there is no confusion. And we can allot you cases today itself, so that probably you can even prepare and come for it. Tomorrow, you can see on the program list, you know what all cases will be kept. So if you're interested, you can tell us now itself, so that we can allot you cases today itself, so there's no confusion tomorrow. We'll be starting the session on nerve injuries, chaired by Dr. Anil Bhatt and Dr. Surendra Kamath.
Good evening, sir. So myself, Dr. Yogesh, I am a second year DNB resident from Bijlani Hospital, Ashok, Bangalore. So today I am going to present a short case of breast drop.
We will make it a long case.
Sir, my patient name is Chitra Prasad. He is a 26-year male, software engineer by profession. He is a right-handed dominant person, and he got a there's a history of RTA.
What's your diagnosis? We'll make it really short now.
What's the diagnosis? So my diagnosis is wrist drop and finger drop post-traumatic due to this thing.
Wrist drop, finger drop is not a diagnosis. It's a deformity.
Wrist drop is not a clinical diagnosis, it's a deformity.
So, post-traumatic high radial nerve palsy.
That is the diagnosis.
With wrist drop and finger drop.
Post-traumatic
high radial nerve palsy.
What is low radial?
So, high radial nerve is it's more proximal.
Sir, one second. So, please don't, when you present the case, don't tell wrist drop, foot drop. That is not the diagnosis. The diagnosis is what is the same thing. Which nerve is involved? What is the etiology? At what level is it involved? What is the duration? Is there any other associated complication? So can you reframe your diagnosis? Left-sided?
Left-sided, post-traumatic, high radial nerve palsy with
duration.
It's chronic in nature, since 1.5 years.
Chronic trauma, is there something like that? Chronic trauma?
No, sir. It's 1.5 year.
Why is it in a nerve injury? Time is very important for us. 1.5 year old.
Yeah, 1.5 year old.
Okay. Right. So why do you say now it is post-traumatic? Why do you say there is high radial nerve palsy? Type of injury.
So
in fact, if you go further, we also would like to know whether it is recovered, partially recovered, not recovered, all these things in that diagnosis.
Sir, on examination, I find...
No, what is the type of injury sir is asking? In your diagnosis?
It seems to be an axonotomesis.
Seems to be an axonotomesis. Recovered, not recovered till now? Or partially recovered?
Sir,
you've examined history, you know, you've done the examination, everything.
Partially recovered.
Partially recovered. Okay. Now we will break down each one. What is the trauma now?
Sir, it's a mid-shaft humerus fracture with both bone forearm.
Not complete. Open, close. First thing I want to know.
Sir, closed fracture.
Closed humerus shaft fracture and both bones. Some people again both bones they'll feel bad. So
proximal radius and ulnar shaft fracture.
Okay. How do you know it is proximal radius and ulnar shaft fracture?
Based on the scars.
Operated?
Yeah.
Both were operated.
Yeah, both.
Okay. And why do you say it's radial now, pals? You said high radial now. For me as a hand surgeon, it's high radial now, low radial now. Radial now and posterior trochanterous now. So median nerve you can say high and low because median nerve is same median nerve only. Ulnar nerve is ulnar nerve from the entire stretch. But for radial nerve, it is radial nerve and becomes a posterior trochanterous now. So, yeah, that is why. So,
triceps weakness is present, sir.
No. What about brachioradialis?
Yes. But we also accept this high radial or low radial? Very high radial.
Very high radial, low radial.
So why do you say this high radial now? Why do you say high radial? I'm just giving a little more respect to the posterior trochanterous.
So because of triceps weakness and as well as supination of the forearm is also absent.
What are the muscles facilitated directly by the radial now?
So directly on the arm they are supplying triceps and enconius and brachioradialis and extensor carpi radialis longus and supinator. They are directly supplied.
Supinator is not supplied by radial. So triceps, brachioradialis, enconius and ECRL. Right? Out of these, what are paralyzed in this patient?
So triceps is paralyzed. Then ECRL is paralyzed. And Brachioradialis is, sir, it is also paralyzed. Brachioradialis is paralyzed.
Triceps generally escapes paralysis when you talk of a humerus shaft fracture. Can you demonstrate the triceps power? Can you demonstrate on the normal side and on the affected side?
Sir, ask the person to extend one leg.
Talk to him. He knows.
Sir, try to extend.
No, what are you showing us?
So we are check for the triceps this thing and against gravity against
Sir said in his lecture you start from which grade first? It's spine or peripheral nerve, doesn't matter. The principle is always the same. What grade you start with when you ask the patient to demonstrate muscle power?
Grade 3.
So do grade 3. Why are you holding him and doing? Just do grade 3 now.
Just try to do this movements against this. Yeah.
So that is grade 3. Okay. Now go to grade 4 now. You know he is doing grade 3, so show grade 4.
Try to extend.
Where will you give the resistance?
On the forearm.
Why?
To give a resistance against the.
Where is the muscle attached? Inserted distally. This is the only case, nerve case, I think. So we'll go a little detail. These are basic things you should know, right? So you don't give resistance so far away somewhere wherever the muscle is not even there. So you give resistance just distal to the insertion of the muscle as much as possible, so that your lever arm, the way the muscle works, it will be more convenient for the muscle to act. So give insertion. You did tell where it's inserted. So if you don't know where the muscle is inserted, then it's difficult. Triceps insertion. Morning, the statement was made whether you do any harm when you go outside after MS. So this is okay. Molecular process, right? So there's a broad insertion of that.
So 3 heads, medial head, lateral head, and long head.
Okay. High radial.
Sir, no. Medial head, I think, is supplied proximal to the spiral groove, and long head and lateral head are below the spiral groove.
So classically, where is it involved? The nerve. In a humerus shaft fracture, classically. A closed humerus shaft fracture, which is the classic site of involvement of the nerve. The spiral groove. Okay. So demonstrated on the normal side now.
Sir, here the active shoulder movements are absent.
No. Huh?
Active shoulder movements are absent. So this is
Absent. Why? Any particular reason?
Does he have a break?
No, you said is a high radial nerve palsy post-traumatic with humerus shaft fracture. Now suddenly you say shoulder movements are absent. Any particular reason? No, you examined, no?
Yeah.
Is it stiffness? Is it paralysis? What is it?
Sir, maybe stiffness because of
No, maybe. You examined.
So it is stiffness only.
Stiffness. What is the duration of the surgery now? Post-surgery, 1.5 years.
Yeah.
Huh?
Sir, and then he had an implant breakage. So for which he again went to the revision surgery.
So it's more of stiffness. Okay. But can't you test triceps without abducting or anything of the shoulder?
Eliminating gravity, I can try. But
No Vidya. Kannada Bharata. You have any pain? When we move? Okay. Right.
Actually, active flexion is not there, sir. I have to support his we will try to just try to extend.
He doesn't know extend, so we tell him.
Straighten the elbow. This thing, supporting the Sir, MCB joint if you're stabilizing, then the extensors are able to work.
Elicit good motor power. One is pain, second is stiffness. So you should know that. That's why I asked initially first, does he have pain? Then there is stiffness of shoulder and elbow also. So you might not really get your triceps action. Okay, but you should be able to at least feel for the contraction when he's trying to do that. And you can actually feel that the triceps is contracting. Okay, so that probably tells that the triceps is not paralyzed. So what is the next muscle you would check for your high radial? Brachioradialis. Okay. So in usual clinical situations, triceps is most of the time spared. Majority, 99% of the time spared because the supply is quite high. In a humerus fracture, I'm talking about. Ankylosing you can't test clinically. ECRL you can't really differentiate from ECRB, right? Unless you really look at the tendon. But most of the time, so the only definite muscle you can check is brachioradialis. So for you to differentiate between high radial and low radial, The only differentiating muscle is brachioradialis.
Brachioradialis will ask the person to, one is the action is the flexion of the elbow in mid-prone position, another is the supination. So, supination of the forearm.
Which one? Brachioradialis.
Sorry, flexion in mid-prone position.
You should talk less and do more. Maybe you will. Yeah.
Just try to.
It's the same principle, doctor. It is inserted where? Insertion where is brachioradialis inserted? Now is in trouble. You are doing DNB in Orthopaedics.
Yes,
Radial styloid. So give your resistance, just listen to the radial styloid. That muscle contracts very nicely. You can see that, very nicely it stands out. So brachioradial one muscle you should not miss. It's a very good muscle to test. Yes, do it now this side. Here also he has some elbow flexion, so you can test it actually. And again he has stiffness because the forearm is fixed in mid-prone. No. See, expose the area, you have to see the muscle and you have to feel the muscle. Both you have to do. Okay? So support it, ask him to get it inside. Leave that. Yeah. Try to do that. Try to get it inside towards you. Yes. So it's not contracting, it is not also getting prominent. Okay. Right. And then wrist of course is not extending, finger is not extending, thumb is not extending. So that's why you say it is high radial now. Okay. Why do you say it's axonotmesis? Yes. Sensory, will just before sending sensation, did you check?
Yes, sir. Sensation I checked. The sensations are intact on the.
Just help yourself.
Only the sensations are present on the dorsum of the first space. I check for radial now. As well as the tip of index finger and little finger.
Thank you.
They are intact.
That is the autonomous zone, but you should know the supply entirely. It's not just only the autonomous zone. Okay. Sir is asking about
dorsum of the palm.
Tibia sign.
Tibia sign was absent, sir.
Absent. How did we check?
We check for tapping the nerve along the from distal.
You are showing median now. Radial. Which now?
Radial now, sir. Yeah. Radial now you have to tap from distal to proximal along the course and you have to check for the tingling numbness sensation along the distribution.
Okay. So why you thought it was axonotmesis?
Because there is no recovery of motor functions.
It is not recovered. At least brachioradialis is not recovered. Right? Okay. A closed injury, that's why I asked you. So a closed injury with an associated fracture or dislocation generally results in axonotmesis. That is based on the history. First point. They have operated now. I'm sure they would have seen the nerve during the surgery. The nerve will be intact if it's an axonotmesis. Okay? It won't be damaged, ideally. There might be some contusion sometime and this one. But if the nerve is lacerated or any caught in the fracture fragments or any of those things damaged completely, that's to be taken as neurotmesis only. So that would be documented during the surgery. But before that, without that, all these things, how do you diagnose axonotmesis? It has to be closed injury, first thing. Okay, and then ideally should recover. Why? A neuropraxia should recover ideally, an axonotomy should recover ideally. And neurotomy you have to repair as a surgeon for it to recover. This is the basic principle, right? An axonotomy has to recover because the sheaths are intact. The perineurium, the epineurium, all these are intact. Okay, the axons are damaged. So axons have to grow back. Unless there is some other problems. What are the problems you anticipate in this? It's not recovered here. Why?
Sir, 1.5 year.
By now it should have recovered if it was axonotomy. Was the nerve damaged completely during when they operated the patient? Did they notice the nerve was damaged? Was the nerve explored? You won't be aware unless you see the OT notes. But then, what are the possible reasons you should remember, or at least know why axonotomy doesn't recover? It can be engulfed in the callus. It can be engulfed it can be caught between the plate. All these can happen. So many reasons can happen. If there is an infection and then plate, you said plate breakage happened. Why is that? Based on the history at least, can you tell us?
There is no history of trauma as such. And,
why did the implant fail then?
Maybe because of excessive stress at the fracture site.
So in a patient like this, yeah. Based on the history, what did the patient say? Did he have paralysis immediately after the fall, after the trauma, or?
So actually, the patient has not noticed the things. Whether he had paralysis after injury, he came to know after surgery. He has not noticed it after the injury.
As per the patient, he is not noticed after the injury, but after the surgery, he noticed it. Okay, fine. Right. So you should understand if at all it was axonotomy, ideal situation, patient was operated, we have to see the nerve. Most of the as I was telling, we will go to the posterior approach. We will document the status of the nerve. We will put the plate. We will also document where the nerve is running on which hole of the plate. All those things should be documented ideally. And then you wait and watch, right? So how long will you wait and watch? These are the classical questions asked in radial nerve palsy. So everything is done, everything is nice. Nerve is intact, how long will you wait and watch? What's your guideline? Do you do any investigations? Do you do any tests? So you do a nerve conduction study, document the baseline characteristics, and then you have to repeat it. Okay? So clinically, which is the first muscle to recover after this kind of injury, in a closed humerus shaft fracture?
Triceps will be the first.
Triceps usually won't be affected. if you go and see the anatomy where that's why sir asked, where is it innervated, where the nerve branches come off for the radial, from the radial now. So the first muscle you check, no? Right? So the questions are asked by patients also nowadays, by examiners also. How long will you wait from, if it is a lower third, classic lower third spinal groove fracture, you've operated, what is the time taken for the nerve to recover, for the brachial radialis to be innervated? You should know the distance and all those things. Anybody? So the nerve recovers at the rate of? Right? So you know the approximate distance, the brachial from the lower third humerus to brachioradialis, between 12 to 16. Right? So you calculate that. Okay? Add 1 month for the validity regeneration, and regeneration will start. Okay? If you do that, you will get approximately how many months? 5 to 6 months. 50 to 60 days you will get. So that's what you need to tell the patient, that by about 6 months you will be able to see some clinical recovery. Patients always ask that. Okay? Earliest way you can find out is also doing an EMG at about 5 to 6 months, because the EMG will pick up activity in brachioradialis compared to the clinical recovery. And then you have to wait and see, and then continue with this. Meanwhile, what will you do? He has developed stiffness of elbow, shoulder and all. So ideally, what should have been done?
Physiotherapy, sir.
What is physiotherapy?
Physiotherapy for increasing the range of motion exercises.
So he needs to undergo active assisted mobilization whenever, shoulder especially, passive mobilization. Any split you give?
Sir, dynamic cocker splint for the wrist strap.
Okay. He has other hand normal, so he can move himself. So static cocker splint is most of the time enough. Don't give them very cumbersome dynamic splints with rubber bands and all those things and all. It's not really necessary. And if possible, electrical stimulation. Nowadays, home kits are available for about 3,000 rupees. You can give those kits. They don't have to go to the therapist every day. So you can teach them how to do electrical stimulation. Why are you giving electrical stimulation? Reason for electrical stimulation? Anyone? To nerve won't recover unless you are stimulating the nerve directly. No, you are stimulating the muscle in electrical stimulation. I told initially we are running against time. Time is important for us. What is that which is the end point of what gets damaged over time? The
Now and
what junction? The neuromuscular junction undergoes fibrosis by about 16 to 18 months. So that is your race against time. Before that, you have to make sure the nerve recovers. Otherwise, you have to give electrical stimulation to keep them alive as much as possible. Okay, that's why the duration is very important. Then your nerve surgeries might not work. You will have to go for other procedures like tendon transfers. So that is how you need to answer, looking at the time and the distance the nerve has to travel. Okay. So if you have now finger and thumb drop here, the last muscle which will get innervated would be what? Last muscle to get innervated would be EPL and EIP, index. Okay. Some people tell index, some people tell EPL. They are somewhere in the mid forearm or proximal. So that is where the nerve has to travel all the way to innervate that. So till then they have to be kept alive. Otherwise they undergo degeneration. Even if the nerve recovers, it doesn't matter to them. So you need to. So in this patient, that's what is probably 1.5 years now. It's all become stiff. So your only option now would be what tendon transfer you know. Classic high radial nerve palsy, wrist drop, finger drop, thumb drop. So you need 3 motor parts to be given back to the patient.
So palmaris longus, FDS, extradenosophagealis, and KINES-FCU.
What is the classic procedure described? At least the names you should know for these. It's a commonly kept short case. Anybody?
Jones transfer.
Modified Jones transfer. Okay, people. So you want one motor to the wrist, one to the thumb, one to the fingers. So tell us the motors. So for the wrist, what will you transfer? Assuming the median nerve and ulnar nerve are intact, what will you transfer? The pronator teres goes to ECRB, right in the center so that the wrist can go up nicely. Then you need one for the fingers. So we have either FCU or FCR. Generally we prefer FCR because FCU is a very strong muscle for the wrist action. So we don't take the FCU, but both are described. You can take the FCR and transfer to the EDC. All the 4 slips of EDC, it has to be weaved through. That is there for the fingers. Thumb. Anybody can tell how palmaris longus is transferred to EPL? Palmaris longus stops here. EPL is on this side. So there is no length of palmaris longus to go all the way to EPL. So what do? So you get the EPL towards the palmaris longus. So you reroute the EPL to the palmaris longus. So you get the EPL out from the muscular tendon cut there, get it towards this side. So you get 2 actions now. One, you get the extension, you also get the some amount of abduction. APL is lost by radial ulnar palsy. So you get that also. So that is a rerouted EPL to palmaris longus, or rather palmaris longus to the rerouted EPL. So at least this much you should know. Right? But before that you should get rid of the stiffness, shoulder, elbow, so many problems are there for him. Okay? And you should mobilize the opposite muscles. They all are, he's not been using that hand. So even this is now disuse. So start strengthening. Ideally for a tendon transfer, you should start strengthening the donor muscle first. So check their grade. If it is less, start strengthening them and give time and then do the transfer. But before that, the joint, the 10 principles of tendon transfer you should know. The main problem here is joint stiffness. So you have to get rid of the joint stiffness before you do a tendon transfer, otherwise the tendon transfer won't work. Okay? Right. Thank you.
Thank you to Dr. Anil and Dr. Surendra. Now we'll have a talk on orthotics and prosthetics by Dr. Athani from the Department of PMR. Chairing the session will be Dr. Ashwini Kumar and Dr. Ramesh.
Well, good evening, everyone. Speaking on orthotics and prosthetics, which is a very vast subject, but I will be able to give you an overview in the given time. Well, for bipedal activities, whether it is walking or running, structural and functional integrity of the neuromuscular system is a must. When there is a deficiency of structure or a function, then it needs to be externally supported, and that is where the orthotics and prosthetics comes into the picture. Now, definition of orthosis. It is called by various names. Somebody calls it a brace, somebody calls it a caliper, somebody calls it a splint, all various types of, but the internationally accepted nomenclature is the only orthosis. It is, you should not call it, whether it is cervical collar, or sometimes you call it collar. So it is cervical orthosis or one word wrist orthosis. You should prefer to use the word orthosis rather than using the various words like brace, caliper, collar, all those things. So it is, definition is, it is externally applied device. It is not internal, it is in vitro, used to modify the structure or a functional characteristic of either neuromuscular deficiency or a skeletal deficiency. As an orthopedic surgeon, for you, the knowledge of orthotics is essential because you may not get the desired results as you want. So there will be deficiencies left, and that has to be managed by orthotics. What are the indications? Supporting. For compensating weak muscle, as you all know, poliomyelitis used to be there in good old days. Now, myelomeningocele, cerebral palsy, all these patients at some point or the other in their management cycle will require the orthotic management. Weight relieving, and this is directly related to your field. When there is a patella tendon bearing orthosis or ischial weight bearing orthosis are used for various types of disorders affecting the lower part of the tibia or lower part of the femur or the knee joint. Commonest use the tuberculosis of the knee or tuberculosis or malignancies or osteomyelitis. We tend to use the weight relieving orthosis. Then correction and maintenance of deformities. Now, let me remind you, orthoses are not at all used for correction of the deformity. It is just to maintain. Nobody uses the force with orthosis to correct the deformities. If there is minor deformity or 5 to 7 degrees, you may do so, but otherwise correction has to be done by either other means, but maintenance can be done by orthosis. Protection, ulceration for example, diabetic ulcer where you want to protect, and pain relief. Well, you know better than everybody that temporarily we use the orthotics, whether it is lumbosacral orthosis or cervical orthosis for pain relief. Promote healing and to add length. When there is a lot of leg length discrepancies, more than 5 centimeters, then you cannot do just by compensation in the shoe, but you may have to give the orthosis with a proper raise. Now, orthosis can be used either for a short term or a long term. It is sometimes some people have to use it for lifeline and some people have to use it for a very short time. For example, the patients who are admitted in the ICU or those who are coming to you with spinal cord injuries, vertebral injuries, till the final picture emerges in terms of neurological recovery or neuromuscular recovery, you may have to protect them temporarily with a orthosis. Like in this patient, which is St. John patients, who ultimately recovered, that is, you may have to prevent knee deformities and equine deformities by giving the orthotic, you are right, even when the patient is unconscious. This is for temporary use. So nomenclatures use these foot orthosis for shoe modification, ankle foot orthosis, KFO and HKFO, which means that in this nomenclature, the segment of the lower extremity which is encompassed by the orthosis is mentioned. FO means foot is encompassed, AFO means ankle and foot is encompassed, and KFO means knee, ankle and foot are encompassed in the orthosis. H means even hip is encompassed. So it basically, the code that is used here is, it indicates which are the joints which have come to be protected and encased by or covered by the orthosis. This is the accepted nomenclature. And some of the segments that we use sometimes, like knee orthosis, commonly you call it the knee cage, knee orthosis or hip orthosis, hip abduction orthosis for Perthes or septic arthritis that you use also are segmental, and LSO, TLSO, all you know it. So what are the prerequisites? Orthosis cannot be prescribed so casually. It has to be detailed evaluation of the patient, neuromuscular status has to be found, and externally, and they should not, extremity should not have the fixed deformities, and iliac psoas and hip extensors should have the power, because if the iliac psoas do not have the power, you figure the Aponi caliper, and how will the patient propel his limb forward? He cannot. So the iliac psoas, hip flexors has to be there. Or there should not be any cellulitis, deep vein thrombosis, etc. Or swelling up due to any reason, unacceptable swelling in the lower extremity is a contraindication for orthosis. So principle of orthotic management is pressure, equilibrium and lever arms. Pressure, they should not, orthotic itself should not cause pressure points. And when the person wears the orthosis, he should be able to stand without much wavering. That is, it is really supporting. Third is lever arms. You should not produce such arms by which you produce the deformity rather than correcting the deformity. For example, this is a myelomeningocele child who was ill-fitted with, not properly fitted with, here is an ulcer, one ulcer due to orthosis, and here is another, in this region, you can see orthosis, there is an orthosis-produced ulcer, iatrogenic ulcer because of excessive pressure points of the pads. So this kind of supports which are causing localized focused pressure is not correct. We have to use well-padded and encircling orthosis for those who have sensory loss. It should not be just like this. So equilibrium I mentioned to you. What are the components? Components are normally shoes. It starts from the shoes, then joints, ankle joint and knee joints. Then connecting these two are called as structural components, that is the uprights. And then you have cosmetic components. Some people want the cover to be put on that. And interface components are the only components which come in contact with the patient, like shells, pads, straps, and foot orthosis. These are the ones which are the only components of orthosis which come in contact with the patient's body. For example, this is a good old conventional orthosis. This is a thigh pad which comes in contact with this. These are the structural components. These are the articulating component, joints, again pads, and these shoes. So this is indicative of practically all the components of orthosis which have gone sea change now. This is the, I have already mentioned. So what are the materials? Materials, steel is used, aluminum, leathers, resins, rubber. These days we use basically the thermoplastic. Lot of good thermoplastics and carbon fibers have revolutionized the orthotic techniques. So these have reduced the weight, though increased the cost, but it has become too convenient for the patient to wear lightweight orthosis. And we also have the high temperature as well as low temperature. And for those patients who have the problems of cellulitis or pressure ulcers in the feet due to a diabetic or neuropathic food, then we have various types of material available now, thanks to the material science, which will provide extremely good cushioning effect over the sole or whichever region you want it to be used for example, socket. So these are the, for example, knee joint, hinge, what we call hinge joint with a lock. And mostly we use single axis joints and we use ankle stops. If you want to prevent the plantar flexion, we use the posterior stop. If you want to prevent the dorsiflexion, we use the anterior stop. That also can be done in the joint, which is only asked in examination sometimes. And ankle joint assists are also used to improve the power of the dorsiflexors or the plantar flexors. Now these two are the very commonly asked questions for you. PTV orthosis. It's a weight relieving orthosis. If there is any affliction, infection, osteomyelitis or fracture delayed healing, you may use the patellar tendon bearing orthosis, by which you mean that the entire lower, because of the ground reaction force, the weight is directly transmitted to the patella and over the upper surface of the tibia, bypassing the affected region of the bone. And this is called as flow reaction orthosis, where the foot being in equinus, because of the ground reaction force, it forces the knee backwards and thereby stabilizes the knee. These are the flow reaction orthosis, and this is a PTV. One has to know difference between the two because both look almost same, but here you have the patellar notch and there you don't have the patellar notch. And this is simple off-shelf, available in every medical shop, called PLSO, posterior leaf spring orthosis, which can be used temporarily when there is no valgus or varus deformity. This cannot be used for where the feet which have valgus and varus deformity. It can be only used for the purpose of foot drop prevention. And now occasionally we are getting in this hospital post-polio, though it is all gone, but even then we get old patients who are used to it or who never worn the orthosis. For example, this lady is a 55-year-old, first time in her life she is wearing the orthosis. She can even, but she is quite comfortable. We could manage to accept orthosis for her. Then pediatric age group, let us talk about a little bit more. First thing is we require a lot of shoe modification for the pediatric age groups. in good old days, we used to use the valgus straps as well as varus straps for valgus deformity, and this of late is replaced by the proper shoe modifications like longitudinal R supports, metatarsal pads, and lateral R supports. So these are the various top quality materials are available in the market which can be used for shoe modifications. And for orthopedic surgeon purpose, you use the footwear very often for clubfoot management, and that is you wear Steinbeck's orthos, this one, a hip, what you call the foot abduction brace, and you know how this is to be adjusted and what is the aspects of it, better you know it. But this much I say that foot has to be kept in abduction and external rotation, and the protocol is that open toe leather shoes, metal bar which holds shoe in 70 degrees of external rotation and 10 to 15 degrees of dorsiflexion, inspection hole on the medial side, and low posterior cut to prevent the heel slipping, and bar as wide as shoulder. It should be as wide as shoulder. And this is another one which is made here. Hip abduction orthosis, sometimes we use for Perthes as well as septic arthritis, we used to use, and even some people, some orthotics are in minimal afflictions, we use this video is not running, never mind. Perthes as well as the reconstructive surgery of the hip as well as DDH correction, post correction, one has to use the hip abduction orthosis. This is myelomeningocele. In children, when it comes to child, it should be well fitting, well padded, lightweight, and whenever you give bilateral, giving them gait aids or walking aids become mandatory. No child or no adult can ever walk with bilateral orthosis without using the gait aids. So your prescription has to include also whether you want to use elbow crutches, auxiliary crutches, or cane, whatever it is, you have to similarly see. Nobody can walk with bilateral elbow or any kind of orthosis without gait aids or walking aids. So like which are like, for example, canes, it can be crutches or it can be walkers. Now this, for example, he is using the bilateral, but because he has got good voluntary control, I have just given him, testing him with the elbow crutches. He is our patient with traumatic brain injury. So check out, after doing all this, you have to check out the procedure, whether what you prescribed is fitting him all right, or you not just prescribe on a piece of paper and call him after 6 months. That's not correct. You have to see whether orthosis is serving the purpose for which it is given. So now coming to the amputation part and our prosthetic part. I finished an overview of orthotics. I will be open to you discussion on any points that I have covered. Amputation is a different, it is a structural loss. It is not structural deficiency. The limb does not exist. Whereas orthosis is given to limb, existing limb which is weak or which is structurally deficient. Here it is structurally lost. So yes, you are doing the operations day in and day out, structural severe traumas, mutilating injuries, infections, and malignancies. These are three main indications for doing the amputations. And the commonest, this is one of the questions asked to you again, what are the common levels of amputation? One is transtibial. The difference between amputation and disarticulation also should know. Amputation is through the bone, whereas disarticulation is through the joint. Dismembering through the joint is disarticulation. Dismembering through the bone is called as the amputation. And transfemoral amputation, transtibial amputation, knee disarticulation, and hip disarticulation are the accepted levels of amputations. Similarly in toes, where we do diabetic, for example, or infections, amputation of the toes, Lisfranc's at the tarsometatarsal junction, Chopard's at the mid-tarsal, that is talonavicular, and calcaneocuboid, and Shyam's at the lower end of tibia, including the keeping intact the heel pad and modified Shyam's. There are several modifications. So early prosthetic fitting is always better, and that all depends upon you surgeons. How good you keep your stump. If you fashion the stump properly, we can fit the process very quickly and the patient will get back to the activity. But if there are multiple scars, skin adherent skin, skin grafting, oozing, then prosthetic fitting becomes delayed. So objective is to condition the stump immediately, improve confidence of improve the confidence of the patient and reduce the total time of rehabilitation if you fit it early, and it helps in early rehabilitation. So another question very often asked you is what is ideal stump? Though the concept is being reduced, but because of the advent of technology, but still then you should know. The stump should have the adequate length, In case of tibia, it is around 10 to 15 centimeter from the tibial tuberosity or junction of the proximal third to the distal two-thirds. It should be conical, well-healed scar, and muscle power should be good, and there should not be any deformity. These are the 5 points which you are supposed to mention what is ideal stump. And this is ideal stump, done in this hospital only. Very conical stump, no edema, good muscle, good power of muscle power. Absolutely, it is instantly fit for fitting the process, and I have done also. It is already fitted with processes. He is fitted with this Aboni process. What are the components of the processes? Here, like in orthosis, this is the socket which encompasses the thigh, remaining thigh, stump, and this is the knee joint. There are several types of knee joints available, the cost of which range from 20,000 rupees up to 2 lakhs, 3 lakhs also, depending upon whether the hydraulic or pneumatic. I will come to that very short, briefly. And this is the, again, this of the shank, and this is the ankle foot complex. So this is endoskeletal because we are not earlier it used to be exoskeletal, but nowadays we are using the endoskeletal. So this is a partial foot amputation. Look at this term. If you produce this kind of this one, though everything is good here, just because of this damn scar here, we cannot fit any kind of process. You don't lose anything if you go to the cleaner area and close the healthy skin together. Don't try to play with the thickness, partial thickness skin grafting at the end of the stump. That will totally prevent us from rehabilitation. So these are the various levels in the foot. Those who are interested in the foot, metatarsal level, Lisfranc's, Chopard's, Sym's, and modified Sym's. These are the type and various types of orthosis that we give, process that we give. Most of the times we give only shoe with a filler, or boots with a filler, or a capsule with a filler. So what are the considerations of the design? It should be very, very comfortable, otherwise patient will not wear it. And it should be properly cushioned prosthesis, and process should be stable. It always in Bombay Orthopaedic Society we used to say that the patient should not carry the prosthesis. It is a process which should carry the patient. It should not be other way around. So it should be so light. Patient should not have the conscious of even wearing prosthesis. It should be so good. Like when we wear shirts and trousers, we are not conscious of its weight or anything. It's natural. So it should become sort of a natural for the patient. So stability, lighter assemblies, duration of use, and activity levels. You have taken into account all this. So this is how nicely, this is a cosmetic cover over it, endoskeletal processes with the knee joint, with suction socket, and energy storing ankle foot complex. This is energy storing, but commonly asked for you is Jaipur foot. Jaipur foot nothing but a sach foot. It is a modified sach foot, saying solid ankle cushion wheel, which imitates or simulates the plantar flexion and thereby natural stance phase. In stance phase, you always land on the heel and then you go for plantar flexion and then you move forward. So that is what is missing there. So in cushion sach foot, when the person stands on that, because of the rubber, it produces artificial plantar flexion and it simulates natural mid stance of the gait. And this is of course high-end energy storing. These are called energy storing flex feet. And liners of the socket are also very equally important because most of these days we are getting a lot of diabetic stumps and there are a lot of edema, so you must have the protecting liners. And the commonest liner that we use, that you should remember, is the silicone liners. Variety of silicone liners are available, and some are pull over and some are rolling over. Both are equally good. So these are the liners. Ithaflex, Plastazort is what is very commonly used, plus silicone sleeves. This is silicone sleeve. So this is BK assembly. This is very conventionally made, and this is sophisticated made, endoskeletal. And these are various types of prosthetic feet. They itself is very costly, but they will increase the efficiency of the patient. People have climbed the mountains with this, and people have done a lot of strenuous activities with that. Their life is near normal. I won't say normal, near normal with this. So this is a Aboni assembly. We have for your purpose, for the purpose of controlling the knee joint, we have the pneumatic joints, hydraulic joints, and we have the 4-bar, which will produce, because of its anatomical alignment itself, will produce stability. The purpose of all this is to produce stability. When the person is walking, he should not buckle at the knee. So here we have in the natural course, we have the quadriceps, but when amputation is done, neither there is a quadricep nor there are hamstring. So how to prevent buckling? Buckling is prevented by hydraulic or a pneumatic mechanism. Even if we bend also, we will not buckle. though he doesn't have any muscle power. So therefore, those are the very important. But these are other mechanisms, hydraulic, and our Alimco produces something called as a constant friction, which is the cheapest of the cheap knee joint, and hydraulic is using the hydraulic mechanisms, 4-bar, pneumatic, and now we got what we call intelligent knees. Now we are coming, it will identify in which phase of your gait, whether you are in a stance phase or you are in a swing phase, it will identify itself, and accordingly it will produce the stability. That's called intelligent knees. And improving of stability is wider base, more friction, brakes, move foot anterior, adding friction. This is technological. This much of detail you may not require, and that's what I wanted to inform you about the orthotics and prosthetic. And I hope I was able to give you an overview of orthotics and prosthetics in a given time to me by the organizers of this event. And I thank Chairman Dr. Ramesh and Kumar for giving me this opportunity to speak on a subject which doesn't take the forefront position, but as today it has always taken the back seat, but it is important in the practice. When you sit in your clinic, then you know how important orthos. You'll be calling day and night orthotic. Where are you? You're not come till the patient has come to me. Please come fast. That's what you'll be telling him. But knowledge of orthotics and prescription, checkout, material, ideal fitment are considered, are deemed not considered, are essential for every practicing orthopedic surgeon. Thank you very much. Thank you.
Thank you, sir. Thank you very much for your brief lecture on orthosis.
Thank you so much, Dr. Athani. Now I'll request Dr. Ramesh to felicitate Dr. Athani. I'll request Dr. Ashwini Singh and Dr. Ramesh to continue for the last session for today. Should be on pediatric ortho case discussion. Also requesting Dr. Matthew Verghese come on stage for this chairperson for this lecture.
Good evening, sir. Myself, Aditya from James Gulbarga. I am here to present a short case. Here's a 17-year-old girl named Muskan, who is a student and who resides at Balshankari. The main complaint which brings to her is the complaints of pain in the right knee. Muskan, she is apparently normal. 1 month back when she
Short case, let's reverse the approach. Can you come out with your diagnosis?
Genovalgum of the right knee. Genovalgum of the right knee.
Anybody from the audience wants to comment on his diagnosis? He's a postgraduate exam going, presenting in the exam. Diagnosis genovalgum of the right knee. Anyone? Every diagnosis has an anatomical has an etiological component. So your diagnosis doesn't tell me the genovalgum is because of tibia or femur or both. It's a primary genovalgum or a secondary genovalgum. It doesn't tell me the etiology. Is it part of a physeal injury, or is it part of a nutritional deficiency, or some other metabolic condition? It doesn't tell me the severity of the problem to decide on my diagnosis-based treatment.
It's a it's a bilateral knee, sir, but more she has got more pain on right knee compared to that of left, and deformity is more on right knee.
You decide the unilateral, bilateral, the pain or
deformity.
So, sir, what clear things like what is the deformity, whether it is femur or shoulder, or here is metabolic.
So it's congenital, sir. Since it's a congenital, sir. The patient
Congenital.
The mother says that it was present since birth and it is not yet it's not got corrected, and it has been progressively till this point of time, and she has had on and off pains, and she was
When a newborn baby is born, the baby has genovalgum, is it? So at birth the child had genovalgum. So what is the physiological progression of knee as the child is born and as the child grows?
So initially genovalgum will be there up to 2 to 3 years.
No. 2 or 3 years, 2 years, 3 years is a long time.
Physiological virus, how long it lasts?
A virus
It is known as
physiological, up to 2 years of.
When does it peak?
But why you have that virus?
Anybody from the audience, it is not necessary that he only has to answer. This is for everyone.
Due to stretchability of the hip
Anyone?
The answers, it may be wrong, it doesn't matter here. It's not an exam.
No? When a child is born, there is a flexor tone dominance. So you have no idea whether it is varum or valgum. Because in a flexed joint, you cannot assess the varum or valgum. So if the elbow is flexed, you can't say it is cubitus varus or varus. If the knee is flexed, you can't say it is genovalgum or varum. So flexor tone dominance. As the child grows to be 6 months, begins to sit, the tone is beginning to reduce. When the child is standing, that is 8 months, the tone is still reduced, but still stands with a little crouch. As load bearing comes, there is a tendency for bowing to come up. That's physiological bowing. And as the child stands without support and then begins to walk with support and continues to walk with support, the varum progressively increases. It deteriorates till it reaches a peak of 1.5 years. Once a child is 1.5 years, that is a peak. So when a parent comes to you with this complaint, ki, bow legs, your job is to see, is it pure physiological or is it a combined nutritional or not? So is there any widening of risk? Are there telltale marks of deficiency? Are there telltale marks of rickets? Is there frontal bossing? Is there delayed fontanelle closing? Those things you assess and say, sir, there is no telltale mark of deficiency, no telltale mark of any metabolic, seems to be physiological genovarum. Tell the parents, keep under observation, the no roll of bracing. You just heard, he emphasized bracing not for correction. I see any number of patients being put on mermaid splint, no roll. It's a torture. You're actually punishing the child and the parents both. So 1.5 years it peaks. After that, gradually it reduces till the normal adult genovalgum comes up by 4 years or so. It gradually reduces to begin to just rectus then valgus 1 centimeter, and beyond 7 years, an intermalleolar distance of 5 centimeter or more is beyond the norm. So the physiological valgum is up to 7 years, 5 centimeter. But changes from verum to valgum. So if you say congenital, has to be from birth. So I disagree with your diagnosis completely.
Mother might have been confused. Okay. That is why you are just anything diagnosis from mother's point of view. But you should take it on. You should tell this was mother was behaving like this. Maybe this is that. You have to tell.
If a child has deficiency, severe nutritional or renal rickets or vitamin D resistant or vitamin D dependent rickets in infancy, because renal rickets, renal tubular acidosis, those are birth defects. They may present with early onset rickets. And if that is there, physiological verum gets exaggerated. So a child who presents with at 7 years genu verum has had it from beginning. Worsening of physiological verum. If the child gets a deficiency after 4 years, it will always be because physiological verum is now exaggerated to become pathological valgum. Physiological valgum has now become pathological valgum. So in this case, from what I understand, this will be after the age of 4 or so when the mother noticed. Usually they don't notice. Especially girls, they are covered. COVID rampant. We have genovalgum epidemic during COVID. Nobody went out. Nobody saw the knees. It's only when they post-COVID lockdown is over, they started walking away. I have an epidemic on my hands. Now can you tell me? Repeat your diagnosis. So I want to know first the anatomical diagnosis.
Bilateral. More affected on the right?
Yes. Both sides. Both the bilateral, which component, whether it is a tibial component, vertebral component, how do you make out? We'll ask simple questions.
So we'll ask the patient to in exam.
You demonstrate that it is femoral or tibial or both.
Anybody can do this. Easy questions. How will you differentiate?
So we'll ask the patient to lie down and
do it, no?
Yeah. Right side. Yeah, sir. Yeah. So. Right. So. पैर को पूरा पीछे. He'll ask the patient to flex the.
Just do it.
Yes.
Up till the 90 degrees.
Yes. What has happened now? Yes, it's okay. Now what has happened now? It's remaining same or it is appeared? Reduced.
Intermalleolar distance is almost come to its your condyles are not touching. Your condyles have to be touching. Yeah. Then get just about 2 or 3 centimeters, which is normal. What does that mean? Why? Why should it reduce when you flex the knee? Anterior, posterior. What about it? I didn't understand.
Posterior condyles, the tibial articulation comes and lies on the posterior condyle of the
Relaxes the posterior condyle.
When this
What he meant is when you flex it, the posterior condyles are coming into contact.
tibial.
What does it indicate?
Femoral component is.
The deformity is in the weight-bearing portion of the femoral condyle. The non-weight-bearing portion of the femoral condyle is unaffected. It's a weight-bearing problem. So the weight-bearing portion of the femoral condyle is affected. When you flex the knee, the articulation of tibia is with the non-weight-bearing portion, and therefore the deformity corrects. So when you flex the knee fully, the deformity is corrected. When you extend the knee, the weight bearing portion comes into articulation and you have manifestation of genu-valgus. So you have to draw the midline and look at the asymmetry. Right worse than left. You don't say unilateral, no. Asymmetric genu-valgum, femoral component with right worse than left. With
right with TPL component.
Is there a TPL component? I don't think so. It's normal. You yourself demonstrating, it's almost normal here. Tibia is vertical, just look at that. You can see it hanging vertically.
So it is a femoral component, isn't it? So it is femoral component. Everyone understood why it is so femoral component will disappear? Sir has explained to that. Okay. So what is the ideal component?
Most common with is idiopathic. Most common cause
Idiopathic. Why did you say idiopathic?
There is no any nutritional causes, no history of any trauma or infective pathology in and around their knees, and there was no.
So there is no antecedent history suggestive of trauma or infection, and there is no evidence of any nutritional rickets. Telltale signs of healed rickets are not there. So what are the things that you're going to look for? What are the telltale signs of healed rickets? She may be healed rickets. So you don't find anything.
White line of X-ray, white line of Frank.
I'm talking about the patient. Clinical. X-ray, I'm not going to show you.
Clinically very simple. Anything in the upper limb?
Cupping and flaring, which would have been present.
Cupping is X-ray.
That's a deformity of the.
What deformity?
Wrist
clinical signs now.
So this deformity which can widening can be reduced in healing stage of rickets. And bowing in infants, bowing also starts regressing in rickets, and the person will be more active compared to that pre-stage of.
So the telltale sign depends on the age of the patient. At this age, you may not find anything unless there is active rickets. She's 17, physis would have closed. She'll be post-menarche. The physis would have closed, so I don't think you'll get any telltale signs. Okay, the telltale signs of rickets come up in the growing phase. If growth is not happening, you don't see any sign. If growth is happening, that's the paradox of rickets. If severe deficiency is there, multiple nutritional, protein, energy with vitamin deficiency, you will have stunted growth. When there is stunted growth, there are no signs of rickets. And that's the paradox of rickets. That can be a question from the examiners as the Viva evolves. So here we have anything else you would. So there are no telltale marks of anything. No frontal bossing.
No frontal bossing. No.
No widening of wrist. No rachitic rosary. No. So none of all those things you see in young children, not in this age group at all. So there are no signs of any nutritional or metabolic disease. So it seems to be idiopathic genu-valgus. Okay. Anything else?
Normally we'll have genu-valgum or genu-valgum this age. Any patient for that matter. Anybody?
7 to 8 degrees of valgus will be.
That's a valgus. So when you have valgus, is there any history of patellar subluxation or dislocation? Have you checked for that?
Yes, the J sign, I have checked for it, so there's no patella.
Have you checked?
Yes.
So what did you check?
So I have held the patella with both my fingers, and have normally the patella moves upside down and sideways. If there is any patellar instability, on inspectory findings, if I ask the patient to flex, there will be a dislocation of the patella, and when in the flex position, we can check the stability of the patella by moving in.
When you move the knee joint, you will see mal-tracking of the patella. It adopts a J track. That's a J tracking that it does. Okay. So because of severity of the angle of quadriceps pull, and if the medial condyle is overhanging with lateral condyle hypoplasia, then you may have this more prominently. So you're supposed to check this. They say you're supposed to check for the Q angle. They highlight. So you check the Q angle. How much is the Q angle in this?
On right side it is 30 degrees, on the left side is 15 degrees. On 15, right side is
15, 30. How much is the normal?
So normal 7 degrees in males and 8 degrees in females. Yes.
8 degrees.
15 degrees. Sorry.
You may go up to 20 degrees also. 20, 22 can also be normal. Though it came up as an article, again, you should always look up follow-up articles. There are articles which talk about the irrelevance of Q angle in the decision for assessment for dislocation of patella. Though it may be high, 30 degrees, she has no patellar subluxation. It was thought that it tells you the line of pull of the quadriceps, yes. So when you're deciding a treatment modality for an associated patellar dislocation, you may use that for realigning it. But in a patient like this, you're not going to change the line of pull. You only change the deformity, isn't it? Okay.
Have you looked for any generalized ligament laxity in this?
Yes, Pediatric school, I have access for
What are the criteria that you look for?
So there are 5 components. Sir.
5? I thought there were 6.
Hyperextension of the...
So, no. The reason I am saying this is, I was, taunting him. Never start with, say there are 5 causes. There are 10 causes. So I had one person who said, sir, I remember the first, third one I don't remember. Don't expose your ignorance here. You just rattle out what you know. 1, 2, 3, 4. In your mind, think of 5 causes and say whatever you remember. Okay, let's hear the 5 causes.
Hyperextension of elbows. If it is present on both, we give it as...
You start with the elbow.
With fingers. When flexed with wrist, when flexion, passive... Hyperextension. Hyperextension of the knee. And when standing with both, and touching the foot with...
Last case presentation, she could touch the floor. Not everyone can. They will go up to 10 centimeters, not lower than that. So you know that. And the worst is when you can do this. That's the Baton's criteria. It's actually modified Ruth-Wine-Davies criteria.
Okay? So does she have any of those?
No,
No, she
she doesn't have.
doesn't have. Okay, good. So she is not hyperlaxity. Would it make a difference in treatment if she had hyperlaxity?
In conditions where ligament laxity and conditions where
Like?
Marfan syndrome or Ehlers-Danlos syndrome.
Marfan syndrome, Ehlers-Danlos and Larsen syndrome also. All of them have hyperlaxity. Okay?
Finally, your diagnosis now?
Idiopathic deformity of bilateral genovalgus. Femoral problem.
So have you checked for the hips?
Yes.
You checked. Can she walk?
She
What
walks
will you
without-
check in a gait? What peculiarity of the gait will you find if there is a varum or a valgum?
Varus thrust or
Varus thrust? In this there will be a valgus.
Valgus thrust.
It will be valgus thrust. Because of chronic valgus deformity, the medial structures get lax. Every time she puts weight, it will go medially. It will go medially and the legs will go more. So the weight bearing valgus component would be more than the non-weight bearing. Have you checked that in this? Did you measure both ways? Did you check the genovalgum intermalleolar distance in standing and lying down?
Intermalleolar distance for standing was 19 centimeters.
Not in lying down?
No, no.
So you wouldn't know whether there is a...
No, the same distance is not maintained while lying down, sir. When standing, it is 19 centimeters. Sir. The,
lying down is?
It is decreased up to lying down, just
you're not measured.
measures.
So when you're presenting, you have to measure both standing and lying down. That will tell you, because if you operate her and you correct the structural component, but not the ligamentous component, she's going to complain to you. My knees are still going like that. My valgum is still there. You've not corrected it. You will document in the file. There is a ligamentous component and there is a structural component. I have corrected the ligament, the ligamentous will remain. If it is hyperlaxity syndrome, the ligamentous component will remain. It's important. So you have to assess and document that also. That should be part of your assessment. But you haven't answered my question about hip. Is the hip normal?
And the foot and ankle.
Foot and ankle normal.
What are you looking at for?
Any question?
Secondary pes planus is what you look for. Does she have that? 19 centimeter intermalleolar distance, she is likely to put weight on her medial border. She'll put. So have you looked at her footwear? I told you in Gait you look at the footwear. Which side will wear out? The medial side. Normally which side wears out? The outer border. So in her the medial border will look out. So you'll have to look at the footwear. First see the Gait. Does she have planovalgus? Right side particularly. Right side she is touching the medial side. Anything else which is unusual which you find in the Gait cycle? Anyone? Walk line. Hip. We'll just finish this. Anything you find abnormal in the Gait? The foot progression angle. The normal foot progression angle is 10 to 15 degrees outwards. So when they stand like this, they have genovalgum. So what do? They want to reduce this. That's energy intensive Gait again. So what do? Internally rotate their legs to reduce the valgum apparently. So most of these patients with genovalgum will walk with in-toeing. If it is more than 25 centimeter, she will walk the flex knee also. Like that. I have patients coming to me, referred for flexion deformity correction, and all I did was a growth modulation or an osteotomy to correct the genovalgum. Why? Because they learn intuitively that when you flex the knee, deformity is less. Same logic. Non-weight bearing portion comes into contact and therefore deformity is reduced. Now answer the question on the hip. So this is in the exam a simple case. So this will be a zero tolerance case. If you can't answer even basic questions, you are done in. Just remember that. This is zero tolerance case. Yeah, continue. The hip answer you haven't got.
This is not exam, don't worry.
Try to
To
remember.
stimulate you to read more, that's all. I'm challenging you. It's a simple case, but it's not so simple as it looks. There are lots of nuances to it. Okay? Why should you check the hip?
So when there is the patient, due to Gait, there is a deformity and she tends to rotate internally, so we need to check the range of motion of...
Anyone from the audience? Why should you check the hips? Louder. Anteversion is one thing because she's got an in-toeing gait. Anything else? What is the normal neck shaft angle in women and what is the normal thigh leg angle in women? Is the valgum less or more in women than men? More. Why is it more? Neck shaft angle. Coxa vera goes with genovalgum. So if the patient has a coxa vera and this is a secondary genovalgum, you're again done in. So in the exam, when you're presenting a genovalgum case, don't ever do it without checking for coxa vera. So That's checked with Nelliton's line. You heard in the morning lecture, bilateral case, check for Nelliton's lines. It's just a 10-second procedure. Just check for the Nelliton's line. Is the trochanter above, below, or at the level? You know the answer. No coxa virus, sir. I've checked. How do you know? I've done Nelliton's line. There may be excessive femoral anteversion, that you have to check.
What do you do now?
Order for a radiographic image.
Yeah, you have to take a radiograph. Yes.
What radiography?
What radiograph? What radiograph?
Complete.
You're filling the form and you're writing down X-ray.
Orthoscanogram of scanogram.
Yes. It's a small district hospital. They don't have facilities for a scanogram.
I'll take X-ray of bilateral hip with pelvis with bilateral hip and also.
Why? You have problem is in the knee. Why do you need the hip?
Hip.
Clinically, you have seen Nelliton's line. It is normal. Excessive femoral anteversion is not there. So,
I'll take excess of knees.
What?
What view would you take? Standing X-ray. Any other instruction?
What about the patella, your foot?
See, he's an internal examiner. He's wanting you to pass. He's giving you hints.
Foot in.
Patella facing forward.
Patella facing.
Standing X-ray of both the knees, patella facing forward. Unless you do that, you will get a falsely reduced thigh leg angle. Okay? So instruction has to be very clear. Ideal, if you're putting a knife, you should do an orthoscanogram. Hip, knee, ankle, you need to see is there any compensation, is there any femoral, tibial compensation. So does she have a tibial torsion? Have you checked? She has an intowing. Have you checked for tibial torsion?
Thigh, foot.
You haven't checked? Can you do it now?
I'll ask the patient to sleep in prone position, sir.
This is scary. Trolley, actually. I would be scared of lying down.
We'll ask the patient to.
No, just do it. No talking. When you are doing a thigh foot angle, first of all you have to get the thighs together and then hold the feet in neutral position and relax. Hold the foot in neutral position and then see the thigh foot angle is normal. It is normal. So in chronic renal rickets, which has been from childhood, they have torsional deformities associated with variable. So you will have a problem and you must assess for the foot thigh angle in all these patients with present with valgum away. Thank you.
This is the radiograph of bilateral knee standing position with knee joint being exposed. Here we can see. The deformity can be seen in the right knee more than that of the left knee, with medial joint space being reduced. This is the outlook.
It's a distorted picture. Photoshop distorted picture. Portions are totally reduced in length. So we assume if is normal, assume E is normal, what will you do?
ankle is normal, what will you do?
Correction of the deformity by either open or closed osteotomies can be.
Straight away you go and operate. She may be having high alkaline phosphatase.
Routine blood investigations has to be done to calcium, phosphorus, and alkaline phosphatase levels has to be seen to assess.
Baseline SAP is a must. Before you put your knife, baseline SAP is a must. Assuming everything is normal, parents are keen for correction. What correction will you do?
To correct the valgus deformity, either open or closed osteotomies can be.
What will you do? You don't do this in the exam. I can do this. No, what will you're the surgeon? You have to decide. You have to counseling the parents. Will you do decide closed or open?
Bilateral case, I like to do.
Okay, you have planned the surgery now. Okay. So you think you said how much was the valgus?
30.
30. Huh? 30 degrees.
That's not the thigh leg angle. Please don't do the
No,
correction
no.
by Q angle. You'll end up in a disastrous situation.
So that is what you need to calculate first. You think
Calculate the lateral
distant
femoral angle and the medial and the lateral
proximal femoral angle.
You base your calculation and CORA and all that correction angles based on that. LDFA. Because it's a femoral problem, it is LDFA that is important.
Suppose if it is now 30 degrees up, how much will it
10 degree of correction is about 1 centimeter of.
You've not told me whether you want to go medially or laterally. So your registrar is asking me, you're the consultant registrar, medial or lateral incision. Median would mean a closed wedge osteotomy, lateral would mean an open wedge. What would you prefer?
Lateral wedge osteotomy.
Lateral. Why?
Medially, femoral artery.
Medial femoral. Lateral something more dangerous is there. Lateral something more dangerous is there.
Iliotibial tract.
You call the lateral popliteal offense. She's going to sue you. Post-operative lateral popliteal valve. Earlier it was only genovalgus, now it's put droppers.
Go
Where
back.
is surgeon mind? The artery is way behind. Why you are scared about the artery? Artery doesn't come in the way at all. Okay, if at all you do a close wedge osteotomy, how much you do? You are asking the question 30 centimeters, 30 is the angle. How much you do and how much you will take off the wedge? How much you want to correct first of all? Normal, what is the normal thing? You have to give some value, isn't it?
Subtract the normal value. Normal value separate.
20
Correction.
That's all.
So how much you have to take? How much you have to take the base?
2 centimeters.
Calculation should be like
1
degree.
1 centimeter is about 10 degrees.
Yeah, 1 centimeter. 1 degree is good, 1 minute. Okay.
Coventry's calculation for tibial osteotomy. Only valid for a tibial width. So, because I don't have a goniometer, I always show this. So, if I have 30-degree angle, pull this. The angle of this.
Goniometer is there.
I'll show it on this. This is a 45-degree angle. So, supposing the leg is this wide.
Small.
How much would be the wedge that I take out to correct this? This is the wedge. the leg is this wide, how much is the weight that I have to take on the same angle? Depends on the width of the bone that you cut. Coventry described 1 millimeter per degree tibial, high tibial obstruct. He calculated the average tibial proximal tibial width and found that it is 1 millimeter per degree. But that's not valid for all of us. Okay, this is the reason you can find out yourself. So you will correct appropriate. So the answer in the exam would be, I would measure, use the orthoscanogram, calculate the angles, measure the precise angle, appropriate wedge correction to the exercise based on the angle on the cutout, and then appropriate wedge will be removed and fixed with the plate or pivot or whatever your center is doing. Okay?
Thank you.
High-step-based gait. Sir, I know foot drop. Yes. So it's a post-traumatic, post-IM injection, foot drop.
So diagnosis, occurred.
An injury to the side. Yes.
Diagnosis, post-injection, what?
Neuropraxia most likely.
Just of what? Femoral nerve, obturator nerve, sciatic nerve, lateral popliteal nerve, lumbar plexus.
Peroneal component of the sciatic nerve.
Only peroneal component.
With tibial nerve component.
No. This is a peroneal, that is sciatic nerve then. Is it tibial nerve or lateral popliteal or sciatic?
Knee flexion is also involved.
I didn't ask you. We'll come to that, don't worry. We will get you on that. But tell us what is your diagnosis first?
Post-injection, peroneal component.
Lateral popliteal nerve. Okay, justify your diagnosis. I'll keep quiet for some time and justify your diagnosis.
On examination, the gait is of a high steppage gait. High-stepping gait. And on no inspectory and palpatory findings as such. Inspectory, there is a scar that is healed by secondary intention on the dorsal aspect of his foot, which is correlated with the history that the mother provides. Wherein
Don't bring in history in examination.
Your findings.
Now asking you to justify based on physical findings.
Gait is high stepping.
Yes, sir.
Gait is high stepping.
Yeah, one is under.
Ankle movement is absent, both plantar, dorsiflexion, version and
Plantar
version.
and dorsiflexion are absent.
Yes, sir.
That means what? It indicates something different.
It involves the tibial component too.
No, you contradict. You had examined this child?
Yes.
Then?
Both flail foot. Flail foot.
That is why we asked him. Post-traumatic sciatic nerve palsy,
Flail foot.
both involving both the components. He could have completed this. I don't know whether it is predominant this or that. That is why I just told you. Okay. So what is the reason? Why do you think it is happening?
So most likely due to direct trauma by the injection.
Direct trauma is small thing, no?
Yes, sir.
The They might have used about 21 PS needle or 22 or 23.
Any telltale signs there in the gluteal region?
No, sir. No findings on
These are the things you should come up with.
What was the nature of the injection given?
Given. There is a chemical, there is a chemical element which is involved. They are all important.
Why the injection was given?
He
So
had
you
a
can-
acute fever
Huh?
and weakness for which he was given an IV injection 2 months back, following which he developed instantly. There is no progression.
Justify your diagnosis. Your diagnosis. You revise it to shattered.
Yes.
Accept.
Yes.
Now justify it shattered now that's.
Ankle movements are completely absent.
Steady wake up movements. Any physical examination, look, feel, move, measure.
Yes, sir. Inspection.
Don't break that protocol.
Inspectory only the scar present on the dorsal aspect and no other inspectory findings. And palpation. Attitude, sir, attitude is neutral, hip in neutral on standing, hip in neutral, knee in neutral, ankle on the down to the ground.
Wasting?
No apparent wasting, but thigh, calf muscle about centimeter wasting on the affected side.
You're telling no wasting and you're telling 1 centimeter.
On inspection, no apparent wasting.
On inspection, it's very obvious. Look at the right foot and look at the left foot. All the toes of the right foot, look at that. They're all extended at the MP joint. All the toes on the left foot, they're neutral, they're not extended. They're flat. Can you see that?
Yes, sir.
There's a clear difference between the two sides. Okay? You have trophic ulcers on the dorsum with skin changes on the dorsum of the foot. That's also there. Are there any trophic ulcers on the plantar? Yes. There is something there. On the second toe, there is something there. That tells me, because if it is the lateral popliteal alone, the area of sensor loss only will be here. There's no reason such a large area. Even this is unusual. Okay. So what else? They're wasting. No. Look at the triceps between the two sides. Is it wasted? Visibly wasted. The calf is visibly wasted. Look at the thigh. It's visibly wasted. So at that level,
No apparent tendencies.
did you check for the hamstring? Is it working?
Hamstrings work.
Working?
Yes, sir.
Demonstrate.
Manti Manchi. Manti Manchi. Is Manti Manchi? Yes. So, but it's not comparable. It's reduced in power. It's reduced in power.
Reduced. You said it's good.
No, sir.
Hamstrings are good.
Moving, but power
Moving,
is
but
reduced. Power
what
is
is the but
reduced.
for?
Manchi, Gatiga Manchi.
Either. That's a good strong. Here,
It's reduced.
here. Essentially, medial hamstring is working. Lateral hamstring is very, very weak. There's hardly any contraction. If you take out the wasting is predominant on the lateral hamstring.
Yes.
The biceps is wasted. You can see the hollowing out there. And it's not contracting. So hamstring will be wasted only if sciatic nerve is there. It won't go anywhere in the lateral popliteal. It will not go in tibial. Tibia is here. Tibial nerve is here. The injection was not here. Injection was there. Assuming it is injection. Have you checked for the triceps already? Power. Can you come around and check it and demonstrate?
That's right.
Triceps power.
This side. You stand this side.
Stand this side.
Everyone can see.
All of them can see only your pant and shirt.
Yes.
Triceps surae.
Gastrosoleus. Gastrosoleus.
Caligimani?
Straight, straight. ಪಾದ ಹಿಂದೆ ಮಾಡಿ ಕೆಳಗೆ ಮಾಡಿ ಈ ಕಾಲು ಸ್ಟ್ರೇಟ್ ಹೋಗಿ ಸ್ಟ್ರೇಟ್ ಅಲ್ಲ ಹಿಂಗೆ ಹೊಟ್ಟೆ ಮೇಲೆ ಮಾಡಿ ಕೆಳಗೆ ಮಾಡಿ.
You don't have much time. Triceps, so what you were doing was asking the child to do this. What are the plantar flexors of the ankle? Name them. 1, 2, 3, 4.
Gastrosoleus.
Gastrosoleus.
Plantaris.
Plantaris. Hardly a muscle.
Tibialis.
Good in tennis
Tibialis
players. Yes.
posterior.
Tibialis posterior. Peroneus longus. Flexor longus. Flexalis is longer. They're all plantar flexors. So when you ask him to do this, you're checking all the plantar flexors together. It has no meaning. I asked you to check only the gastrosoleus. And the only way to check that is this. Tell him to do this. I don't know his language, that's what I explained to him. Pull his heel towards himself. Then I can't tell him. He'll have to tell you. I don't know how to tell him. I don't know the language.
Do.
Good, good, good. Very good. He can do that well. Let's see whether it does that. See that? So watch where my hand is. My hand is on the triceps, so I'm feeling for it. Do that? Triceps is paralyzed. Biceps, the hamstring is paralyzed. Middle hamstring is weak. And can he wiggle his toes? Can he? Long toe flexors are neither FHL nor FDL are working. Both are gone. EHL, EDL is not there. So it's clearly a shedding. No doubt. You end up by saying it's lateral protruding offensive.
Oh. Now you want to change your diagnosis completely?
Yes, sir.
Check that.
Post-intramuscular injection, sciatic nerve palsy.
Complete sciatic nerve palsy. There is no partial there. The injection palsy has the worst prognosis. So you important to find out what injection. So this degree of paralysis will happen only in irritant injections. Some of it may be antibiotics.
It's a chemical induced paralysis.
So there are three components of damage to a nerve from injection. One, the sharp needle, which is needle. Two, the physical injection into the nerve, which expands the perineurium and causes chiropraxia. Three, the chemical neuritis that comes from the irritant substance that is injected directly. So you had an instant paralysis, there is a total sciatic nerve palsy, right from the hamstring down all the way. That's a terrible injury. Is the prognosis good or bad?
Yeah.
Bad. They do not recover easily. And they have a sensory deficit. They keep having trophic ulcers. He has a flail ankle. He has a flail foot. And push-off is gone. Gastric nervous is not there. Total wasted. Prognosis is very good. When was the injection?
2 months ago.
2 months ago. It's worthwhile exploring. Maybe doing neurolysis. Checking. I'll find out the level. Maybe I'll give the nerve protection. I'll do the evaluation. I'll look at the EMG. Find out the details of the injection. Let us go.
It's an ankle foot orthosis. Ankle foot orthosis. Knee ankle.
Ankle problems. Which are the muscles not acting there? Sir has already.
Knee ankle foot orthosis. Knee ankle foot orthosis.
Yeah. Quadriceps is working. Fellow is working nicely.
Just ankle foot orthosis.
You are changing your color now. Hamstrings is not important as for the walking movement. Okay.
He has a flail ankle. Sir, I will give him an ankle foot. He will not work with the foot drops player alone. Okay. He has a flail ankle, a flail foot, and an anesthetic foot. I would give
like to thank all the faculty who took out time from their work, and I think we all can agree that we've learned a lot today. Though it was a really long session, we have managed to learn a lot. So now, whoever has registered for the quiz has to stay back, and anyone who wants to register can still register. It's a team of 2, 60 questions. You will have 40 minutes to do it. Okay. So whoever is registered, just stay back. 60 questions, 40 minutes to do it. It's basically an MCQ quiz. Whoever is the first and second, first and second position based on the marks are getting the first and runners-up position. There is a cash prize for it. Okay, just a 40-minute session. Anyway, it's what, 7:30 now. By 8 o'clock, 8:10 we'll be done. So we'll start distributing the papers now, and we can start the quiz. So there's probably another 5 minutes we can start. Have all of you got the a paper to mark the answers in? There's a question paper and there's a paper to mark the answers in. If you've not got it, please raise your hand, we'll give it to you.